A very good morning to all the ones present here. Without further ado, we are going to start with our lectures for the day. Our first speaker of the day, with whom we are going to start our keynote lecture session, is Dr. Vinita Nikhil ma'am. A brief intro before we invite ma'am to the stage. Dr. Vinita Nikhil ma'am is the Director PG Studies in Subharti Dental College. She is the Professor and Head of the Department of Conservative Dentistry and Endodontics. She is the editor of Indian Endodontic Society in the newsletter section, which is in IS Times. Along with this, she is editor-in-chief of Indian Journal of Conservative Dentistry and Endodontics. Along with all this, ma'am is an avid speaker and invited guest speaker for many national and international conferences across the world. She has had a good amount of publications under her name and is a national and international awardee in her field and a guide for everyone associated with her. It is indeed a pleasure for all of us to have you here with us, ma'am. Welcome, ma'am. The topic that ma'am is going to cover today is contemporary indexing in traumatic injuries. Please give a round of applause for ma'am.
Thank you so much. Jai Hind and a very good morning. Greetings from Subharti University. As she told, this is my workplace, and the unit, Subharti Dental College and Hospital. The disclosure is the content I have kept is totally for the undergraduate section, and this is extremely important to know this because we are facing problems whenever we are trying to find out the prevalence of traumatic injuries, that is the dental traumatic injuries in India. There is so much lacunae. So my dear students, dental trauma or trauma can happen to anybody at any time. And whenever this trauma, it incorporates teeth and associated structures, we call it dental traumatic injuries. Now, because of this injury, not only the individual, also their near family people, they suffer because of emotional trauma, functional trauma the individual is suffering with. But the problem is that when the worldwide prevalence was studied, it was found that this is the 5th most prevalent problem or injury, even though it is the most neglected. Now, what is the issue? Why it is so much neglected? The prevalence is even higher than the migraine. We all know how many people suffer with migraine, and the prevalence of dental traumatic injuries is more than that. So what it was found, that because of the poor reporting of the dental traumatic injuries and less recognition by the public health organization, there is so much ignorance about this unit. So what is our role? The role is that why this poor reporting is there. The reason being is that in our dental curriculum, that is particularly in undergraduate, this has been taught in very minimal time. On the contrary, postgraduate students definitely go in more details, but the undergraduate section, the coverage is highly minimal. And when we see that in the medical side, they hardly know anything about it. And from where the reporting will come? It will definitely come from the hospitals, either from the dental or from medical. And for proper reporting of any disease or any injury, the prerequisite is that you should know how to identify it or how to classify it. Now, what is this classification? According to the Cambridge Dictionary, classification is basically categorizing something or someone into subgroups depending upon various characteristics. And for a good classification, few things should be in common. It should be easy to understand, it should be easy to communicate, as well as it should be universal in nature. Universal means that if I am classifying dental traumatic injuries, it should be followed for both primary and permanent dentition. There should be no separate classification for them. So, till date, more than 50 classifications are available in the literature based on various characteristics. But when it was surveyed, we came to know that this Ellis and Davy classification and Anderson classification are the most followed one. So let's see a bit of these two classifications. It was in 1962 when Ellis came out with this classification, depending upon the trauma to the various anatomical structures. But it was in 1970 when David modified it by adding 2 more categories. Ellis gave only 6 categories. On the contrary, David added 2 more. And easy to understand, and it defines a wide range of lesions. But the issue with this classification is they have added subjective elements. Subjective element means they say that simple fracture, complex fracture, or extensive fracture, which may vary from one individual to other individual. Later on, in 1970, J.O. Anderson, he came out with another classification, and he was the fellow, he's the father of dental traumatology. He is the fellow who keep on updating his own classification right from 1970, then 72, then 74, then 81, 84, and ultimately in 1994. And he categorized and he updated it into 19 categories so that we can incorporate various lesions. Now, this classification basically divided the disease or the event or the injury into 4 main categories. That is the injury to the hard tissues and pulp, injury to the periodontal tissues, injury to supporting bone, and injury to the gingiva or oral mucosa. And then each of these categories he further subdivided depending upon how much extent of the lesion was, like whether only enamel or in addition to enamel, dentine was also fractured or injured, or whether the pulp was exposed or not, like that. But the thing is that whenever we classify something, it should be universal in application and it should be used by everybody. So this was a more of a clinical-based classification, and when it comes to the epidemiology or the prevalence, this was not fitting much. In addition to it, this is a modern era where we just practice digital dentistry and digital communication, so that to communicate this classification from one person to other, it was very, very difficult because there was no coding system. So now it was the role of WHO, World Health Organization, who took many of the lesions from the Anderson's classification and gave coding to these. But the issue with these codings that they also updated it, and now presently we are having ICD-11 classification. It's highly complex classification where they have incorporated majority of the Anderson classification with codes. But if you see the codes, these are so difficult to remember. 873.68 or 69, then 802.41. So the ease of understanding and communication was missing. Anderson further added few more. Anderson actually told the WHO to modify it, but unfortunately he died and he left us in 2020, and ICD tried to change its present classification in the March 2022. So the work he has done, it's been immense, and that's why we call him father of traumatology. Now, coming upon the new classification, which I want to emphasize today, and I want you to understand it, because a simple classification, and if you understand, and if we all understand, we can definitely report this incidence very nicely. Now, why this is important, this new classification has actually added 2 more entities to the previous classification. Number one is they have also added the maturity of the root apex, because they said that whenever we classify a dental trauma, the classification should be such that it should give all the information related to the trauma, as well as it should help the clinician that how it should be treated. So they said that whether that tooth whichever tooth is injured, whether it's mature, the apex is mature or immature, has also to be mentioned. Now, to categorize that what is mature apex and what is immature apex, they said if the clinician feels that at the time of injury, he or she can complete the root canal treatment and obturate the root canal, then it should be categorized as mature apex. On the contrary, if he or she feels that there is a need of a barrier, which we call apexification or barrier formation, then it should be categorized as immature apex. And the second another category which they try to add it is that whether there is an event of fracture of alveolar process or not. So let's see what is this classification and how it emerged. Now, it is Professor Dr. A.S. Eden, who is a periodontist in Turkey, and along with her final year BDS student, that is Mehmet Basil, they collectively came up with this classification, and this is known as Eden-Basil classification. Now, this classification basically has, first of all, you have to mention about which tooth is injured. And the tooth numbering system they followed is FDI. And the beauty of this is because they are following FDI system, that's why if you take the number of the tooth, it is applicable both for permanent as well as for primary dentition. Followed by 5 major things which have to be identified. That is the 5-digit. The first digit will tell you about injuries of the crown. The second digit will tell you about the injuries to the root. The third digit will tell you if there is any type of luxation injury, that is the injury to the periodontium. The fourth is the maturity of the apex, and the fifth information is whether alveolar process is being fractured or not. So we know that if there is an injury to the crown area, it can have a different severity. And that's why the numerical values have been given. If there is no injury, you just write 0. If there is only injury to the enamel, or enamel is only fractured, then you write 1. If it is enamel and dentine, both are fractured, write 2. If it also incorporates pulp, write 3, what we call complicated fracture. And if there is a fracture of enamel, dentine and cementum without incorporation of pulp, write 4. And if the pulp is involved, then we write 5. So these are the 5 types of injuries which can occur in a crown, and they have given this new numbering system. Similarly, for the root, depending upon which third of the root is being fractured or cracked, they have given a number. Now the number, the hierarchy, like 1 to 3, it also tells you the difficulty in management. If there is a fracture in the apical third, then we write 1. If it is the middle third, we write 2. If it's cervical third, we write 3. Now, it's not that always we'll encounter with a horizontal fracture. There are also oblique fracture which run from one third to other third. So in such case, if there is an oblique fracture, just see where the cervical, the line is ending. It is ending, for example, in the picture you can see in the last, if it's ending in cervical third, then you have to grade it 3, not 2 or 1 from where it is initiating. The third digit tells you about the luxation injury. We all know, and I'm sure that all the students must be knowing, what are different types of luxation injuries. So take the first digit in capital, and that is what you have to write. We know the luxation injuries are concussion, subluxation, extrusion, lateral luxation, intrusion, and avulsion. So if there is no luxation, no injury to the periodontium, write N. And if there is a concussion, write C. Subluxation, write S. Lateral luxation, write L. Extrusive luxation, write E. Intrusive luxation, write I. And if the tooth has been avulsed, write A. As I told you, the fourth digit, it tells you about the status of the root end. So whether it's mature, immature, or has been resorbed. Because in primary dentition, we also see that there is resorption of the root. So you have to write the first letter in small case. For example, if it's immature, write small I. For mature root, write small m. And in resorption, small r. And the last fifth digit will only show you, will tell you, they give you the information related to whether the alveolar process has been fractured or not. If it's fracture, write plus. If there is no fracture, write minus. Mind it, you have to mention even absence of disease, absence of event, absence of injury, so that the complete information you write down, in future you can also use it, and if you're communicating to the fellow dentist, he or she also can use. So the beauty again of this classification or indexing system is that in your format, regular treatment format or the case sheet, you can write, you can make diagrams in this section, and so that you never forget any of the thing and you can write all the details. Similarly, because these are the digits you can enter, if you are following the digital format in entering the in the patient information, even in drop-down case, you can get all these information and you can place the tick. So that's why manually as well as digitally the recording can take place. Now this is an example which it's been followed in the School of Turkey Dental, where the Mehmet and Dr. Eden are working. So I told you upgrading is must, and in 2021, just a year after, it was recognized that all the information which we need can be entered, but what about the soft tissue which Anderson has told? So there was a modification which was done later on for the system, and this is known as Modified Eden-Basel Trauma Index. Now they added the soft tissue injury also to it. Basically, there are 4 types of soft tissue injuries. They are abrasion. Abrasion means simply rubbed off or scratch. If there is a scratch on the skin or gingiva or we call it abraded. Second is laceration. Now what is laceration? Laceration if there is any tearing of the tissue. Either it may be a shallow or deep, but there occurs a tearing, then we call it laceration. The third is contusion. The contusion is whenever there is a subcutaneous hemorrhage without laceration. I repeat, without laceration, then only we say it contusion. And the fourth is avulsion, means there is a loss of soft tissue structure. It is not even there. So these are the 4 categories in which you have to mention. This is, you can see, abrasion, laceration, and contusion. So in this field, there are 9 codes being given. The 0 code stands for no soft tissue injury. The first 4 digits, 1 to 4, is for the extraoral lesions, and the 5 to 9 or 5 to 9 is for intraoral. And the sequence will remain same. That is that abrasion, laceration, contusion, and avulsion. For example, if I write 1, that means either the skin or the lip is abraded. If I write 2, that means skin or lip are lacerated. If I write 6, that means gingiva is lacerated. If I write 7, that means the gingiva is contused. and if I write 8, that means there are some portion of gingiva has been lost. So let's see what are the rules when we follow. After understanding what are the various digits, let's see what are the rules follow. First of all, you have to write whichever tooth is being injured, you have to write its numbering system in parenthesis. Then for the first digit, that is the information about the fracture of the or the injury to the crown, you have to write. If there is suppose 2, I am writing, that means enamel and dentine both are fractured. The second digit, which gives you the information related to the root injury, and here the 1 will stand for root, the fracture line is in the apical third. Then there is the type of luxation injury. So as it's been mentioned E, that means extrusive luxation injury is there. Then about the maturity index of the root. So in case of immature root, you can see the small case I has been used, and the presence of alveolar fracture, you have to write plus, and in absence definitely minus. Then close it, and you have to mention the soft tissue injury as a superscript. Now, like 2, as you know, either gingiva or the skin are lacerated, then we'll write 2. Now, it's not mandatory that you'll have only one type of soft tissue injury. So if there are more, you have to separate it with a comma, and in hierarchy, you have to mention the different types of injury. Now, it's not only the one tooth which is being injured. So you have to give information in detail about all the teeth or which have been injured. So for example, if 2 teeth are injured, then you give the same information by separating with comma. The soft tissue injury will remain same because that is the injury to the individual. So how this system should be used? First of all, it's very easy to use, but training is essential so that you don't miss anything. Secondly, in case you are having any doubt about any coding, that whether it's severe or less severe, always code the severe one. If you are in doubt there is an enamel or enamel and dentine both fracture, then always write in the enamel and dentine both fracture. Okay? And then if there are more number of it, just separate them, but give all the information. If there is no injury to these entities, please mention either 0 or n according to the digit. Let's do some exercise. I'll show you 2 or 3 cases where how you can use it. Now this is a clinical case, as you can see, where a pediatric patient, that is 14-month-old male patient, and he reported with injured primary right lateral incisor, which has moved below the gingiva. This is the way we write basically. Now when you examine, it revealed that there is no soft tissue injury related to skin or lip or gingiva. And then when the radiograph was taken, it showed that there is an erupting canine and an intruded primary lateral incisor with an open apex. So if you are not trained with the system, you'll use Anders's system and you'll simply write 5-2 intrusive luxation. On the contrary, if you know the system, you'll give all the information, that is 5-2 in parenthesis with no injury to the crown, no injury to the root, there is intrusive luxation, and there's immature apex in the absence of alveolar fracture. But when the modified Eden-based dental trauma indexing will be followed, you'll also give the information related to that there is no soft tissue injury. Another case report. There's a laceration in a 12-year-old boy. There was laceration of the lower lip. There was gingival contusion and abrasion. There was extrusion luxation injury in 1-2, and 1-1 was found mobile with uncomplicated crown fracture. That means the pulp was not involved. And 2-1 showed enamel fracture. When the IOPA was taken, it revealed that the apical root fracture in 1-1 was present. So, if you follow the Anderson classification, you'll write this information like 1-2 is extrusive luxation, 1-1 is uncomplicated crown fracture and apical root fracture, and 2-1 has enamel fracture. On the contrary, if you are trained with this indexing, you will, in Eden Basel Dental Trauma Index, you'll give the information like 1-2 with no crown or root injury, which is extrusive injuries present with mature apex and absence of any alveolar fracture. 1-1 with enamel and dentine fracture with apical root fracture with no luxation injury, mature apex and absence of alveolar fracture, and 2-1 with only enamel fracture with no root injury and no luxation injury with mature apex and alveolar fracture, no alveolar fracture. So, and in addition to it, in modified version, this is that you will also give information that there was skin or lip laceration with gingival abrasion and contusion. So this gives the entire information about the patient. Even in your absence, if somebody wants to treat, he know how to treat it. Now this is the case which reported to our department a week back, and I trained one of my intern with this classification, and he did this one. It took only 10 minutes till the time he get all the IOPA, he did his RVG and found out to classify this disease, and then we planned the treatment accordingly. Then who are the persons who can use the system? For clinical recording, definitely the dentist and the medical practitioner. But if you want to do the epidemiological study, then the trained person should be dentists, medical practitioners, as well as healthcare workers. Then only we can use the system and the prevalence of this disease can be easily recorded. The plus point of this system is that it is useful for both, for clinical recordings as well as for prevalence studies. You can report multiple injuries at a time. Then this also helps you to suggest a treatment, how you should proceed, because it gives you the information about the maturity of the apex as well as alveolar fracture. As it can be digitized, so it is computer friendly, and this information can easily be sent and communicated not only in your inter-department or inter-college, but also in multiple countries, and then it can be easily evaluated statistically. It can give you the possibility of recording 1,008 different clinical scenarios. To conclude, I would like to say that although there are a wide range of existing classification systems, and Anderson system is most widely accepted and been used by all of us, but it has some underestimation as a drawback in its. And that's why this newer classification system, which came out in 2020 and then modified in 2021, that is Eden Basel Trauma Index, it is emerging strong, and it is such a simplified registration system that we all can easily understand and can get trained to it. And then using this unique coding system, it can be also digitally accepted in the modern era. So let's follow all of this, let's understand this, so that the prevalence of this disease can be reported, and the ignorance which WHO and the international classification of disease is what they are ignoring, this one can be prevented. I thank the organizing committee of this event for giving me the opportunity to talk to you people. Thank you, and Jai Hind. In case anybody wants, I can.
Thank you, ma'am, for such an enlightening lecture. If you want to ask any questions or have a conversation with ma'am, ma'am would like to acknowledge you all. So, any questions or queries for now? Thank you, ma'am.
Ma'am, can you elaborate the clinical scenario of the contusion and the gingival abrasion, ma'am? Yeah, yes, ma'am. Abrasion, gingival abrasion.
No, these are, it's not the clinical scenario. These gives you the information because whenever we are doing follow-ups of various things, and it's a multidisciplinary approach, whenever we treat such trauma cases with the medical fraternity as well as the dental fraternity. So in case of aversion, contusion, because you have to simply supervise it, and the follow-up you have to record about these things. So in aversion cases, definitely a plastic surgeon will be required. On the contrary, in intraorally, the healing is so it's superior because of the good blood supply. We have to simply follow up how the healing is proceeding. Yeah.
Ma'am, is there any present systematic reviews regarding this? Yeah, yes, ma'am.
It's such a new system, and which is being formulated because of its ease and digital friendly. And then they are communicating that we should start following it. And when the studies will be done, definitely. One of the study which was done in Turkey last year, which I know to the best of my knowledge, they were simply reporting it, and they find it out that whether the students or the fraternity, it was helping them to understand about this event and the treatment, and they found a positive report regarding it, that if you categorize it, the communication was good, and later on on follow-up, you can easily register what changes are being coming.
And one more query, ma'am, like is there any software available to install?
It is no software. You can easily make it because, as I told you, there are 5-digit system. A table can be done, and for each category, if you have to divide it into subcategory, a drop-down box can be created where you have to simply click yes and put the digits. So you don't need any software. You can create your own software.
Okay.
So,
Thank you, ma'am.
Thank you, sir and ma'am. The next speaker for the day is Dr. Pankaj Dhawan, sir. He is the head of Department of Prosthodontics and Implants and is also associated with Manav Rachna Dental College and Research Center and Manav Rachna Center for Dental Excellence. And the topic on which sir is going to deliver the lecture is implant dentistry, chambers concept and bone augmentation. It's a pleasure to have you here with us today, sir. We welcome you, sir.
Thank you, everyone. Good morning, everyone. I would be speaking on something which is little difficult to have in your armamentarium, but very easy to learn. Once you learn this, you need to excel in it with lots and lots of patience. You know, it's very easy to start with implants, but very difficult to maintain the implant practice. And to do implants in your clinical practice, it is very important to learn how to do implants in a correct way so that you are able to have a very good implant practice, and when recalls are very important in this. Today, I'm going to speak about a chamber concept. Now, this chamber concept was given by Dr. Digedi, and in my opinion, one of the toughest area to do successful implants are maxillary anterior teeth. And in maxillary anterior teeth, whenever the tooth is extracted or you have a trauma, you actually lose the labial bone. And once you lose the labial or facial bone, you get very poor aesthetic results with implants. So overcome this, a lot of investigator gave this concept. So let us dive into this and see how we can do. This is my college, Manavachna Dental College. And sorry. And I'm also associated with Manavachna Center for Dental Excellence, which is a continuing dental education arm of the college, where I'm looking after the education of implants, lasers, and prosthetic work. So, most of the patients will access you with difficult clinical situation. You know, there is a saying which says that rarely you'll get everything right in the first place. If the patient has a very good bone, he will not have money for implants. If he has a lot of money for implants, economically he is well off, he will come with you with a very challenging clinical situation. There will be lack of bone, there will be accompanied disease, there can be medically compromised patients. So the practice of implantology actually is quite challenging. But if you know the concepts, if you know your science, if you know your subject and you have done clinically well, then you can always overcome this. So my whole presentation today would be on learning how to do right in an anterior region. My whole concept of chamber is denoted on doing the clinical cases in the maxillary anterior region. One another thing which I have come across is, which we always overlook, is the gingival biotype, the thickness of the gingiva in the anterior region, whether it is pre or post extraction. You must understand, I know if you are periodontist here, you will know that a thick gingival will always give a very good results post implant placement. So always remember to check the type of gingiva or the tissue type before extraction, because it's going to matter. You know, if the gingiva is very thin biotype, you know, it will have problem healing, it will recede very fast, and you will also encounter loss of structure underlying it, because remember, skin or tissue, whether it is in the oral cavity or outside, will never be present if it is not supported by an ample amount of bone underneath it. So I am very particular to see what kind of gingiva a patient has. Now, we also undertake a lot of courses for ITI, and our center is an ITI course accredited center. Dr. Ashish Kakkar, he is with us as a director. So we undertake a lot of ITI courses, and I am personally also a member of ITI. So I follow classifications of international team of implantology, ITI team. So my presentation to you here is also based on the classification which is given by the ITI in. So very simple. I will try to bring it very simple for all the youngsters. You must understand that there is a timing for implant placement. At what time you are placing the implant also, after all, give you the prognosis for the same. So the very early implant placement protocol which was given was, number 1, late implant placement, early implant placement, immediate implant placement. Now, one of the earlier classification, you can leave the tissue to heal. But remember, once you take the tooth out and allow the tissue to heal, you are bound to get some kind of bone resorption there. There will be bone remodeling, and the actual height of the bone will actually come down by as much as 20 to 25%. So if you go for a late treatment protocol, you will have a longer crown. Your implant height may be short, but your crown lines have to be compensated with the loss of the structure. Then you can have an early placement, or you can have an immediate placement. Nowadays, because immediate implant placements are having a good protocol and having good success rate, most of the implantologists are going for immediate implant placement in the fresh socket for the only reason to maintain the bone height. The cervical bone area, they want to augment and maintain so that there is minimal resorption of the bone around that area. And personally speaking, if patient is not medically compromised, I like to go for immediate implant placement with bone augmentation. Then there is a classification of loading of implants. The early classification was placement of implants. The second classification I'm showing you here is the loading of implants. In the loading of implants, you can load it conventionally, means after 60 days, once the osseointegration has taken place, there is a healing of 2 months, and then you can load it, or you can load it early. But again, if you are loading it early, you have to keep it out of occlusion, because concentration of forces in the cervical or actually in the platform area. The platform area is an area where the abutment and the cervical part of the implant are meeting. If the concentration of forces take place near the abutment and the implant connection, then you are bound to have bone resorption. So whole idea of early loading should be based on the premise that you are not concentrating the forces in the implant abutment connection area. Then, very recently, ITI came up with a consensus statement. Now, this consensus statement was done after a conference of all the implantologists in Europe, and they came up with a proposed classification wherein they gave the timing of the implant placement and the loading combination, which allows for comprehensive treatment selection. So this is, which is more comprehensive and more apt in nowadays. You can see that they divided the classification into type 1 A, B, C and type 2 A, B, C. Now in the type 1A, they say that immediate implant placement plus immediate restoration with loading can be done, and the survival rate of these cases were seen as 98%, which is pretty good, in fact. Over here, I would like to give an insight to all of you. Here is that the immediate placement and immediate loading has also been helped by better surface characteristics of the implants. You know, there is a good amount of research on the surface characteristic and the surface morphology of the implant surface, which has helped for better retention of the implant within the bone. There are now treated implants. You know, you have a different implant material now. You have different, in fact, you know, I was reading recently, you have now stem cells impregnated implant surfaces, which help us to get better bone proteins over the implant surface, which gives faster osseointegration. So when I'm talking about type 1A, it should be remembered that you should go for a grade 5. I want you to know this. You should go for a grade 5 surface characteristic implant for your immediate placement and loading. Then there is a type 1B, wherein you can go for immediate placement, but you delay your loading for some weeks. And then you load it after some time. Again, the survival rate is quite high, which is 98%. And in 1C, you have immediate placement, but loading is delayed for 60 to 90 days, and you can go for a conventional loading. Now, I want all of you to appreciate the survival rate from 1A, B, C. In the 1A, it is 98%, 1B, it is 98%, but it drops to 96% when you delay the loading. So as I go in my lecture, you will understand why there is a drop in loading protocol and survival of the implant. So you will see when I go more into my context, and I'll see you that there is a 2% dip in conventional loading. Then there is a type 2A wherein you do an early placement and immediate restoration presents clinical insufficient documentation. Means there is not particularly good clinical case to document. 2, 3, wherein early placement early present, whereas there is an insufficient documentation of the cases. These actually ITI consensus statements are based on lots and lots of meta-analysis of data. You know, they collect lots and lot of clinical data all over the world, and then they come to the consensus statement. So they actually classified 2A and B and C because they said there was lack of clinical documentation to present that this kind of thing is in. But again, the survival rate is 91 to 100% in these cases. And then you can go for late placement and immediate loading. Survival rate is very high. It is sort of a conventional implantology. Then there is a 4B wherein you can place an early load. Again, the survival rate is 98%. And in 4C, where you have an immediate placement and conventional loading and scientifically proven protocol, the survival rate is very high. So let's come to a case wherein we'll now learn how to place an implant in a anterior region of immediate extraction or a sort of early implant placement. That means 1A, B, C or 2A, B, C. So one thing which is advisable is to do a flapless extraction. Why flapless extraction? Because they want to preserve the bone. The more you raise the flap, more inflammatory mediators will be going to the area causing bone resorption. So always remember, the more soft tissue is touched, more prostaglandin 1 and 2 are secreted in the area, which leads to bone resorption. So anterior region, try to do flapless. So it's not easy to say that you have to do flapless. You need to have a CBCT or a guided surgery to do flapless surgery. And always remember to put the implant below the crest. So I hope you remember this. There is also a classification of implants, whether you placed it subcrestal, at the crest, above the crest. This is also because implant companies are making nowadays implant up to the platform. That means you don't have a smooth collar on the implant. If you have a smooth collar on the implant, you have to keep it above the crest, because you know there is not going to be any osseointegration on the smooth collar. But if you don't have a smooth collar on your implant, and your implant can be put subcrestal. So in the maxillary anterior region, always try to put implant subcrestal, and it can be up to 2 mm below the crest. Everyone must check the RFA for primary stability. Anything above 40 or 45 is very good. So always place your implant little palatally, because you'll get good primary stability. There's a good palatal bone, and you also have the curvature of the nasal cavity, which will help you to get good bone support from the lower area. Then there is definitely going to be a gap, and that gap is known as jumping gap. And that has to be filled with a good biomaterial. You can use BioOS, you can use Osfix. You know, Osfix has been launched in India, which is, I'm also using it by Dentistry. It's a very good material. Now, once you put lots and lots of bone graft there, you can expect the facial bone, the facial bone which is very thin buccal bone present there, to be supported by it. Once the implant has been inserted, you can initiate a standard prosthetic abutment which can be connected to the implant. But in my opinion, what we do in our cases is that we put a long healing cap. Whenever we are trying to use maxillary anterior teeth, we use implant with a good stability. We give a long healing cap, because for at least have disocclusion in all the centric and lateral extrusion contacts. Patients need to be very much taught of maintaining the hygiene over there. You must recall the patients early and make sure that there is no subsequent infections or any problem, because these kind of patients need to be recalled more often. Once the healing is up to the mark, you can go ahead and put a prosthetic provisional crown over there. And once the provisional crown is placed, you can expect more reorganization to be taking place. And then you can go ahead later, after 10 days, for final crown placement. The whole idea of teaching today you is to see the facial bone. Always remember that since you have put the implant subcrestal, there will be good amount of concentration of forces around the platform, and the dimensional changes of the bone will happen around those. So the jumping gap, in this, the B is your jumping gap, the distance between the facial bone and the surface of the implant. That jumping gap will reduce over a period of time. That is what is very important for you to see on the CBCT. So the horizontal distance between the implant surface and the inner wall of the socket at the implant level is the more important thing which needs to be seen in these areas. And if it is maintaining itself over a period of 2 months, this is wherein you can go for your final prosthesis. So this is how you go ahead. You extract the teeth, you place the implants, you can put a healing abutment, you can then give a definitive abutment after that, and then you make a provisional crown. And once the healing is complete, then you can go ahead with the final ceramic zirconia crown. And the lower picture, you can see how the bone reorganizes things. From the first picture, you can see that bone has resorbed a little bit and has now remodeled itself, and now it's rounded in nature and supporting the implant. Most of the implants have conical connections, and in the conical connection, the concentration of forces are vertically present, so you have less bone resorption around them. So I'll be presenting some cases of theoretic nature. So most of the work on chamber concept were done by Digedi et al., and he has done a lot of work on preservation of anterior facial bone post-extraction with bio-os grafts. And cone beam CBCT were performed in all the cases, and they were done again after 12 months, and measurement was done. And the study demonstrated that the extraction of tooth and immediate insertion of implant together with the xenograft resulted in alteration of the vertical horizontal dimension of the buccal bone plate. The vertical and the horizontal gap reduction was nearly complete after 12 months, and respectively the implant was normally in contact with the buccal bone in 99.3% of the cases. So Digedi also did a study to assess the effects of implant removal after abutment removal after 6 months of bone healing and subsequently placement of immediately restored tapered implant in cases of posterior abutment edentulosum. They did a study in which a total of 48 implants were placed in healed sites and immediately splintered with temporary restoration, which was placed in a way to avoid occlusal contact. 24 weeks after surgery, 12 patients underwent the standard prosthetic protocol, The abutments were removed and the impressions were made directly on the implant platform. The 12 patients underwent the one abutment at one time protocol. Impressions were placed and the abutments using snap-on abutment copies, and the final restoration was delivered approximately 6 months after implant placement. The vertical and the horizontal bone changes were assessed using periapical radiograph immediately after surgery and after 36 months. All the implants in the study osseointegrated and were clinically stable after 6 months follow-up. So non-removal of implants were placed at the time of surgery in a statistically significant reduction in horizontal bone remodeling. So the whole chamber concept is not to interfere in the healing process. That's why they say if you want to not interfere in the, you put the abutment at the time of placement only. So the chamber concept says either you put the long healing cap or you put the implant abutment at the same time of the placement, so that there is less inflammation there and more remodeling. Now, let us see at the case which we did at our center. A very young girl reported with the missing teeth. So we opened the flap. There was a lot of resorption in the area where we have to put. So we used lots and lots of bio-os material, and we also immediately placed the implant with the long healing cap. In this case, we put a long healing cap. We didn't load it because the RFA was not very high. So this was immediately post-op. Next day, you can see the graft material and also the Offix mucograft, which is visible with suturing. Overall, the healing went very nice. So within 10 days, we loaded the implant. What we did is we took the long healing cap out after 10 days and we put our provisional abutment over it. And once we put the provisional abutment over it, we were able to give a composite crown. You know, in this case, we gave a provisional composite crown to the patient. So within a span of 2 weeks, we were able to load the crown. Now, to better understand this concept, I would like all of you to see this video. This video is by the team, Dr. Digedi, who is the proponent of this concept. I hope this will be a very good learning for all of you to see how they do the chamber concept placement of the implants. Immediate extraction. Palatal osteotomy. Very less amount of bone tapping is required because you already have a lot of space there. Implant placed in the socket. There is a jumping gap. There is a gap between the implant and the bone. Conical connection. This is a conical abutment. Temporization. This is how the tissues are going to reorganize themselves. gingival contour. Immediate restoration. So, Dr. Dignity is the pioneer in this concept, and he has been doing these cases for long, and he has written number of papers on this. So, my whole presentation today is to make you understand about the biology which is there around the cervical area of the area where we are putting the implant and restoring our prosthetic crown. So always remember that it's a very dynamic area, and that's why it's called as chamber. So it is actually a three-dimensional biological space around the abutment and is defined by a floor, wherein floor is your implant part, and the four sides. There will be four vertical walls, lateral, and the ceiling. And ceiling would be your crown part. So I want all you to see this. So this is the area which I am talking about. This space actually gets filled by the connective tissue, and your hemidesmosomes get attached to the abutment very harmoniously. And your crown also gets supported by this. And always remember, this is happening because we are putting the implant subcrestal. Nowadays, most of the implant companies are giving implants with no finished or polished collar. So you can easily put your implants subcrestal, and you can give and load your conical connections early. So this area actually becomes a biological equilibrium, or you may say it becomes a very happening place, and that's why it's called as a chamber. So whole concept of chamber I wanted to introduce to you, all of you today, and immediate restoration and immediate loading was the concept of this. Thanks everyone. Thank you.
Thank you, sir, for the wonderful lecture.
This is for pointer. Yeah. Okay. No, what's your tablet? This one. Just put the pointer. It's working. The PPT is working. Just steady.
After sir, we have our next guest speaker for the day, and she is none other than Dr. Nupur Kaushik ma'am. A brief intro before ma'am is here for the lecture. Dr. Nupur Kaushik ma'am is professor in the Department of Pediatric and Preventive Dentistry. She is presently associated with Subharti Dental College and Hospital, Meerut. Ma'am has about 40 publications under her name, with about 29 research publications in national and international journals. She is a recipient of Distinguished Women Award 2020 by ISPPD and Research Excellence Award 2020. Along with all of this, under her name, she is the co-author of 6 books of her specialty. She has supervised various research projects and her students are proud to be associated with her. We are really grateful for your presence here, ma'am, and we welcome you, ma'am. Please welcome ma'am with a round of applause, everyone.
Hello. Am I audible to everyone out there? Okay. So first and foremost, Jai Hind to one and all. This is something that we start our presentations where I work, that is Subhati. So I bring you greetings from Swami Vivekanand Subhati University. This is the institute where I work, that is Subhati Dental College and Hospital. This college was established in the year 1996 and it is led by a very dynamic personality who is none other than Dr. Nikhil Srivastav, and he is apart from being the principal and dean in our college, he is the HOD of my department also. So I missed out one slide. These are my fellow colleagues I have all there, and I'm sitting with my 9 postgraduates of my department. So now moving on further, like this is a very typical clinical scenario that we all have come across, dentinal caries. This is nothing new, we all have seen caries in different forms. But this is a peculiar form because to the department which I belong is that of pediatric dentistry. I know everybody, like they tend to escape out from these departments because we have to deal with children, and each and every child, they come with a different form of their trauma or any other experiences out to our department. So even like in caries, if we are talking about, and if I say which is the most common cause or the most prevalent disease, you will again tell me that it is dentinal caries only. In fact, it is caries only. So now the question arises that when WHO conducted their report in 2022, they come across that this is the most peculiar form of oral disease, and millions and billions of people are affected, and children are also affected with such. The report has shown that 514 million children, they suffer from caries, be it in mixed dentition, primary or permanent. In fact, moving on further, a systematic review was conducted which has shown that the overall prevalence of dental caries was more than 50% in a population, and the type of caries which is most common was the type of problem which was most common was caries only, and it was most common in pediatric population. Now again, why am I coming to all these things? So that I could bring you all to my topic, because when we talk about caries, what are the treatment options that we are left out with? Earlier we had amalgam, but it has become very obsolete. Now we move on to further like GIC, we have composites, and recently to the department we have added stainless steel, not recently, but apart from stainless steel we have something new that has been added to the department. And that brings me to the topic today. And yes, of course, if we have children like this, how are we going to deal them? So that brings me to the topic today, which is non-invasive management, non-invasive strategies for caries management in pediatric population. So moving on further, this is something which has come up recently. What it is? It is silver diamine fluoride. I know many of you must be knowing what is silver diamine fluoride. It is also known as magic bullet, or it is also known as silver bullet. So this silver diamine fluoride that was introduced in Japan. I know Japan is one country that leads to everything. So this was introduced in Japan, in which married women, they used to cover with the solution of silver onto their teeth surface because they wanted to show to their peers that they are married. So this was a tradition out there which was followed in Japan. Apart from this, it has been used in the medicine in the form of antiseptic also. And It had been used in dentistry later back in the stage as hose solution, where it was used to sterilize and disclose caries, to avoid direct pulp exposures, to detect incipient caries lesions, and extremely sorry, and to disclose the leftover carious dentine. Apart from this, this ammonial silver fluoride was used to arrest dental caries also. Now, what is the mechanism of action of this silver diamine fluoride? So, this silver diamine fluoride, it consists of two components, silver and fluoride. These silver and fluoride, they combined with tooth, and we know that our teeth, they consist of two main components, which is the proteins and the mineral component. So, what happens when this silver, it reacts with the protein, it forms silver protein, and when it reacts with the mineral, it forms silver phosphate. Apart from that, when this fluoride reacts with the mineral, it forms calcium fluoride. So, what happens basically, this silver has the antimicrobial action, and this fluoride, it has the capacity to form fluoroapatite, which is more resistant to caries. So, just in short, what this silver does to our teeth is that it prevents the cellular respiration, it causes the cellular destructions, and it inhibits any kind of enzymatic activities which is going on. So, again, to summarize, what is the effect of this silver on enamel and dentine? In short, is that it increases the micro hardness, and the fluoride component, it helps us in remineralizing and forming fluoroapatite, which is more resistant to caries. Now, a very peculiar phenomena of this silver diamine fluoride is its zombie effect. Now, all of us must have seen these Bollywood and Hollywood movies in which we have seen those zombies. So, what actually happens, that these silver ions which are killed, when they come in contact with a live bacteria, the silver again activates and they further kill the live bacteria. So, this is kind of a zombie effect which goes on, and this is a very peculiar phenomena of this silver diamine fluoride. Now, why SDF? When we have sodium fluoride, we have stainless fluorides, we have APF gel, we have fluoride varnishes. Why are we progressing towards this? Because the amount of parts per million this SDF gives to us is far better than any other fluoride that is available to us. That is 44,800. And that is the reason we are moving towards this non-invasive dentistry. So, what happens and what are the cases in which you can use this this SDF is, in each and every patient who is suffering from caries, in patients who have dentinal hypersensitivity, in geriatric patients, and of course pediatric population, in patients with special healthcare needs, we can use silver diamine fluoride very easily. Now, when we have indications, naturally we tend to have certain contraindications. So, moving on to the contraindications, like we are not supposed to use if a patient has any silver allergy, in cases in which the patient is having ulcerative stomatitis or gingivitis, and in cases in which you expect the lesion to be very close to the pulp. We are not supposed to use the silver diamine fluoride in cases when we expect any pulpal involvement. Now, it has got so many advantages. It has to bound to have certain disadvantages also. So, what are those? That it stains. The biggest disadvantage of silver diamine fluoride is that it stains the tooth. So, whenever you are applying it onto a patient, patient's concern or parent's concern is of utmost importance. You have to take their consent and then only you have to perform the application. It causes gingival and mucosal irritation. So, whenever you are applying, you have to apply a barrier onto the mucosa wherever you are applying onto the tooth surface, and then it has got a very unpleasant taste. So what is the actual application of this SDF? One drop of SDF can be easily applied to 6 teeth, and you have to continuously rub onto tooth surfaces for 1 minute. This is the main method which you have to follow onto the patients. And then you can easily dry it out with your air. As such, no post-operative instructions are there which we have to give on to the patients. No. But in many of the whatever the products are available in the market, some have written there are no manufacturer instructions, but many of them have said that 30 to 60 minutes you have to avoid anything to eat and drink. So this is a video that shows how the clinical procedure happens. She's a small child, 3 years and old. Please make sure whenever you're applying it onto the patients, the child age has to be above 3 years of age. If it's below 3 years of age, make sure that you're doing it under proper supervision and guidance. See, proper isolation is there with the help of the petroleum jelly that is available. And then a single drop with your brushes that are available for the composite etching and bonding, you can simply apply it onto all the tooth surfaces. So we have tried to isolate it with the help of the napkins, tissue paper, so that it doesn't go anywhere else, because staining is a very big disadvantage with silver diamine fluoride. Just keep on rubbing, and you will automatically see that the white surface of the tooth has completely turned black. The amount of blackness will tell you that for how the extent of this SDF onto the tooth surface. And if we talk about like for how long we have to do this, I have already said 1 minute. For 1 minute you have to continuously rub it onto the tooth surface. Frequency application, if somebody asks, we have seen that this SDF, the studies have shown that this SDF causes reduction in caries. So, once a year or biannual application of SDF is appreciated. There are no adverse reaction unless you don't put it onto a tooth surface in which the exposure is expected. Apart from this, if we summarize SDF, it is a very good material to arrest caries. It can be easily used in pediatric population. The only disadvantage is the black staining. However, the discoloration is not permanent except onto the tooth surface, which you can hide with the help of your restorative materials. So, just to summarize about SDF, it stops the progression or arrest carious lesions without removal of the sound tooth tissue. It helps to remineralize dentine, and the effectiveness of treating carious lesion with SDF is demonstrated by the increase in the mineral density. It has been targeted for the safety doses, so we don't have to talk about whether it is safe or it is unsafe. Now, apart from this SDF, because we have seen it is non-invasive, you don't have to make a cavity onto the pre-existing carious lesion. You can simply apply, and it disrupts the carious lesion. Another thing, just 3-4 slides more, it's stainless steel. I know all of you must have done stainless steels in the department, and you know these are stainless steel crowns that can be used. But if we talk about the indications, earlier we had any pulpal therapy in developmental defects, in cases of bruxism, even after pulpotomy, and the contraindications for stainless steels were like if the tooth is expected to exfoliate, or if any patient has nickel or silver allergy. But now recently we have seen that there is another modification of this stainless steel crowns is Hall's technique, in which no cutting was there, no carious removal, and in all those uncooperative patients who were not cooperating, we could simply place these stainless steel crowns onto the tooth surface. So remember, in both of these techniques, we are not removing the carious lesions, because the studies have proven out that they are very effective even if you don't remove the caries. So now in this Hall's technique, this was like you choose the size of the crown according to the tooth number, and then place separators. If you have tight contacts, then you directly place the crown onto the tooth, lute it with GIC, and then after you ask the patient to bite for 4 to 5 minutes, you can send the patient back home. There's another modification of this Hall's technique, which was modified Hall's technique. Suppose you have very tight contacts, you are not able to place onto the crowns, and what are we supposed to do? We have to do simply proximal stripping, and this is modified Hall's technique. Now these are the variety of luting cements which are available, from GIC to resin modified GIC. So in the end, I would like to conclude that these non-invasive techniques are gaining popularity because everybody fears small children in the department because they might be pre-cooperative, uncooperative, or they may be cooperative. So these are the techniques which are gaining popularity, and we should inculcate them in our dental practice. So this is me with my department, my undergraduates, my postgraduates, my patients, and I would like to thank CynoDent for inviting us here. Thank you one and all for your patience listening.
Thank you, ma'am, for the lecture. Ma'am wants to know if there is any query or any discussion anyone wants to interact with ma'am. Then please let us know. Okay. Thank you, ma'am. Thank you for the lecture. I would request you all to kindly wait because we are going to felicitate the 3 of the guest speakers. I would request Dr. Ashish Chandra sir and Dr. Anmol Bagaria ma'am to please, and Dr. M. Siddharth sir to please proceed on the stage for the felicitation of the guest speakers for today. And I would request the coordinator to please change the background. The first speaker to be felicitated is Dr. Pankaj Dhawan sir. He is the professor and head of Department of Prostho and Implants from Manav Rachna Dental College and Center. Thank you, sir, for your lecture today. Meanwhile, sir is coming. We are going to felicitate the next speaker. She is Dr. Vinita Nikhil ma'am. She is the professor and head of Department of Conservative Dentistry and Endodontics from Subharti Dental College, Meerut. Please give a round of applause for ma'am. Thank you, ma'am. It was a pleasure listening to you.
Thank you.
Thank you once again, ma'am. The next speaker to be felicitated is Dr. Nupur Kaushik ma'am, who has just given the lecture. And she is the professor and head of Department of Pediatric and Preventive Dentistry from Subharti Dental College. Thank you, ma'am, for your lecture today. Please give a round of applause for ma'am. Ma'am, sir has proceeded for the breakfast. He's just coming. Please kindly wait. So we have Dr. Pankaj Dhawan sir with us. Sir is the professor and head of Department of Prosthodontics and Implants from Manav Rachna Dental College and Center. And we are very delighted to have you here with us, sir. Please, sir, proceed to the stage for the felicitation. And I would request Dr. Ashish Chandra sir, Dr. Anmol Bagaria ma'am, and Dr. M. Siddharth sir for the felicitation of Dr. Pankaj Dhawan sir. Please give a round of applause for sir. Thank you, sir. It was a pleasure to have you here. Thank you, sir and ma'am, for the felicitation. Now we will continue with the lectures. I would request the coordinator to please switch on the PowerPoint presentations. So the next speaker of the day is Dr. Sanjeev Salaria, sir. A brief introduction before we call sir on stage. Dr. Sanjeev Kumar Salaria, sir, is the principal, professor, and head of Department of Periodontology from Kalka Dental College, Meerut, UP. He has graduated from Government Dental College, Patiala in the year 1996. He has done his post-graduation from Government Dental College, Amritsar in the year 2000. And he has more than 22 years of clinical experience as academician, both as undergraduate and postgraduate teacher, along with 23 years of experience as a periodontologist. Sir has more than 60 publications, both in national and international journal citation, and along with all this, Sir has about 200 citation index, along with 175 co-author in textbook of periodontology and periodontology revised by Shalu Bhatla ma'am. He has been former executive committee member ISP for 4 years till 2021. He has also been the former periodontal health care convener in ISP for the session 2021 to the session 2022. He is presently working as Joint Secretary, Indian Society of Periodontology for the year 2022 till now. Sir is awarded as Outstanding Professional by Uttarakhand State IDA Office in 2009, and it is a pleasure for all of us to have you here with us, sir. And the topic that sir is going to cover is gingival reactive lesions management, a periodontist perspective. Welcome, sir. Please give a round of applause for sir.
So good morning. I'm audible. First of all, I thank Almighty who give me courage to present in front of such a wonderful audience. Thanks to Sharda University and CynoDent for giving me the opportunity to present my special note cases regarding the reactive lesions and how the periodontist manage such cases. The way how it differs from the normal clinician they manage it. Most of us we are aware about the gingival reactive lesion. How many you are aware about periodontist? Definitely. How many you are associated right there? Can you raise hand? Interns? Yeah. So reactive lesions basically means they are the eruption that occur because of any impact that is persisting too long or for a long duration of period. So anything that is pertaining to the gingiva and reaction that occur within the gingiva because of these irritations, they are normally considered to be as an, you can say, the reactive lesion of the gingiva. Other than that, there are different types of way, or you can say they are associated with the developmental growth. You can say the gingival growth has been associated with the developmental region, inflammatory region, maybe reactive or neoplastic. But today we are going to discuss about reactive lesion. And routine, they are no neoplastic. That means they are unbenign. They are not carcinogenic. So most of them are aware that there are typical characteristics you can see. There are the nature of that growth that occur isolatedly as a reactive lesion. They are normally painless, and they can observed as an peduncle or you can say sessile growth. Color may vary from the pink to bright red, and the surface morphology normally smooth or non-ulcerated or ulcerated once the size may be enhanced and got multiple trauma from a long duration. Size may vary from the millimeters to you can say centimeters, or the growth rate may be rapid in onset. This is audible? So, if we talk about the etiology may be a local irritating factor that may be a bony spicule, or you can say the local factors, plaque, calculus, or any food trapment or food infection that is continuously persisting, or it may be iatrogenic. That means it may be induced unintentionally by a clinician by an overhang restorations, or you can say by placing the gingival margins or the restoration or prosthesis subgingivally. If I routinely ask any one of you that if you find out some isolated growth of gingival tissue in the oral cavity, what will be your treatment plan? Most of you are agree to that we can go for excision. Absolutely right? Is it right? I need your attention, please. Just say yes or no. Don't worry. I find myself 25 years beyond that last line. It take me to reach this site 25 years. So everyone can have the potential to reach, because Almighty already blessed you with a professional integration that you are supposed to serve the society. No doubt we are not, till date we are not aware we are supposed to reach here or not. But already the plans are there. Have faith in Almighty, you definitely reach it. Okay? So, any growth that normally find out in the oral cavity anywhere on the interior gingiva, you can say posterior gingiva, most of the clinicians, they simply say, doctor, nothing to worry, we are supposed to excise it. But what happened after a season? Have you observed the patient after excision? We have not observed. We think so, we have excised the tissue and the patient is gone. So that means patient is successful. Unintentionally we are considering because we don't have any feedback of that patient, either the lesion is recurred or not recurred. Second, after resection or before resection, we should understand what are the things to be taken care at the level of undergraduate and what are the things to be taken care at the level of periodontist. So if I say the lesion is persisting at the level of marginal gingiva, or you can say 1 to 2 millimeter of attached gingiva is involved and the lesion is pertaining that site. Simply a clinician, a BDS or an undergraduate can simply manage that case at his own clinic by simple doing excision, by taking care of mild extension of the lesion beyond its periphery. That means the lesion should extend at least 1 to 1.5 millimeter all around its periphery and complete enucleation of the site has to be done. It can be easily managed and most of these types of lesion will not reoccur, always remember. But when the lesion extended up to the attached gingiva, including interdental papilla and attached gingiva, that means if you extract that lesion, what happens? We are creating a wide surface area get exposed. It may be exposing the root surface, it may be exposing the underlying alveolar bone. If you leave these surfaces as such, it may induce, after excision, it may be interpreted as the residual soft tissue defect. And those residual soft tissue defect, if not managed, because you are not specialized or trained for management of such type of defects. So those cases has to be, you can say, go for the periodontal consultation where your patient give, so that you can give the best advice and best treatment modality to prevent reoccurrence of those lesions. Thereby periodontist consultation is required in such scenario. Normally the lesion less than 1 centimeter should be excised in one go, and if the lesions are extended more than 1 centimeter or you can say an inch, you can always prefer to take a biopsy before you go for complete excision. Normally these are the trends followed by most of the dentists in their practice. If bigger than that, they can excise and leave the tissue as such. Sometimes they will manage the local etiology that are inducing this type of growths, but sometimes they are simply excising it because they are not aware why the growth has been initiated and what are the site of origin and what will be the etiology behind that. So periodontists always plan the things before they intervene into the surgical intervention. Here I am going to present few cases that we have already reported and published in the index or PubMed journals. All these cases have been available at my site of Dr. S.K. Salaria citation. If you search at Google Scholar, you can find out all these articles. So whenever we are facing the attached gingiva is involved with an reactive lesions, we should always plan it first of all, because we know that if we excise the tissue, it will lead to the residual defect formation, and these residual defect formation will always precipitate the post-operative sequelae like recession, sensitivity, difficulty in managing the oral hygiene, and slowly it may induce further marginal defect growth and ultimately loss of tooth. So before we are excising, we should plan the cases and treat them accordingly at our own clinic where you think so you are capable of enough to handle these cases, and if you are not Where you need an periodontist consultation, you can always advise and refer the case, or you can call a consultant to your clinic and proceed. Here we are presenting a case. This is the 52-year female patient that reported to the Department of Periodontology with a chief complaint of reoccurrence 3 times after excision by a family dentist. The lesion was extensive, and it is more challenging for a clinician or a periodontist when recurrent lesions of multiple times has reported to you for treatment management, because already the patient has gone for 3 time traumas. So we find out the lesion and we find out the local factors are pertaining. It is quite evident from the slide that the local factors are quite evident. Subclinical or subgingival deposits are present. We can find out what is the length, size has to be evaluated, and along with the suturing threads, we find out what are the basal attachment, how much is the peripheral extension of that lesion actually is. That means which component of the gingiva, either it is marginal, either it is interdental, or either it is attached gingiva is involved. So we find out the part of attached gingiva is already involved along with the interdental tissues between the 2-2 and 2-3, but still a part of attached gingiva can be preserved if we take care of that. As the lesion was bigger than 1 centimeter, we go for incisional biopsy, and the biopsy is suggestive of inflammatory cell infiltrate with area of hemorrhage and degeneration along with purulent, fibropurulent membrane formation. That are suggestive of complete diagnosis of pyogenic granuloma, and we know that the recurrence rate of pyogenic granuloma vary from 15 to 20%. That means if we are not completely eradicate the lesion, there are chances to reoccur again. Might be in the previous history, the clinician who has resected the lesion might not be remove the etiology or might not completely excise the lesion. That may be the reason for the recurrence. Now, local factor along with the brush trauma was the most probable etiology that what we encounter, because the patient was reported he is having feeling now the difficulty in maintaining the oral hygiene, and brushing will also hampering these things, and the growth will enlarge within a month of 3 months. Within 3 months that lesion will extend. So rapid in growth in nature, and we find out biopsy will suggestive of pyogenic granuloma. Already the patient was exposed and told that no doubt on the next visit the lesion might reduce in size because we have taken an biopsy and we have performed the oral hygiene procedures. So, but there are 2 options. Either we have to resect the tissue and leave it as such, but that may induce a residual defect formation along with the postoperative sequelae like dentinal hypersensitivity, gingival recession, or might be in a later stage you may find the difficulty in maintaining the oral hygiene or may lead to the loss of tooth if not taken care appropriately at the right time. So out of the different choices, we have given them the option because we know that the attached gingiva component is still present if we excise the tissue. So we can plan to go for either one, connective tissue grafting, for which we need a second stage surgery to harvest a graft, and second is we can go for an PRF with corneally advanced flap. So both the surgery procedures has been disclosed, and as the second surgical intervention is always having a problem with the patient, most of the patient doesn't allow, and they are associated with the postoperative sequelae also, the pain, healing will be discomfort. So the patient agreed to go for minimally invasive and the PRF associated corneally advanced flap. So after 3 weeks, 2 weeks, when the patient reported the size is already reduced to half, we can find out, we cut the mushroom head to find out, you can find out in the first slide. Sorry. You can find out the lesion periphery is available at the first slide. It has pebbled appearance and involving the part of attached gingiva and the interdental papilla, which we have already assessed and we have planned it accordingly. Secondly, we give an internal bevel followed by the clavicular incision, and whole of the lesion has been excised, and we find out approximately 8 millimeter to 10 millimeters of residual soft tissue defect is still existing, for which we have given and vertical releasing incision followed by the slicing, or you can say the scoring, or you can say the periosteal incision to displace it coronally. If you find out the recession, the soft tissue residual defect is 8 to 10 mm, whereas the gingival recession pertaining to that particular tooth is 4 to 5 mm. Even if it is less than 1 mm of root exposure or 2 mm, we can still consist of to leave it as such. But because the 2 mm is the amount of biological width that is required to be regenerated. So if it is more than 5 mm, that means 3 mm of recession definitely going to happen if we are not supposed to manage this case. That's why we advise the coronally advanced flap, and the vertical releasing incision has been given on both the sides within scoring of the periosteal flap and repositioned back and secured at the surgical site. After 3 weeks, you can find out the surgical site heal uneventfully without any recurrence sign, which were further reevaluated at 3 and 6 months. You can find out the pocket depth is reduced and there are absolute color match. That is an advantage of coronally advanced flap, because we are not taking any pedicle graft from anyone else. We are not taking it from other side. If you take FGG, FG has patch type effect. That means it is a puncture type effect. The color contrast will not match. Secondly, we have used the autogenous PRF that has bundles of, you can say, the growth factors that stimulate the soft tissue healing and improve the aesthetic outcome also. Similarly, a second case of peripheral ossifying fibroma. The patient has the previous, prior to the biopsy, the pic has not been right here. So this was my first case when I start using this technique to repair such lesion immediately. So the patient after biopsy will show there are parakeratinised stratified squamous epithelium with a trabeculae of bone is observed, which are suggestive of the lesion is of peripheral ossifying fibroma. So the part of the attachment, normally all these type of lesions are female predominance and mostly observed in the maxilla. Rarely you can find out such lesion in the mandible side. No doubt the availability of literature show that it may be present in the mandible too, but higher prevalence rate will be observed in female as compared to male and more in maxilla as compared to the mandible. Similarly, we can find out, but here we can find out the extension of that lesion is approached the mucogingival junction. So if we thoroughly excise that tissue, it may go beyond the mucogingival junction. So what will be the alternative available? If we resect the tissue, what are the other pedicle flap options we have? One is with SCTG. Either you go for subepithelial connective tissue grafting, for which the patient is not agreed most of the time because of the second stage surgery, and that is technique sensitive too. Then we find out alternative for group and Warren, laterally displaced flap, because the prerequisite for them is the site where adjacent site has sufficient amount of attached gingiva, you can laterally displace the flap to eradicate such type of residual soft tissue defect if you are presuming it to be occur. Similarly, after surgery, the mucogingival tissue has been involved. So we give an vertical releasing incision followed by the cut back incision, which is approximately 2/3 of the length of the amount of recession or the soft tissue defect was present. That means we are giving vertical releasing followed by cut back in the direction where you are supposed to displace the flap. Interiorly, we given papillary incision because we don't want to change the papilla position. We want to retain that papilla intact, and you can observe in the first slide the interdental cuts are there. The papilla is already preserved, followed by the partial thickness flap. In the second image, in the last corner, you can find out the red point of triangle is observed. That means when you displace the partial thickness flap mesially, you can find out the area which is covered with the periosteum and the flap is shifted. Advantage of doing the partial thickness, because it has a capacity to regenerate, it contains various potent cells and the bone is not exposed. That means the chances of soft tissue coverage automatically will take place from the recipient side and simultaneously at. 6-month follow-up, we can find out excellent healing without any scar formation at the interior side. The patient is highly pleased with the outcome because that is also a recurrent type of lesion. The third recurrent type of lesion, what we observed in the posterior segment, and the lesion was approximately 2 centimeters in length, covering the molars. Most of the time, because when I am starting my practice as a periodontist and managing the periodontal tissues, I feel difficulty in such type of cases, because here it is very difficult because the area is not visible thoroughly in the posterior segment. But if you proceed slowly with a patient time, definitely you get on success. Your aim should be clear. The biopsy has been taken, there is no or mild alveolar bone loss has been observed all around the tissues. Histological studies show there are random RBCs are available, and microphotograph showing atrophic epithelium with connective tissue stroma and focal area of inflammation. That's suggestive of this is none other than an irritational fibroma. And the irritation in that case may be because of the local factor which are present, subgrowth region. So from upper line, we can move from the left to right, left to right, left to right. So initially, attachments have been found out and the lesion base has been eradicated, followed by the similar procedure. We can find out the vertical releasing incision has been given, but in the fifth slide, if you observe, the irregular bony margin with subgingival granulation tissue has been present with the local factor that has been eradicated, followed by the osteoplasty, and then the scoring has been done in the seventh slide and cornally displaced the flap, simply without any grafting material, and the post-operative sutures has been placed immediately after displacement. You can find out at 14 days, 1 month, 3 months and 4 months. There is no probing depth, no growth, except the biggest disadvantage of, you can say, the vertical releasing incision is the scar formation. But as the lesion is existing in the posterior segment, so that is not the criteria. So that's why we attain absolute healing without any recurrent lesion. So take home message from that, if you want to say, it is our responsibility as a clinician or a dentist to give the best treatment or clinical outcome to our patients. If you think so, the lesion is pertaining and well under the control, extended up to 2 mm of attached gingiva, you can completely excise the lesion without any advice. There is no issue. But if the lesion is involving more than 3 to 5 mm, always consult a periodontist, because he is the person who is specially trained to manage such type of defect. Otherwise, the patient will continuously visit your clinic with a complaint of post-operative sequelae associated with excision of such lesions. Thank you very much for your patience listening. Any questions? I'm most welcome.
Thank you, sir, for the lecture on gingival lesions and their management. I would kindly request you all to please get seated in the center. All those who are sitting on the sides, please do not segregate and settle in the center, please. The next speaker for the day is Dr. Preeti Sharma ma'am, and a brief introduction for her is that Dr. Preeti Sharma is working as professor in the Department of Oral and Maxillofacial Pathology, and she is from Subharti Dental College. She has an experience of 13 years after completing the post-graduation from prestigious Swami Vivekanand Subharti University, Meerut, in the year 2010. She has been awarded the prestigious International Fellowship by International College of Dentists India, Sri Lanka and Nepal section for 2020 and 2021. She was also awarded Fellowship in Forensic Odontology recognized by the Board of Indian Association of Forensic Odontology, IAFO, in the year 2015. And currently she is the Executive Committee member, that is the special invitee of Indian Association of Forensic Odontology for 2019-20 and 2021-22. Today she is going to deliver the lecture and we welcome you here, ma'am, among us. Welcome, ma'am. Please give ma'am a round of applause.
Jai Hind and very warm greetings, dear delegates and my dear students. I'm a proud Indian and I'm also a very proud Subhartian because I work at Swami Vivekanand Subharti University, Meerut, which has vision and mission of Shiksha, Seva, Sanskar, Evam, Rashtriyata. At the same time, I'm very proud and happy to be working at Subharti Dental College under the dynamic leadership of our esteemed principal and dean, Dr. Nikhil Srivastav sir, who is not only an inspirational model for the students, but also for the faculty. And this is our department, and we are all working together with passion and dedication under the headship of Dr. Vijay Vadhavan sir, my department. And at the same time, ladies and gentlemen, I'm also proud to be an oral and maxillofacial pathologist. So I am also a proud student of my guide, Dr. Sushmita ma'am, ex-president IOMP, under whom we published this paper, Trends in the Epidemiology of Oral Squamous Cell Carcinoma, which was published in Indian Journal of Dental Research, which now has citations of nearly 181. But why I'm talking about it here? Well, the reason is the dismal statistics. Ladies and gentlemen, it is very dismal to know and shocking that even after 13 years, it is 2023, article was published in 2010, it's still being cited so much. And the oral cancer statistics in India is carrying the major burden for the oral cancer, and hence the relevance of my topic today, that is the early detection of oral cancer in view of global challenges, the current paradigms. So the current problem here is the oral cancer scenario in India, which is the now world capital for oral cancer. And once again, if we see the statistics, we find that 1/3 of the total burden is carried by India. And if you know that out of all the oral cancer cases, the major chunk of the cases, they are the oral squamous cell carcinoma cases, about 84 to 97%. And this is showing us the incidence of oral cancer in different states of India, and we can see that the major sites are the buccal mucosa, tongue, followed by tongue, and we can also see the etiological factors here. We also know that the concern here is that oral cancer is actually detected at a very late stage. It is not detected in an early stage. So there is a delay of 9 months from the onset of symptoms to diagnosis. So delayed diagnosis leads to increasing the cost of treatment and reduces the likelihood of survival, also reduces the quality of life. Therefore, a paramount question should be, what can be done to favor diagnosis in earlier stages? What is the solution? Well, the solution is early detection and early treatment to prevent the physical, psychological, and financial losses to the patient. Therefore, what should we do? We should reinforce the control of tobacco usage, reinforce tobacco awareness programs, reinforce early detection of the oral cancer. So I'm not going into details because all you are already aware of the factors causing oral cancer. There are so many factors with the tobacco leading the factors, so many tobacco products, the market is flooded with these products. And of course, one of the reasons for oral squamous cell carcinoma is oral potentially malignant disorders. So if students are sitting here, let me tell you that earlier we had the pre-malignant lesions and pre-malignant conditions. This is what we were following. Now we group them under oral potentially malignant disorders, which means that these lesions may transform into oral cancer. We are not saying that they are definitely going to transform into oral cancer. So let us discuss the techniques which are in demand for the diagnosis of oral cancer, which are non-invasive, rapid, and easy to use. So some of the techniques I'll discuss with you today, which are based on the direct observation, imaging of the patient, and analysis of the extracted material from the patient. So first of all, what we do, of course, is the clinical examination of the patient, and these are some of the clinical presentation, clinical pictures showing the ulceroproliferative growth, fungating growth of the oral cancer. We do a biopsy. In case of a large lesion, we do incisional biopsy, and as an oral pathologist, we do histopathological examination, which still remains the gold standard for the diagnosing of these lesions. We should also be aware that sometimes the lesions which do not appear to us, which are suspicious, even they may show the dysplasia feature. So what is dysplasia? Basically, there is total alteration in the architecture of the tissue, and we recognize all the changes like nuclear cytoplasmic ratio is changed, there are bizarre mitotic figures. So all these things are seen, and our diagnosis can be on the degrees of dysplasia, like mild, moderate, and severe degrees of dysplasia, which can be seen in the potentially malignant disorders. And then on the histopathology, we see the types. We finally sign out as the types of the oral squamous cell carcinoma. It's a huge responsibility being an oral pathologist, because oral surgeon's treatment will depend on how we sign out the report, whether we are writing well-differentiated squamous cell carcinoma or we are writing the poorly differentiated squamous cell carcinoma. However, friends, this is an invasive technique, so what can we do? What should be done, the techniques which are non-invasive, rapid, quick, painless, simple? So let us discuss about the vital staining techniques. And you know that we usually use a toluidine blue, which is used to detect the mucosal abnormalities in the oral cavity, which is a metachromatic dye, stains the DNA and RNA. We can also use the Lugols iodine. So here is a picture which is showing that there is indistinct margin. We do not know which part is more suspicious. So toluidine blue, since it's staining it's an acidophilic dye, so it will stain the DNA and RNA in an oral cancerous lesion. Lugols iodine is more sensitive than toluidine blue. The difference here is that it stains the glycogen. So the staining will depend on the degree of differentiation. While it will stain the well-differentiated lesion, it will not stain the poorly differentiated carcinoma. A very simple technique is the brush biopsy. So if we look at the picture, you can easily see that within the epithelium, we can take the transepithelial cells from the superficial to the basal layer. We can observe these cells, and very simple, we can take this cyto brush, which is not very expensive. We rub it on the buccal mucosa till there is a bleeding point. We prepare the slide using the spray site, and after fixation, these results we get, and then we report to the oral surgeon. These days, we have advanced techniques like we can use liquid brush cytology, which is little better than the normal brush biopsy, because here we have more suspicion of cells, and we can see even the monolayer of the cells. So this is a conventional smear and the liquid base, so we can compare the two types where we have the cells, which the morphology is more clear in the liquid-based cytology. One more picture showing that liquid-based cytology is getting better and better day by day. So what is the difference in the exfoliative cytology and the brush biopsy is that in the exfoliative cytology, we get only the superficial cells. It is a more simple actually technique than using the cyto brush. Disadvantages, as I have already told you, we get the superficial cells, and these are the instruments which we can use, which will give us a good yield of cells. Even your ice cream spatula can be used, cotton swab, Toothbrush will give a good yield of cells, and then we can classify it on the type of the dysplastic features or the normal features which we are seeing on the slide. To quantify, there is a better method. This picture shows the use of image analysis software, whenever we want to quantify the ratio of the nucleus and cytoplasm, then we can use this. So this is a summarization of the processes of the techniques which I just talked about. So the major advantage here is that these techniques are non-invasive, rapid, simple to use, and very simple to be used by the general dental practitioners also. Coming to the next methods, which are very popular commercially. So these are the light-based detection systems, which are based on the autofluorescence. And one of the very popular you must all be familiar with and must be using in your dental clinics, in your institutions, is the use of well scope. So what is well scope? Let us understand the principle, Our body is made up of tissues, and these cells, they are actually having the fluorophores. So we are already having these tissue autofluorophores, and whenever an excitation light is thrown upon it, so it reflects and a light is emitted. So wherever there is some abnormal tissue, wherever there are some features of dysplasia, it will appear darker, and whereas the surrounding area will appear brighter. So this is the picture, and this is how we can visualize, that can give a quick view of the lesion, whether it is progressing towards oral cancer or not. A similar technique commercially popular is the use of Visilite, where we use a disposable capsule is there, we break it, and then because it consists of acetyl salicylic acid and hydrogen peroxide, and then we can visualize the cavity along or in conjunction with the toluidine blue. Another addition to it is the Microlux DL, or diagnostic light. So these are the summarization advantages. So main advantages are that these techniques are all non-invasive. And I would say the main common disadvantage is that false positive and false negative results are also there with these techniques. Imaging techniques, so the MRI, CT, they also help us in evaluation, pre-treatment assessment of the oral cancer lesions, plus the positron emission tomography, which is very, very useful to see the extent of the involvement of the lymph nodes. There is a new technique which is known as the Raman technique or Raman spectroscopy, which is based on the principle of the vibration of the biomolecules. So here, like we can see that we take a saliva sample, or we take the oral desquamated epithelial cells, and then we see on the spectroscope. So the only disadvantage here is that we require trained specific personnel to gather our gradings for this Raman spectroscopy, which is the only disadvantage. More disadvantage is that it is little expensive, not very dental practitioner friendly. You have to be very technically qualified in that. Another optical imaging technique is optical coherence tomography. So in this, we find it is non-invasive technique, very useful, and it is already being used in ophthalmology and cardiovascular patients. So that also can be used in the oral cancer patients' optical coherence tomography. And since it is non-invasive and we can compare it with the histopathology, it can help us in knowing if there is any break in the basement membrane or there is invasion in the connective tissue stroma. Well, there are some advanced methods also. As we all know, this is a simple picture. If students are sitting here, they can understand that the carcinogenesis or cancer that goes through some processes, initiation, promotion, and progression, and some genes are involved here. So many genes are there, and I'm not naming all of them. So this is a simple gene which you all must have heard of. That is a tumor suppressor gene P53. So whenever there is some danger, so it comes into action, and we find that there is elevated levels of P53. So these can be used as tumor biomarkers. And these days, we have also biosensors. So biosensors, to put in the simplest words, they are available commercially also as nanobiochips or biochips or cytochips, and they're very similar to glucometers. So as all our tissues, the biomolecules, wherever the cancer cells is there is elevated level of these tumor markers. So these analytes consist basically of DNA, RNA, and proteins, and then we can use the receptor and we can get the finding in the form of the transducers. So these days, biosensors, they are also available because they reduce the diagnostic time in the patients. So this is one more picture, which is telling us about the use of the biosensors. These days, we are also using the nanoparticles for the biomarker detection of the oral cancer. So friends, microRNAs, what are these? These are the non-coding RNAs, and their levels are again elevated in the case of oral cancer patients. So they can also be used as markers, not only in the blood, but also in the saliva. And last but not the least, it is the artificial intelligence which is coming up. So we now have whole slide imaging system. So we have an automated data where we use the machine learning and the deep learning, and that can also be used in the future for the early detection of the oral cancer. So the take-home messages: prevention, early diagnosis, and timely treatment are critical aspects to tackle and cancer-related burden in India. Reinforce, reinforce, and reinforce the robust programs on a war footing to control the tobacco usage, awareness programs, and early detection of oral cancer. And are you all aware that April is actually World Oral Cancer Awareness Month? So please spread the oral cancer awareness. So thank you for your patient listening, and I would like to thank the organizing committee, organizing members, for giving me this opportunity to give my presentation here. Thanks a lot.
Thank you so much, ma'am, for such an informative lecture. Now, I would like to invite our next speaker, Dr. Rabindra sir. He is all the way from Nepal. We heartily welcome you in India, sir. Professor Dr. Rabindra Mar sir completed MDS in orthodontic from the University of Philippines in 2004 and BDS from SDM Dental College, Dharwad, Karnataka in 1966. He is working as the principal in Kantipur Dental College and member of faculty board of Kathmandu University. He is currently serving as the president of Nepal Association for Dental Research and Pierre Foucault Academy Nepal section. He has served as the president of Orthodontic and Dental Facial Orthopedic Association of Nepal, General Secretary of Nepal Dental Association, and executive member of Nepal Medical Council. Over to you, sir.
Thank you for the kind words. Thank you, CynoDent. Thank you, International College of Dentistry, and thank you, Sharda University, for giving me this beautiful opportunity to stand in front of you. As notified, my topic is the joy of interdisciplinary orthodontics. I represent Kantipur Dental College, Nepal Association for Dental Research, Peer Research Academy, Orthodontic Association, Kathmandu University, etc. So this is my college where I work as principal and professor in the Department of Orthodontics. It is associated with Kathmandu University. We have UG and PG programs. To start with the topic proper, orthodontics being a distinguished specialty, however, in many cases, it is only a part of patient's need for dental treatment. So there can be multiple dental problems which cannot be treated as an isolated phenomena. So you have to do it in some collective effort, and orthodontics becomes a component in re-establishing aesthetically and functionally satisfactory dentition with this effort, which can only be achieved by collaborative works of several disciplines. I'm sure you have been working in multidisciplinary setup. So interdisciplinary treatment, as you all are aware, is the treatment which involves multiple service providers working together to achieve the common goal. For example, I'm an orthodontist, I'm working with general dentists, endodontists, periodontists, etc. That becomes an example. But there is difference between multidisciplinary and interdisciplinary. As you must be aware, multidisciplinary draws knowledge from different disciplines but stays within their boundaries. They work differently on a same patient. But interdisciplinary analyzes, synthesizes, and harmonizes the link between disciplines into a more coordinated and coherent whole. So if you look at these pictures, there are different disciplines for multidisciplinary, but they are not working together, but one by one their action comes into, their service comes into action, but in interdisciplinary it is working coherently. There is one more terminology called transdisciplinary. In transdisciplinary, you are working beyond your boundaries, like Sharda University, beyond boundaries. So I'm orthodontist, I'm even working for like oral pathology. I may be diagnosing the case using such devices as just shown before. I may be working as a general dentist. I may be doing some general dentistry work, bridge work, etc., implant work, etc. That is transdisciplinary. So what I'm most interested about, what I most practice is interdisciplinary, and I also suggest for the same. According to a research, a little old research, but this gives an idea about the distribution of interdisciplinary involvement in adult patients. In their practice, solo ortho group was about 25%, dual specialty group was about 45%, and multiple specialty group was about 25%. And within the dual specialty group, ortho resto was 30%, ortho perio was 8%, ortho surgery was about 7%. So this gives us frequency of distribution of work in the Western world. So there are many articles from Indian authors itself regarding the how to optimize interdisciplinary orthodontics, what is interdisciplinary orthodontics, a review, interdisciplinary therapy, overview, etc. There are many review articles, but there are very few systematic reviews on this subject. So interdisciplinary orthodontics and adult orthodontics is very interrelated. Interdisciplinary orthodontics is closely related to adult orthodontics as there is increased population of aged people seeking solutions for a secondary malocclusion. So what is secondary malocclusion now? It is the consequence of age-related changes on our dentition, or these are the changes locally due to tooth wear, tooth loss, parental disease, etc. And there are populations, age population, who are seeking the solutions for these problems. So the trend of adult orthodontics is increasing day by day. So in US, 27% of the orthodontic patients comprise adult patients. In our context, in Nepal context, about 23% are already the adult population. It was published in our journal. So what are the perceptions and practice of adult orthodontics? According to our scenario, adults have better perception and practice towards orthodontic treatment in all categories or parameter studies. There was a significant difference in practice of food restriction and appliance care by the adults compared to young ones. And many other Western journals also says the same. Adult patients were highly satisfied with orthodontic treatment. Significant increase in self-esteem and quality of life occurred in adults due to orthodontic treatment. So how is adult orthodontic treatment different from adolescent? The adult orthodontic treatment, most of the time it's interdisciplinary, it's more realistic. General health is a major concern here. Resto periostatus is a major concern here. Appliance selection is most of the time is aesthetic. Appliance tolerance is, however, delayed. And they give you high motivation and appreciation to the operator. And however, they may have some high demand from your treatment, and you need long-term or permanent retention for these patients. So there are some issues with orthodontic treatment, like systemic health, psychosocial factors, treatment duration, they want as short as possible, absence of growth, tissue response, parental issues, root resorption, and gaining of the anchorage in orthodontic treatment among the adults. So about the biological consideration, they lack growth potential, so you cannot use the growth modification. It is limited to orthodontic tooth movement only. They have dense cortical bone. Vascularity of alveolar bone is less. Low cellular response, and center of resistance is shifted more apically. And according to literatures, there is issues of root resorption. About periodontal considerations, most of them might have increased prevalence of periodontal problems, decreased alveolar bone height due to periodontal support, reduced periodontal support, increased root resorption. Period problems needs to be controlled before the orthodontic treatment gets started, and light force is desired. According to the studies, periodontal outcomes in adults were similar compared to young groups. So it is a good news for us. There is no association found between any type of malocclusion and root resorption in adults. Again, another good news. About the time duration, the Western journals says that no significant difference between adult and adolescent in time duration, and also the result is same in Nepalese population, which we had done a study. There was no significant difference between the treatment duration among these groups. For orthodontic considerations for adult, we seldom extract classical first premolar. Most of the times extraction is prevented. So we use bondable tubes rather than molar bands on molars because of parental health issues. Segment IPR or anchor. Or the adults orthodontic goal is again not ideal occlusion. It is for disease control or restoration of function. It is indicated mainly for cosmetic or aesthetic or interdisciplinary purpose. Types of problems would be incisor alignment, intrusion, extrusion, molar uprighting, space redistribution. Extent is most of the time segmental, not the whole arch, not the both arch. Treatment duration would be as less as up to 6 months, little more sometimes. The goal of orthodontic treatments is to enhance aesthetics, achieve perio or restorative treatment goal, upright, improve axial inclination of teeth, achieve parallelism of abutment teeth, and improve vertical root proportion, and of course in interdisciplinary approach. So there are many scope for interdisciplinary orthodontics, like patients with mutilated dentition, congenital defects, severe jaw discrepancies, periodontal problems, pathologic migrations, abraded or worn teeth, old failing restorations, multiple edentulous spaces, transmigrated and tipped teeth. So these all have the scope for interdisciplinary orthodontic treatment. So this is a chain you list. Gingival recontouring, as shown in this figure. The smile has enhanced. The patient on the left side is now a model, popular in Nepal. Another is air hostess. Gingival recontouring we do a lot. In this case, you can also see some relapse of the gingivectomy. Sometimes it needs to be done again. So we use both lasers as well as electrocautery for these purposes. And such cases in adults are also interested these days for orthodontic treatment, a comprehensive orthodontic treatment with recontouring, with restorations, making a better smile in a female of 44 years, a typical Nepali woman. So many periodontal cases also are treated along with orthodontic treatment that will give you a better support, that will give you a better aesthetics and function. Many a times we require frenectomy after the space closure, especially the diastema. This again is done either with electrocautery or lasers. Here again, I need the support of periodontists. I do not do other disciplines. I do not touch. I do only orthodontics. Even for the placement of minor implants, I ask other disciplines because it is their boundaries, but we work together. The frenectomy case. The next is crown lengthening with restoration. It is a segmental orthodontic treatment of fractured case where crown lengthening, otherwise the restoration would not have been that better. We would not get that good predial effect. Again, the crown fracture case. So crown lengthening was done with segmental ortho. Here osseous recontouring was also required, a minor surgical procedure. Then crown restoration was done on both teeth. In adults, we have such mutilated cases who are also interested for minor orthodontic treatment for alignment. With RPD was used on the lower arch, not a very healthy oral hygiene and oral health, but later it improved on mutilated cases, I can say. Another mutilated cases of late 30s male who also wanted to correct the dentition. with light force orthodontic treatment. Later, the edentulous spaces were treated with implant by our implantologists. So I was also working to provide him a good space for placing the implant. So this becomes the interdisciplinary management of the complete case. Parental treatment was also done, segmental flaps were done, gingivectomies were also done. So this was the case of ectodermal dysplasia. Right from the diagnosis from oral pathology department, we had started treating this case. Hypohidrotic type of ectodermal dysplasia, which was evident on her palms, on her hairs, and the dentition were conical like this with lot of spaces, and space redistribution was required for placing any dentures. So we treated this case comprehensively, starting with light orthodontic forces for space redistribution, then bridge work on the upper dentition, and in the lower dentition hardly she had any teeth. In the posterior, anterior it was oligodontia at the anterior segment, and it was done with the precision attachment cast partial denture in the lower by our prosthodontist. So I even asked my oral surgeon or general dentist for any tooth extraction as simple as this, a single tooth extraction in the lower arch. So these case reports were published in Nepal Orthodontic Journal, a case of multidisciplinary rehabilitation in ectodermal dysplasia which was presented, and also a case of class 1 malocclusion with lower incisor extraction. So many a times a single tooth extraction in a lower arch, lower incisor, it prevents the extraction of all 4 premolar. If it is supported by facial profile, if it is supported by a dentition, then we seldom use these type of modalities also. So this female had 39 years old female had generalized spacing and which was closed with consolidation loop mechanics, non extraction treatment with orthodontic, and later some spaces were closed by composites. Parental health was restored with periodontist. Many times we have peck-shaped laterals, we have discolored, traumatized teeth, we need crown restorations, we need the service of general dentist or the conservative dentist. I'm lucky to have my wife as conservative dentist, works very close together. It is I guess it is a good combination, but you can have only wife, fortunately or unfortunately, but you can have a team members as many as you like, prosthodontist, oral surgeon, even periodontist, etc. Space redistribution again, she had missing lateral incisors. Canine was pushed to its space at canine space. Then bridge work was done. It was porcelain fused to metal bridge. She was quite a young lady of 20s. And this case again had missing canines. And after orthodontic space redistribution, bridge work was done. And this guy, young adult, had multiple spacings and missing teeth. And after space redistribution with orthodontic treatment, he had zirconia crown and bridge, almost the whole mouth. We also do total mouth rehabilitation whenever required, ortho assisted also. And lower anteriors, missing teeth, and these are, here you can see 2 cases. Here again, first space redistribution with ortho, then bridge work. So in this case, lateral incisor was missing, and we made a good space with orthodontic, driftodontics you can call. Then we had a implant placement, a narrow implant for the narrow edentulous space. So with this, I would like to conclude my presentation. An individualized custom-made treatment plan according to patient's need and condition is essential for a proper outcome in adult orthodontics. The treatment plan should be formulated on the basis of careful evaluation of psychosocial, even economical, biological, mechanical factors with interdisciplinary movement. And as Henry Ford says, coming together is a beginning, keeping together is a progress, and working together is a success. Thank you. And you have been celebrating 75 years of independence of your country, and I would also share this prestigious and glorious moment, and I would also like to state that it is exactly 75 years when Nepal and India had a diplomatic ties in the same year during 1947. Thank you.
Thank you so much, sir, for such an informative lecture. Now, I would like to request everyone to please stay here and wait for a few minutes for inauguration ceremony. Before inauguration ceremony, we have felicitation of our speakers and one more lecture ahead. Then inauguration ceremony will be done. For felicitation, I would like to invite Dr. Anmol Bagaria ma'am and Dr. Ashish sir for felicitation of Dr. Preeti Sharma ma'am. Now I would like to invite Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir and Dr. Siddharth M sir for felicitation of Dr. Preeti Sharma ma'am. Now I would like to invite Dr. Sanjeev Salaria sir for felicitation. Thank you so much, sir. Now I would like to invite Dr. Rabindra Man sir for felicitation. Thank you so much, sir. Now we have one more lecture before inauguration ceremony. Now, I would like to invite Dr. Vinayaka M. Sir, a national and international speaker with the subject expertise of laser, local drug delivery, nanotechnology, and regenerative periodontology, with a 32 national and international publication. Sir also is a fellow of International Congress of Oral Implantology, World Clinical Laser Institute USA, Laser India Academy, Academy of General Education Manipal. Sir is presently working as PhD scholar at Unipova University, Mangaluru, Karnataka. I welcome you, sir.
Good afternoon, one and all. I want you to come little bit, front side, so we can talk. Can you please do the honors, my dear students? Can you please come down, or else I should come up? Come down. Yes. Okay, today we are going to discuss little bit about the lasers in terms of periodontal therapy. Yeah. So this is about me, little bit intro about that. Okay, these are the contents. And what is laser? Everybody does know that it's an acronym, substitutes with. What is L stands for? What is L stands for? Yes, it is light amplification by, it's already there, you can just read it up. Okay, stimulated emission of radiation. So we should know a little bit about the history, right? So how does this laser came up into the dentistry? From the broad spectrum to the narrow spectrum in terms of the specialty. So it all started from the year 1917. Okay, from the Albert Einstein. He is the father of lasers because he invented. So like that the era goes on, followed by different techniques in the lasers from the room size to the pen size. Now the laser what we are using is literally like a pen. Rather than using such a modular systems, we are having such a precise systems nowadays. So how does this laser act? Because it is a light, hence it does contain electron or photon. What does that light contain? Photon. So once the light is reflected on any sort of surfaces, it could be a skin, it could be a mucosa, the four different reactions we are going to see. First is, yeah, louder, louder, yes. If the light or the photon is absorbed by the cell, it is absorption. What if it is encompasses from the cellular body? It is transmission. Once the emission happened and it surpasses the body and it is translocated, it is transmission. Next, what if does this surface doesn't alter all these things? So it acts as a mirror and scatters. And what is this last one? It's a reflection. In the cellular plane level only, it does. So just observe this diagram. This is the different cellular levels with the different nanometers, that is 445 nanometer, 520 nanometer and 638. The depth of penetration is always directly proportional to the number of wavelength. As the wavelength is increasing, you can see the penetration. It is deeper going into the connective tissues from the epithelium. So, as I already explained, these are the 4 reactions we does see in the cellular level. So now everybody will be having that question, does this laser burn all the tissues or the area to be targeted? And if does, and how so? The main property of the laser is selective photothermolysis. So, what is selective? Here, the selective means a chromophore only and not the surrounding tissue. Can you just come across any sorts of chromophores in the body or the oral cavity? Anybody? Starts from M, ends by N, S melanin, something which is there in the blood, hemoglobin. Okay, this is the main 2 components or the chromophores which makes it very selective. So what is, now we'll break down the photothermolysis. If you see what is photo, here the pigments absorb the light or the photons. What is thermo? Absorb light, here transfer to the heat energy. Here the light energy is converting into the heat energy. And what is lysis? It's a heat invaded or oriented destruction of the cell. This is the main process of the laser to be enact, that is selective photothermolysis. The whole 2 words describe the whole mechanism of action of the lasers. So, you people all know what are the parts of periodontium? Anybody? There are 4. My dear students, you should speak. This is for you guys only. What is the parts of periodontium? Yeah.
So gingiva, cementum, PDL, and alveolar bone.
Can you segregate 2 types of tissues from this 4? That is 2 hard tissue and 2 soft tissue. Okay, the 2 soft tissues here are gingiva and periodontal ligament. Hard tissue is cementum and alveolar bone. Likewise, we have different lasers for the different cellularity or the tissues. Hard tissues lasers, soft tissue lasers. And another set of classification in periodontics, it is high power lasers and low power lasers. Now we'll discuss what are these high power lasers. Amongst, we have carbon dioxide laser, diode laser, Nd:YAG, yttrium-YAG, then mixture of yttrium, chromium, YSCG. So what are these lasers does, especially these high power lasers? We already mentioned it promote hemostasis and we can perform excisional biopsies. Here we can sort a hemostasis. If you are doing in a very conventional method or the traditional method with scalpels or the cautery, there will be a charring, there will be excessive bleeding in terms of dealing with the vascular lesions. So coming on to the therapeutical approach in sort of periodontics, that is non-surgical periodontal therapy where all the undergrads will be trained with scaling. Okay, in that we do use 2 sorts of lasers. One is the diode laser and Nd:YAG laser. So what does it give the beneficiary effects apart from the conventional scaling, root planing or ozone therapy nowadays, which has been introduced? So it helps in the removal of the sulcular epithelium of the periodontal pocket. That means sulcular debridement. We are removing some sort of debris which is attached with a periodontal apparatus via lasers. Then reduction of periodontopathic bacteria. Can you name any of the periodontal bacteria? Yeah. Agrigotibacter actinomycetum comitans, A. Then PG, Porphyromonas gingivalis. These bacteria are pigmented. These pigments makes them to get under the photothermolysis. It is selectively induced. We'll discuss later on. And another set of lasers is RBM AG and RBM chromium OSCG. You can note down all these energy, time, pulse, depending on the procedure, this modulation of the working mechanism does changes. Okay. Then coming on to the surgical approach, what are the things we can perform by having this approach? First, we can do the frenolectomy, then gingival contour for the gummy smiles, gingivectomy, then flap deepthalizations, then biopsies, which we already discussed, and so on. So, what is the concept of this low-level lasers? Now we discuss like high-level lasers. Yeah, there is a high volts we will be using in the high-level lasers because there will be a need to cut or to lyse. But in terms of low-level lasers, we no need to do that. Here, one is inhibition or the reduction. These two capacitance we are going to utilize by having a concept called PBM, photobiomodulation therapy. So you can see, we can do two things here. One, we can do bone repair and the reduction in pain. So how does this happen? Because we are having a nerves which is engulfed along with the periodontal apparatus. These nerves does absorb certain set of photonic energy that intend to be reduction of pain or the bone repair, depending on the cellularity what we are going to expose. So there is another concept called antimicrobial photodynamic therapy. What we can achieve from this? It is reduction of microorganisms and initial non-surgical or surgical periodontal treatment or alternative in the maintenance therapy. These are the settings for those. So before using that, we need to have some sort of safety measures. Why we need safety measures in terms of lasers? Because it's a high intensive light amplification mode of the device. If you turn to be not with the safety measures, you might lose your vision. That's how. And our safety measures for the dental lasers belongs to the class 4. That is hazards for the direct and diffuse vision, in addition for the fire hazard. So these are the set of precautions. So I want to conclude my lecture before jumping into my case series by saying this statement: laser and periodontal treatment, is it an effective treatment or a science fiction? Keep exploring your lasers in your clinics or in your future clinical perspectives for my students. This is a debatable concept yet. Thank you. Now we can go for our case series. We have certain cases which I have performed, so we'll discuss one by one. Yeah. Okay. Okay. The first case is what, my dear students, can you read the heading? Aesthetic crown lengthening. Have you heard about that? How many interns are there in the house? Internees? Yeah. At least in the final year periodontal exams or some sort of things. You might have heard this prostoperio relationship also, where the crown lengthening procedures will be done. So what is basically crown lengthening? Can you just brief? Just in general.
So to increase the length of the crown for aesthetic purpose.
So with the common sense, isn't it? Hence the title, crown lengthening. You're going to increase the crown height. For what? There is one law for it. Starts from A. Yes, Antes law. If it doesn't determine the proper or the ideal crown or root propositions, your process is going to be wait today or tomorrow, but for sure. So what you're seeing in the first picture there, like this, can you see the gingiva is in uniform architecture? There is a variance, there is enlargements, there is discrepancies in the soft tissue. Can anybody say what is this instrument called as, which you are measuring? Anybody? Any postgraduates? Anybody know? It's called as choose gauge, spelling CHU''S, choose gauge. So it is prepared with the concept of golden proportion. You might have ended up reading back then in your second year, isn't it? Yeah. So what does it do? It mainly concentrates on the sextants, that is the 6 anterior teeth for the aesthetic smile design. So what we are doing here is taking the ideal measurement. Each color, this blue, red and black, indicates incisors, matlab, central incisors, lateral incisor and canines. So what we are using here, the laser is diode laser. Okay. Can you see the pre-op and the post-op? This is all, these three pictures are the immediate post-op, and we have been followed up for 1 month. That is the case. Then similar case with a different patient. Can you observe the difference in the case if possible? Can you observe the difference in the case projected there? This is also same case of a disproportion of the soft tissue in the collateral sides. So we have took the measurements, we are doing the laser crown lengthening using the diode lasers. Yeah, can you see the difference now? What we had and what we have achieved here, isn't it? So this is laser assisted depigmentation. As I told you already, the chromophores are very important ingredients or the elements to achieve the laser's real action. So once you are saying there is a pigmentation, that means there is an ample amount of viability of melanin. So it is very easy to bombard those melanin by using this photonic energy of lasers. So we have done the depigmentation. Can you see the pigments here? Melanin pigmentation. So we are using the diode lasers again, and we can achieve this. But this depigmentation process doesn't last for long. It could come up for around 8 to 12 months. Again, if the patient intends to be done, you have to repeat the cycle. So this was one of the student only. He got this neurolemoma of the tongue. So we just excised because there is a lesion to be appeared on tongue. But it turned to be neurolemoma after having the immunohistochemistry and the HND. And coming on to the laser gingivectomy. Sometimes during the orthodontic therapy, due to the excessive force and the patients not managing the oral hygiene, we does get to see the enlargements. So you can see there is a Bokenkamp's grade 2 enlargement here, and we have been excised, and this is the immediate post-op. And this is again one of the case for the crown lengthening for the prosthetic procedures. Then this is for the abscess drainage. You can even do the abscess drainage by tracking the sinus via lasers. Then gingivoplasty, then phenectomies. Most commonly pre-ortho or the immediate post-ortho we does perform. If we are doing under the conventional traditional scalpel surgeries, we does do get the scars which intends the forces. Another case for the laser gingivectomy. Then it's the operculum. We have excised the operculum here. There is a evident operculum you can see and being relieved via lasers. Same another operculum case. Thank you. Before ending, I just want to show you one of my working space video. Not this.
Another banger, baby, calm down, calm down. Yo, this your body, it puts in my heart for lockdown, oh lockdown. Yo, you sweet life, phantom, phantom. If I tell you say I love you, you know they for me, young girl, oh young girl. No, tell me no, 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 oh, 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 oh. Baby, come give me your lo, 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 oh, 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 oh. You got me like. Le corps est aussi beau que l'arbre, que l'aurore. Encore tu pleures pour une histoire de love. Ils vont encore dire que t'as qui ne parle que d'amour, ou d'amour, mais c'est toi qui demandes.
This is my college space and my clinical spaces where we have performed the biolaser, so the diode lasers.
Bird machine. Check.
Thank you one and all for the patient listening. Hope you imbibe a little bit of the knowledge towards the laser. Laser is really vast, my dear undergrads. You do come across once you touch into the practice. So it's still a long way to go. And thank you for patients listening once again.
Thank you so much, Dr. Vinayak sir, for a wonderful presentation. Now it's time for inauguration ceremony, so we have to wait for 5 minutes.
Good afternoon, everyone. Warm greetings of the day to all the ones present here with us today. It is indeed a pleasure to have you all as a spectator for the event of the conference today. I, Dr. Anam Siddiqui, your Master of Ceremony for today, would like to extend my gratitude to everyone who is a part of today's schedule and our guest at the present conference's location. On behalf of the whole team of CynoDent, I would like to extend a hearty welcome to all our respected dignitaries present here with us today for our conference. We are extremely delighted that your presence is going to be a moment worth appreciating and remembering as a part of this conference. We welcome you all to the 7th World Dental Sciences and Oral Health Conference organized by CynoDent International and Indian Society of Dentistry in collaboration with School of Dental Sciences, Sharda University and International College of Dentists, ICD. Once again, I would like to acknowledge the theme of our conference, and that has always been to bring in the future of dentistry now and beyond, to the reach of all in every possible being associated with the respective field and the same genre, that is medical and dental sciences, and this has been our most important trait since our first conference from the day one till today. CynoDent has been organizing conferences each year for you all with the same motive and trying out different approaches by amplifying its actions each time in each conference that is organized under our brand name. To revise with the schedule of this conference, on 30th and 31st March, we had our pre-conference courses which consisted of lectures by a respected eminent speakers across India, along with workshop and hands-on for our dear delegates. On 1st April, that is today, and tomorrow, we are going to continue with our lectures by our eminent guest speakers and keynote speakers who are not only specialized in their genre, but also a guide for their students and fellows of the fraternity. Along with this, we continued with our online scientific presentations, which has been going on since the last 2 days and will be continued for the ongoing days. Not only this, today in the evening, we are going to have our much awaited award ceremony, that is World Dental Excellence Awards, honoring legends of dentistry since time immemorial. And yes, not to forget, along with all the award ceremony, a special cultural program with various performances by dedicated performers will take place as a part of the conference this evening. I bet you all will be excited for the end of the evening, which will end with a blast, that is a DJ night, and all this will be conducted in the name of Cynophoria by CynoDent Conference. So can you all imagine all this being held in a single day with all the preparation and just for all you? The list of events being conducted in this conference from 30th March to 3rd April does not end here. On 2nd April, there is extended lectures followed by valedictory function in the evening, and the valedictory function is much awaited by our physical and digital delegates who eagerly wait for the results of their hard work and performances. On 3rd April, we will have post-conference courses that will mark the end of our conference. Hence, CynoDent International is a wholesome package filled with not only academic but fun and entertainment for all our dear delegates. In all, it's a journey, a scientific extravaganza in order to enhance the knowledge and skills of students, the budding dentists, the faculties, the clinicians, basically interaction within the people from the same fraternity in order to take our community to higher grounds each day. Now let's talk about the place where we all are present today, Sharda University. Sharda University, with its sprawling campus, is among the 7 prestigious institutions in India and has been a source of global learning since 1996. It is indeed a pleasure for everyone here to be associated with a world-ranked university providing world-class amenities. The university is popularly known by its slogan, "The world is here, where are you?" And indeed, the world is here. This collaboration has proved as a life-changing memory because of the presence of experts present within this university who left no stones unturned for the welfare of their delegates and students and all the guests. So without taking much of your time and further ado, it is time for the inauguration ceremony in the presence of respected dignitaries and dear delegates. Let's start the ceremony with the welcome dance, and I would request all the performers to please come forward for the welcome dance. Please give them a big round of applause. I would request the coordinator to please switch on the music for the dance.
Gurur Brahma Gurur Brahma Gurur Vishnu Gurur Devo Maheshwara Gurur Sakshat Parabrahma Tasmai Shri Guruve Namaha Tasmai Shri Guruve Namaha Tasmai Shri Guruve Namaha. Gajananam Bhuta Ganadi Sevitam Kapita Jambu Phalasara Bhakshitam Umasutam Shoka Vinashakaranam Namami Vigneshwara Pada Pankajam
सरर होलिका जले शत्रु राह में मिले हमने जब जब शमशीरे ताने है माहे भवानी हम सब मर्द मावड़े बड़े खुददार हैं अब हर एक दिन स्वराज का त्योहार है अब ये शीश ना झुके तेरी लाज हम रखे तेरे चरण की शपथ माँ जगदम्बे है माहे भवानी रोशनी भरी है दान दिया भक्ति का दान दिया शक्ति का तूने ही तो झोलियां भरी
जो भी बरसो बरसो तरसी थी आई न होठों पे हंसी अम्बे माता तेरी कृपा से मेरे घर में आई खुशी
हम चट्टान से डटे कभी ना राह से हटे हमने बात यही मन में डाले है माया भवानी सरर होलिका जले शत्रु राह में मिले हम अपने जब जब शमशीरें ताने है माए भवानी
Thank you for the wonderful performance. Now it's time to invite our respected dignitaries on the stage. And before inviting them to the stage, I would like to give a little bit of introduction for our respected dignitaries. First of all, we have with us here today Dr. Pavitra Rastogi sir, who is the DCI President UP, who has been the Professor KGMC, the Deputy Registrar KGMC, and the Senior Fellow of ICD. We are very delighted to have you here with us, sir. Then we have another very senior fellow of dentistry with us here today. And sir, it is a proud moment for all of us to have you here with us. And that is none other than Dr. D.N. Kapoor, sir. He is a legendary orthodontist. He is the ex-dean of KGMC and a regent ICD. We are very delighted to have you here with us, sir. Please give a round of applause for sir. Then we have a fellow of Sharda University itself here with us, Dr. M. Siddharth sir. He is the Dean, SDS and Sharda University. Another two very important members of the conference, that is, they actually do not need any introduction, but again I would like to state their designations. Dr. Anmol Bagaria ma'am, the founder and CEO of CynoDent International, the president of Indian Society of Dentistry, and the pillar of CynoDent. Please give a round of applause for ma'am. And then we have Dr. Ashish Chandra sir, the co-director of CynoDent International, the vice president of Indian Society of Dentistry, and the senior fellow of International College of Dentists. Please give a round of applause for sir, ma'am, and all our respected dignitaries, along with the dean sir of Sharda University. Now, before proceeding to the lamp lighting ceremony and before inviting the dignitaries on the stage, I would like to invite Dr. Shivangi Gaur, a fellow from Sharda University itself, to introduce the dignitaries. I would request Drishti Sarangi and Disha Sarangi to please come forward for the lamp lighting ceremony. They are going to sing for us all today. Hello, hello.
Sharda
Thank you, Disha and Drishti. Now, along with the introduction of our fellows, I would also like to introduce, actually it's my immense pleasure to introduce you all with our international guest speakers of the day who have traveled all the way from abroad to India to attend and to be a part of CynoDent conference. We welcome you, sir and ma'am. And a little bit introduction of sir and ma'am would be Professor Dr. Rabindra Man Shresht. He has completed MDS Orthodontics from the University of Philippines in 2004 and BDS from SDM Dental College, Dharwad, Karnataka in 1996. He is working as the principal in Kantipur Dental College and member of Faculty Board of Kathmandu University. He is currently serving as the president of Nepal Association for Dental Research and Pierre Foucault Academy Nepal section. He has served as the president of Orthodontic and Dentofacial Orthopedic Association of Nepal, and he is the general secretary of Nepal Dental Association and executive member of Nepal Medical Council. We are very glad to have you on stage today. Next, we have Dr. Lamara Arons and Dr. Lina Shalil ma'am with us. They have come from Israel to join the CynoDent conference. A little bit introduction is they have been working with 30 dentists for about 5 years, specializing in facial aesthetics, and they are the members of Women in Dentistry in Israel. They are also going to give lectures after the inauguration ceremony. So I would again like to welcome all our respected dignitaries who are present on the dais, and I would request all of you to please give a round of applause for the dignitaries here. Now I would invite Dr. Shivangi Gaur ma'am, a fellow from Sharda University, to introduce the guests from the Sharda University.
Good afternoon, everyone. I am Dr. Shivangi Gaur, Assistant Professor from the Department of Oral and Maxillofacial Surgery, Sharda University. It is my immense privilege and pleasure to welcome you all to 7th World Dental Sciences and Oral Health Conference hosted by School of Dental Sciences, Sharda University. Sharda University is a NAC A+ accredited multidisciplinary leading educational institution providing world-class education since the year 1996. The name of the university, Sharda, is synonymous to the goddess of knowledge and learning, Saraswati. She is identified with a veena, an Indian musical instrument, and the lotus where she resides. The lotus, as you can see in our logo, symbolizes the seat of learning that the university is created for. A variety of colors signify the variety of disciplines that the university offers, and the overlap between these petals create new colors, which symbolizes the collaboration between students and teachers of different programs, nationality, color, and creed working towards creating an ambient atmosphere of knowledge. Sharda University is the largest educational group in Uttar Pradesh, having 13,000 plus students and 900 plus faculty. We have 23,000 plus faculty and alumni who are leaders in their own realms, and students from more than 95 countries, making us a truly global educational institution with state-of-the-art campuses in Agra, Mathura, and Greater Noida. Spread across a sprawling 63 acres with 3.5 million square feet of infrastructure and a 1,200-bedded multi-speciality hospital, we cater to the needs of the people around the state. Under the aegis of our leading visionary, Shri P.K. Gupta Sir, Honorable Chancellor, Sharda University, and Chairman, Sharda Group of Institutions, we have successfully established roots across various disciplines of education, healthcare, information technology, hospitality, and skill development, to name a few. Sir is a recipient of the distinguished award called Uday Ratna Award, Uttar Pradesh Ratna Award, Gaurav Shri Award for Entrepreneurship from the Alumni Association of Agra University, Best Educational Award from the Federation of Educational Publisher in India, A noteworthy mention would be to Sir's devotion towards his mother, Swargiya Srimati Sharda Gupta ji, who inspired him to grant scholarships to meritorious underprivileged girls. He is a man of distinct vision and illuminating ideas, an idol of knowledge, experience, and inspiration to us all. It is also my proud privilege to share with you the vision and message of our Honorable Pro-Chancellor, Sir, and Vice Chairman Sharda Group of Institutions, Sri Y.K. Gupta, Sir, who believes an investment in higher education is a life-changing decision that will promote one's career growth. An astute visionary, he is a renowned educationist, social leader, and industrialist. On behalf of the Sharda family, I extend a warm welcome to all dignitaries, all speakers, and delegates. Welcome all.
Thank you, ma'am. After the introduction of Sharda University, I would like to introduce a bit about CynoDent International. CynoDent and ISD was founded by Dr. Anmol Bagaria and is headquartered in Mumbai, Maharashtra. Our national, state, college teams are spanned all across the country and are led by our very diligent board of directors. We also have a team of eminent international and national speakers. Our patrons and advisors include the very renowned Dr. Stephen Cohen, Dr. James Gutman, and Dr. D.N. Kapoor, sir, who is present here with us today. CynoDent soon expanded to 20 countries across the globe, and today, with the blessings of Almighty, ladies and gentlemen, CynoDent International stands rock solid with members from 70 leading countries of the world. Our purpose here is to address global health issues, increase awareness about patient safety, create opportunities for dental and medical professionals, and very importantly, to reduce the gap between research and clinics. We share this with immense pride that we at CynoDent are a global organization serving more than 50 million medical and healthcare professionals around the world. We believe in putting our best foot forward for the welfare of humanity by sharing knowledge and granting assistance in the very finest way that is possible. We publish high-impact journals, newsletters, magazines, and papers every year. Our very committed team of scientists, medical professionals, and clinicians across all specialties work day in and day out to transform bold ideas into sustainable realities, which most definitely will make this world a better place to live in. CynoDent has also launched a unique digital healthcare platform, which is the first of its type in India, and we are also working for social welfare and humanity to enhance the quality of life by providing healthcare services, raising the awareness among youth, and providing free treatments to many. We have done 100+ camps with completely free of cost treatment. We have trained 500 ASHA workers and have also organized blood donation camps. Also, we have launched Oral Health Program 2022 with a vision to spread awareness all around the country. Also collaborated internationally with WHO, UNICEF, and UNDP. We have done 200+ free webinars for young doctors to update their knowledge and skills. We have launched the textbooks of Grossman and periodontology on our platform. We have patents, we have copyrights, we have books and scientific papers and what not to our credit. We have organized multiple international conferences this year to the sharing of knowledge regarding the recent advancements and the state-of-the-art technology, so that the lag between the research and clinical application reduces and better care is provided by our patients and to the patients. We have also collaborated with international universities for scientific program and community services. But ladies and gentlemen, अभी तो असली मंजिल पाना बाकी है, अभी तो हौसलों का इम्तिहान बाकी है, अभी तो तोली है मुट्ठी भर जमीन हमने, तोलना अभी सारा जहान बाकी है. We promise to serve you with the best of our abilities for the time to come, and it's an eternal bond that we share, a bond so beautifully nurtured that there shall be no longer a bond than this. Now I'll proceed with the speeches by our respected dignitaries. And firstly, I would like to invite Dr. M. Siddharth Sir, Dean, School of Dental Sciences, Sharda University, to address the audience with a few words. Welcome, sir.
Good afternoon, everyone. Respected Dr. Pavitra Rastogi, Professor, Department of Periodontology, Deputy Registrar, KGMU, Faculty of Dental Sciences, KGMU, and President, UP State Dental Council, Dr. D.N. Kapoor, former Dean, Faculty of Dental Sciences, KGMU, Senior Orthodontist, and Regent of International College of Dentists, Dr. Ravindra M. Shrestha from Nepal, Dr. Lina Sharel from Israel, Dr. Lamara Arens from Israel, Dr. Anmol Bagaria, CEO of CynoDent, Dr. Ashish Chandra, also a pillar of CynoDent, Dr. Sukhdeep Singh, Chairman Organizing Secretary of this conference, Dr. Nitin Bhagat, Co-Organizing Secretary of this conference, all Dr. Sangeeta Talwar Madam, Dean of Maulana Azad Institute of Dental Sciences, eminent faculty members, eminent speakers, all heads of departments, students, and my dear friends. On behalf of Sharda University, CynoDent, and ICD, I would like to extend a very warm welcome to all of you to the 7th World Dental Sciences and Oral Health Conference. The 7th World Dental Sciences and Oral Health Conference promises to be a grand event in dentistry. There are more than 100 national and international speakers, over 800 to 1,000 registered delegates, and the conferences has already been started with pre-conference courses from 30th March, 31st March, the conference on 1st and 2nd, and post-conference course on the 3rd of April. Once again, I would like to thank the members of the organizing committee from School of Dental Sciences, Sharda University, CynoDent, Indian Society of Dentistry, and International College of Dentists for organizing this wonderful program. Thank you.
Thank you, sir, for your kind words. Now I would request Dr. Ashish Chandra, sir, to please address the audience with his few words.
A very good afternoon, everyone. I, Dr. Ashish Chand, extend my warm greetings to you at 7th World Dental Sciences and Oral Health Conference. I welcome the dignitaries on the dais. Guest of eminence today, Dr. D.N. Kapoor, sir. Sir is the regent of ICD. The chief guest of today's program, Dr. Pavitra Rastogi, sir. Sir is the DCI President, Uttar Pradesh. Dr. M. Siddharth, sir, Dean, School of Dental Sciences, Sharda University. Dr. Anmol Bagaria, CEO and founder, CynoDent International. I also like to welcome our international speakers, Dr. Lina Shalel, Dr. Lamara Arens, and Dr. Ravindra Shrestha, sir, from Nepal. This conference is organized by CynoDent International and Indian Society of Dentistry in collaboration with School of Dental Sciences, Sharda University, and International College of Dentists, USA. I welcome all our national and international speakers and the delegates who have made a lot of efforts to make this possible. CynoDent has served you selflessly for 6 glorious years today, and we again are here to your service as we embark upon this beautiful week full of learning and sharing. We started with 2 days of extensive learning with pre-conference courses, which include certified hands-on courses on facial aesthetics, lasers, rotary endo, CBCT, trichology, tobacco cessation, aligners, and many more. And today we are officially inaugurating our conference, where we are having from morning the scientific sessions and lectures by eminent speakers. And not just that, to acknowledge and honor the warriors of dentistry, we have the National Dentist Awards recognizing and honoring dentists across the globe. So gear up yourself because there's a lot we have to offer and a lot you have to gain. And I again on behalf of Team CynoDent International commit to continue to serve you in the coming years as well. I wish you all the good time with us. Thank you.
Thank you, sir. Now I would request Dr. Rabind Manshresh, sir, who has come here all the way from Nepal to attend the conference, and I would like to invite sir for his few words and to address the audience.
Respected dignitaries on dais, a beautiful audience, it is my pleasure to stand in front of you in this prestigious World Dental Science Oral Health Conference. So this is my second appearance in this World Dental Science and Oral Health Conference organized by CynoDent. This time there is Sharda University and ICT involved. Being also a fellow of International College of Dentists, I take privilege and thank D.N. Kapoor sir for me to allow to participate in this conference at this high level. So I have found that CynoDent conference has really improved a lot from the previous conferences that I witnessed. It has definitely worked very hard and it is working into very finer details. The hospitality offered and the content of this conference is very fine, what I have witnessed. So I would also like to invite CynoDent and this team sometime in my country in Nepal to organize such a conference which will benefit the faculties, the students, the postgraduate students in my country. So I look forward to work with this team. Also, I would like to have long relationship with Sharda University, which is a leading organization. Professor D.N. Kapoor is from my own faculty. I'm very happy to know with him and have a personal touch with sir. And our Israeli guests, they are very humble. Yesterday, we had a very good time together at different places of Delhi, including Lal Killa and India Gate. And my humble appreciation to parents of Dr. Anmol Bagaria, and lastly but not least, Anmol Bagaria. She has been very energetic and she deserves a big applause. Thank you, team, and thank you, good audience.
Thank you, sir. Now I would request Dr. Leena Shalil ma'am, who has come all the way from Israel to attend the conference. We are really glad to have you here on stage, ma'am, and I would request you to please address the audience.
Good afternoon. It is an honor to be here in India. Thank you very much, Dr. Anmol. Thank you all very much to be here in Sharda University for the 7th World Dental Science and Oral Health Conference. It's truly a big honor to be here, and we are very glad to share all our knowledge with the future of the dentistry. And thank you for being here. Thank you for your audience. Thank you for the best hospitality. India is beautiful. Delhi is beautiful. And thank you for everything. And I hope that you will enjoy our lecture also after that. We will speak about the future in the dentistry that we think that me and my sister, she will introduce herself. Also, we will speak about the aesthetics, and it is very important that the aesthetics will be a part of the dentistry that should be studied in every dental university in the world. Thank you very much.
Thank you, ma'am. Now I would like to request Dr. Lamara Arons, ma'am. She has also come from Israel and she's here to attend the conference for all of us. And I would like ma'am to please address the audience. Thank you.
Hello, everybody. Hello, our dear colleagues, our friends. India is really our friends. We have been here several times, and now we are proud, and it's our honor to be here among you as speakers. My sister Lina is my sister. We work together, and now we specialize in dentistry also and all facial aesthetics. So thank you very much to the University Sharda, to all dear friends and colleagues, all the professors, all that they invited us, and it's a big pleasure to be here. Thank you. And after that, we'll continue with our lecture, and we invite all of you to be part of all of our knowledge, and not like a professor or something, as friends. Because whatever you'll need, whatever everybody need, it's very important to share worldwide. Lina and me, we are also a part of almost established the women in dentistry. Wow, it is worldwide also. It began from Canada. In Israel, we have very big, huge participants. We were last time in Abu Dhabi, and now we are in India. So thank you very much, and we are very glad to be here among you. Thank you.
Now it's time to felicitate our respected dignitary. Firstly, I would like to call upon Dr. Pavitra Rastogi sir, who is the chief guest for the evening. And as I have all Before the felicitation, I would like to invite Dr. D.N. Kapoor sir on stage to address the audience, and sir, we are eagerly waiting for your precious words.
Good afternoon, everyone. On behalf of the International College of Dentists and on behalf of the Sharda University and our CynoDent India, the sponsor of this conference, welcome you all to this august body. This 7th World International Conference is being organized by CynoDent, which is primarily playing a very important role in development and making you all equipped with today's scenario, how well we are developed and how well we can organize ourselves, what all you can achieve and what is available in the market. So Pandara is before you. You have to commit yourself to the belongingness of the profession. If you belong to the profession, you can enrich yourself to the maximum in my humble advice to all young dental surgeons, professional colleagues coming for a specialty is that you belong to the institution, you belong to your profession, and you develop your institution, you develop your profession, and give whatever you best you have at your level. Whatever I am, I've learned from my institution, I have learned from different countries and at different platforms. I'm equipped not in one day. It is a process which you have to imbibe as a constant source of learning. Unless you develop this habit of learning daily with different sources, you cannot equip yourself. So, my dear friends, I have nothing more to it. But if I trace the history of the development of dentistry in India, I started my dentistry in foot engine. Nobody can believe that there was a time when we were trained to do the junior operative procedures of cutting and preparing cavity through the foot engine. Then the time came that we developed electric engine. Furthermore, the motor, air motor. Now, in today's scenario, you have availability of everything that you think in the world, which is available in India, is available outside. You are so well equipped, enriched. So make a dent and advance yourself. These are the words that I would like to say before you. My humble suggestion is to commit yourself and advance, work hard and hard, devote to the extent that you have to work hard. That's it. That's it. That's all I can say.
Thank you, sir. Now we'll start with the felicitation. I would like to invite Dr. Pavitra Rastogi on stage to address the audience.
Thank you, Doctor. First of all, a very, very warm and hearty good afternoon to everyone present in this very beautiful, very vibrant, rainbow-like colors auditorium. Very, very respective dignitaries on the dais, very eminent Emeritus Professor of Dentistry, our ex-Dean, Faculty of Dental Sciences, Teacher of Teachers, Mentor of Mentors, Professor D.N. Kapoor, sir. Professor M. Siddharth, Dean, Sharda University, and very energetic, very dynamic, and very active CynoDent leader, Dr. Anmol Bagaria. Very humble, very hardworking organizing secretary of this conference, Dr. Ashish. From Nepal, Dr. Rabindra. And well, two elegant ladies from Israel, Dr. Lina and Dr. Lamara. Dignitaries of the dais, Madam Professor Sangeeta Talwarji, Mr. and Mrs. Bagaria, my seniors, Dr. Dinesh Baggaji, my senior Madam Poonamji, and the faculty members from the Sharda University and rest faculty members from the other colleges. Few faculty members are from the Subharti. I welcome you all. So first of all, as we all know that we are here for this inauguration ceremony of the 7th World Dental Sciences and Oral Health Conference. This is with the topic that is the bringing the future of dentistry now and beyond. First of all, I must congratulate all the team members of CynoDent and Sharda University for organizing such a beautiful conference, such a big conference of 5 days. So big round of applause for all the team members. I know that is a big team of Team CynoDent works behind this curtain. I think I'm looking Shubham and Prateek, where are they? But the big team is attached for this type of a conference. I must congratulate all the organizers. And as we all know that these all continuing dental education programs are the need of the hour. Because research is the endless search of knowledge. And we all know that the continuing dental education programs to keep update learning. Because we all bound to the code of ethics. And this is the era of evidence-based medicine and evidence-based dentistry. So we are bound to provide the best treatment available for our patients. And what is the best, what best we can provide to our patients? That is the role of ours.
We all are going to become, you are the oral health care providers. You have to learn a lot. Then you can provide the best treatment for your patients. So on behalf of UP State Dental Council, I am very pleased to announce 30 CDE points for this large extravaganza. And one thing I want to tell you to all the students, that everyone wants to become Amitabh Bachchan in his career. But ये कैसे होगा? कैसे बनेंगे हर कोई अपने अपनी फील्ड में अमिताभ बच्चन? तो इसके लिए you have to make a goal. लक्ष्य का निर्धारण बहुत जरूरी होगा, और लक्ष्य को पाने के लिए आपको सबसे पहले एक अच्छा गुरु चाहिए, which provide you the methodology how to get that aim. As we know that is a research methodology, first is aims and objective, and then the methodology. And the methodology is by your guru. And then what is this? The true hard work. Without true hard work, you cannot get the success. So if you want to become the Amitabh Bachchan in your career, you have to make a goal, you have to make a good methodology, and you have to give your true hard work. Then you can do it. Here, this is the 75th Azadi Ka Amrit Mahotsav. And we are in the place of the northern, it's a national capital region. And yesterday we went to the Rashtrapati Bhavan. There's a new central vista is going on. The new project is also going on. So I would like to quote one very eminent, very famous scientist, very famous philanthropist, and our 11th President of India, APJ Abdul Kalam Sahab. He always told that कि सपने वो नहीं होते जो आप सोते समय देखते हैं, सपने वो नहीं होते जो आप सोते समय देखते हैं, सपने वो होते हैं जो आपको सोने नहीं देते. तो गोल करिए, सपना जरूर देखिए, लेकिन आपको ट्रू हार्डशिप के साथ वो सपने पाने हैं. One more thing I want to say, that is the 75th year. When we got the independence in 1947, the average life expectancy of a normal human being of Asia was just 32 years. Just 32 years. And now, after 75 years, and in the census of 2020, the average life expectancy of the normal human being of India is 67 years. That means we achieved 100% life expectancy. But the latest happiness index, which is based on economical, mental, social well-being, which is given by the Nobel laureate Amrit Sen and the Mahbubul Haq from Pakistan. And that happiness index, we are on the level of 136 on 2020 and 126 in 2023. So that means out of 195 registered countries in UN, we are at the level of 136. So that means we are behind the 125 countries. So we have to travel a lot. And we have to travel a lot with all you young bloods. So as we told earlier, a good goal, a good mentor, and a true hardship is the key to success. And this is my concluding words. With this, I want to all of you go with good amount of cognitive domain to increase your knowledge, to increase your affective domain for the better psychomotor skills. Thank you. Thanks a lot.
Thank you, sir. May I request Team CynoDent, who is present on the dais, that is Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir, to now accord memento to our esteemed guests. And also Dr. M. Siddharth sir, Dean Sharda University, to accord memento to our esteemed guests and their felicitation. Dr. D.N. Kapoor sir, who is a legendary orthodontist, and he is the guest of eminence for us here. Sir, we would like to felicitate you today in the presence of all the ones. Please come forward on the stage, sir. Thank you, sir, for being a part of CynoDent conference, and we are delighted to have you here, sir. Now I would request Dr. Anmol Bagaria ma'am and Ashish Chandra sir and Siddharth sir to accord the memento to Dr. Pavitra Rastogi sir. He is the DCI President UP. We are delighted for your presence here with us today, sir. Dr. Rabindra Manshresh sir, who has come all the way from Nepal to attend the conference. Please give a round of applause for everyone. Thank you, sir, for your presence here. Dr. Leena Shalil ma'am, all the way from Israel. After the inauguration, she is going to conduct lectures for us on cosmetology. Dr. Lamara Arens ma'am, she has also joined us from Israel. And they are a pair of specialized dentists in cosmetology. Thank you, sir and ma'am. I would request you all to please take your respective positions on the dais. We would also like to felicitate our media partners for the day, and that is TV7 News Hindi, Beauty Roy from TV7 News Hindi. Times Now Nav Bharat, Gaurav Singh from Times Now Nav Bharat, who is present here with us today right now. That's why we are felicitating you, sir. Thank you for being our media partners. Times Now Nav Bharat, Gaurav Singh, sir. Also, we have on stage Beauty Roy ma'am from TV7 News Hindi. She is also a part of a media partner for the CynoDent conference. And along with this, we have other media partners, that is Ankita Yadav from FM News and Jartantra TV, that is Vikas Belwal from Jartantra TV, and Kanchan Banerjee from Onkar News. I would request those who are present here to please come on stage and collect your memento. Once again, I would like to take the name of our media partners: Beauty Roy from TV7 News Hindi, Kanchan Banerjee from Onkar News, Ankita Yadav from FM News, Times Now Navbharat, Gaurav Singh, Jartantra TV, Vikas Bailwal. I would request the respected dignitaries to please the respected dignitaries to take your positions on the dais. Thank you, sir and ma'am. Now I would request Dr. Anmol Bagaria ma'am to deliver the vote of thanks and to address the audience.
Good afternoon, everyone. Warm greetings to one and all. Firstly, I would like to thank God for blessing us with His choices blessings, and my parents for their love and support. I once again welcome you all to the 7th World Dental Sciences and Oral Health Conference. Thank you all for giving us your valuable time, trust and support. I wish to extend my heartfelt gratitude to those who have made this possible. I would like to thank firstly all the organizing committee members of CynoDent, ISD, Sharda University and ICD. I would extend my heartfelt gratitude to all the dignitaries on the dais who have graced this occasion and inaugurated our conference today. Dr. Pavitra Rastogi sir, thank you sir for giving us your valuable time. Thank you for your support always. Our very own Dr. D.N. Kapoor sir, our international guests Dr. Rabindra, Dr. Leena, Dr. Lamara, thank you for traveling and thank you for coming to India. Dr. Siddharth sir, Dean School of Dental Sciences, Sharda University, thank you sir for your support. Dr. Ashish Chandra, Organizing Secretary of the conference, thank you for your patience and thank you for your support and thank you for being the pillar of CynoDent. I thank all the audience for gracing the occasion and thank you for your presence. I would also extend my thanks to all the faculty members, UG students, PG students and all the heads of the department for being the part of organizing committee and for helping us out. I once again thank the entire working committee of who have worked day in and day out. I also thank all our speakers who have taken out time from their busy schedules and made it here. A big thank you to all my dear delegates, students who have trusted us and joined us today. I thank all the speakers, clinicians, academicians who have joined us to enhance their knowledge and skills. I promise you the same these 2 days. Sorry if I have missed any name. I am highly thankful to one and all. And I'm sorry if I have missed any name because I'm handling so many things, so it might have skipped out of my mind. Thank you once again for being there with us and giving us your valuable time. Wish you a happy day and happy conference ahead. Thank you everyone.
Thank you, ma'am. Now I would request all of you to stand up for the national anthem.
हिमाचल यमुना गंगा उच्छल जगति तरंगा तव शुभ नाम
Thank you, sir and ma'am, and all the ones who are present here with us today. I would request all our dear delegates to proceed for lunch. And this is the end of the inauguration ceremony, and we'll be meeting soon after lunch.
After that, okay. Yes, they will get something. Yes. They will do some journey. They will do some journey. So the time I will do that. And you point to everything like that. Point to there is column also, there is line also. Yes. So whatever. Yes. If you have so Mr. Yeah, I know. Yeah, I got you. Empire. Empire. אני גם רוצה לפני.
all the facial aesthetic, we can add the facial because when we studied dentistry, we study almost 4 years. Last 4 years we are studying the anatomy of the facial and everything that is combined with the face. So we can combine everything to improve the aesthetic of all the face and the teeth also.
Hello everybody, nice to meet you again. As my sister Lina told you, we are specialists in dentistry and now in facial aesthetics. We know that when the patient comes, never mind it's a lady or a female or a man, everybody needs, they come for two purposes. One, if they have a pain, and the second one for the aesthetic issue. And and the aesthetic issue, it's always combined with the dentistry and the whole vision of the face. We know that by the years, everybody lose the quantity of collagen in our tissue, the fat we lose. So by the age and by the time, all the tissue, all the face becomes old. That's why we have all the skills now and all the opportunities to make it better. In nowadays, everything goes, the worldwide science and everything goes to be very holistic. And we combine the skin structure to rejuvenation and to refill the volumes that we lose with the time. This is my first study case. When a patient, you see, she is a young lady. She is 55 years old. But when she came to me, immediately I imagined that she has no dentistry, and also she came here to me for the wrinkles, for the nasolabial. When I examined her, I told her that only this, it's not sufficient for you. You must go also to treat we have to make everything, to combine everything, all the treatment. The teeth, of course, absolutely, and also to regenerate your face by combination of biostimulators for the skin structure and the fillers for the to fill the volume that you lose by the time. And after four months of treatment, the lady now, after 4 months, the lady becomes this. We treated the total syringe of hyaluronic acid, Profilo and Jalupro. They are my best friends, best skills for the skin rejuvenation and peeling also, of course. And the treatment areas were the temples filling, face frame filling, cheekbones highlighting, and the construction of the contour of the face. So immediately she changed her, the whole face changed, and she became younger, more happier, and etc. Other study, this is our indications where we are when young, everything in its own place, all the fat shoulders, the collagen, etc. We are when we are a big older, everything. This is our changes. Mature moment. This is. When we lose the volume of the face, we lose from the temples, and after that the frame of the face, and all this, the nasolabial, the marionettes, we lose, but we have many skills now to regeneration everything. We have lots of skills I use and we use in our clinics, all the materials of biostimulators. After that, skin boosters, they are combined with amino acids. We use the peelings that BioRepeal is very good. It has a very good effect on the face, and of course the hyaluronic acid to make the volumes when we when we lose the fat. This is study number 2. 62 years lady. I used 10 syringe of hyaluronic acid, temples filling, face frame filling, cheekbones highlighting, nasolabial and marionette filling, and in combination with products for firming the skin texture, Profilo and Jalopro, that they are the biostimulating for the skin. This lady is also 73 years old. Also, all the rejuvenation with 8 syringe of hyaluronic acid, temples filling, face framing filling, cheekbones highlighting, nasolabial and marionette filling, and in combination of 3 biostimulators and skin boosters treatment. These are our best skills. This here also, she is a 50-year-old patient, came to me without, she lost everything. She didn't have teeth, she didn't have volume, she didn't have anything. After 3 or 4 months, we restructured everything. It was, I used 12 syringe of hyaluronic acid, temples filling, face frame filling, cheekbones highlighting, nasolabial and marionette filling, and in combination of in products of firming the skin texture, Profilo, Jalopro, and peeling. So our colleagues, we'd like very much to share everything with you if you like. Here with this lady, I combine also the full face regeneration, but also with the series of 4 chin fat lipo. She had here the fat of a double chin, and I made for her a series of 4 treatment, lipolysis treatment. Lipolysis, it means when you have a fat here and you want to melt it, we use it's a new system of hyaluronic acid, but especially for melting the fat. So this is the effect after 4 months.
So now we have trend on the young woman nowadays. They don't have so much losses of the fat compartments or collagen tissue or elastin, but nowadays with all the media and all the they are all looking, the young ladies, they are all looking young, and the older ladies, they are all looking to look better. And there are a lot of treatments that are fashionating trends now, like lip reshape volume or nose sculpting without operation. And the top model full face treatment, that it means cheekbones, jawline, and everyone wants to be like models. They are coming at our clinic. We have 4 clinics in Israel in different cities, and they are coming and they are looking to be beautiful ladies, and we hope that we are helping them with this. And also for them we have skin texture, post-acne, pigmentation, post-pregnancy hormonal changes, and biostimulations, and we also always explain them at if we begin now when they are young, if we begin to treat the skin as younger they are, they will restore their skin and prevent future sagging and wrinkles. Sorry, we are a little bit excited. So, when they come for lip treatments, they don't. Many of the patients, they don't look at. They don't think that they have gummy smiles, and we as dentists, we always look at their at their teeth, and we suggest them, of course, the lips, to combine the lips together with the gummy smile treatment that we treat with Botox, 2 little points of Botox. We treat the gummy smile, and they have a new smile. Nose reshaping with hyaluronic acid in 15 minutes in our cabinet without any surgery, without download time. Here we can look on young lady. On the upper photo, she is before the nose job. And after that, after 15 minutes, we can see that she looks totally different. She has a nose approximately like after an operation. And they are very happy because we can treat them without operation. And we combine it with chin fillers also. And this young lady looks very pretty after that. They are all the day sending us pictures and selfies, how beautiful they are and how happy they are with a new nose, chin, and lips. Here we can see a lady, that young lady, she came. She didn't observe that she had a problem with a masseter. And we as dentists, I immediately, when looked at her, she wanted to make a Botox, and only a Botox. I immediately told her, I asked her if she has a problem with the masseter. And she told me that, yes, she has headaches. I immediately, of course, suggested to her to make some Botox here, to slim her face, to refill the temples and Botox. And now she looks much younger, much slimmer, and healthier. Of course. Here we have a top model look. Young lady that she came and she told me, you know, Dr. Lina, I'm not, sometimes I don't understand what they want, the patients. But she told me, you know, when I'm making a selfie, I feel that I have a little bit round face and I don't like it. I would like to be some more reshaped the face, jawline to make it shaper. So we made top model treatment, cheekbones, jawline, and this is how she looks. This is how she looks. 2 weeks later, she sent me her selfie. She is modeling in Israel, and she told me that she got a very big campaign after the treatment because, yes. Here we can see a lip augmentation. We combined it. I approximately always combine lips with lip whitening. I'm explaining them, the young ladies, that it is a better look to combine it to combine everything together. And this is how she looks, happy and smiling. Here also, here we have a dentist's case. Here we have in the left side veneers and lip augmentation after that, and here, as we told, the gummy smile and whitening of the teeth. And now about men, not only women, we are treating women, also men can also treat, and it is very, in nowadays, it is now important and popular men to be treated also to keep their young look. This is our world tripping. We are studying all over the world new combinations, new treatments, new methods, and we hope that we are doing well with the patients.
Thank you very much. Now we are happy to be here among you. And we all invite you also, always in Israel, always we are coming here, and worldwide we always meet our friends, our colleagues, and we are very happy to be here. And we always go to all the new experience when we have the opportunity. So this time it is in India, and thank you very much, and shalom from Israel. Thank you.
Thank you so much, ma'am, for wonderful presentation. Now, I would like to invite Dr. Sangeeta Talwar, ma'am. She is the Director Principal of Maulana Azad Institute of Dental Sciences, New Delhi. And her topic of today's session is Dental Technology Innovations, Roadmap Ahead. I would like to invite ma'am on the stage.
Good afternoon, ladies and gentlemen. At the outset, I would wish to thank the organizers of this international conference for giving this opportunity to me to speak on this forum. I will present before you dental technology innovations, the road ahead. I'm Dr. Sangeeta Talwar from Maulana Azad Institute of Dental Sciences. Now, in this slide, we see how is India rising. India is the 5th largest in the world by GDP. What is GDP? It is the, I'm sure everyone knows, it is the gross domestic product, and it is indicated in US dollars. That is the benchmark for the global economies. It is, our country is the 3rd largest in purchasing power parity. It is the 19th largest exporter and 10th largest importer. So we need to export more and import less. And as far as the economic growth is concerned, it was 8.7% in 21-22. Industrial production in India increased by 5.2% year by year in January 2023. That is following a 4.3 rise in 1 month in December, that is 1 month as compared to 1 month ago. And the output from manufacturing sector increased by 3.7, mining was 8.7, electricity 12.7. Therefore, the industrial production went up by 5.4%. Now, the healthcare in India is growing in leaps and bounds. You can see the Indian healthcare industry is expected to reach US dollars 372 billions by 22-23 this year. The e-health market is estimated to reach 10.6 billion by 2025. The hospital services industry is expected to be worth 132 billions by 2023, and the Indian diagnostic services market is expected to grow, touching 20 billions by 2026 as compared to 10 billions in 2021. So what is the global dental industry market share? North America accounts for most of the market, and Asia Pacific, of which we are a part, is projected to exhibit the highest CAGR during the review period. CAGR is the annual, compound annual growth rate, and this is the annual average rate of revenue growth between 2 consecutive years. Now, dental industry market share. In this, we can see the global market, dental market share of CAGR of 5% in 5 years. And the Asian market is showing a highest growth of 10%, out of which the US, that means India is showing a highest growth of 10%. And US is almost half that of the Asian market. That means we are comparing Indian, our country, with the US, which would be at a rate of 5.5%. Now this, you can see the market share in India. India's economic growth has been accelerating even in the times of recession. And the Indian dental market, this is in $1 million. In 2022, you can see it is $653 million. And the projected, that means after 8 years, in 2030, it is $1,339 million. So the forecast is that CAGR is going to grow at the rate of 8.7%. Now this is the dental market. In India, we have about 5,000 dental laboratories and 313 dental schools. As of 2017, the overall market size of Indian dental market was $2 billion US, and it is expected to grow at CAGR, as I mentioned before, at the rate of 6.97%. This is the distribution of dental manpower in India. The population of dentists, the total number of registered dentists in our country is 2,78,076 currently. The present dentist population ratio is 1:4975, and very meager dental auxiliaries at 6605. So these are the most important impacting factors within a period of about 6 to 7 years, from 2016 to 2023. Now what are they? There has been growth in dental tourism in India due to low cost, and in our country, the quality treatment at low cost is available. Then there's rise in investment with increased focus on establishing multi-specialty hospitals. Then there's demand for cosmetic procedures, which is increasing rapidly, but there's low awareness related to importance of oral health. There's scarcity of trained dental professionals, and major opportunities are available due to high potential in untapped rural areas. We all know we all want to practice in metros and urban areas. So definitely rural areas need to be tapped as far as the dental expertise is concerned. Then there's rise in focus of multinationals. A lot of investment is coming in from multinationals in our country. This is the further scope of dental industry in our country. Indian market presents a very lucrative and diverse opportunity as far as the exporters and importers with the right products and the service provision, as well as the commitment is concerned. And healthcare outsourcing of services to healthcare providers, this is expected to increase from 334.2 to 756 in 2030. That is a period of about 9 to 10 years. So what are the opportunities and implications? There is targeted approach with focus on urban and semi-urban cities. Then establishment of laboratory chains with quality controls. We have to create opportunities for better provision, service provision through exclusive dental equipment and maintenance companies. All of us who are in institutions and as well as we are practicing, we know how difficult it is to get our equipment's maintenance done. Then there is foreign direct investment. That means investment is coming from international sectors. And most important, very important, is the integration of dental education and industry. A collaboration between the academia and the industry is very, very important to take the innovations and self-sufficiency of India forward. So we here see that the market trends predict that India is all set to become the single largest consumer for dental products and materials globally in the coming times. So where lies the lacunae? This is the lacunae that about 85% of India's annual requirement, it is supplied by other countries. Everything comes from consumables and equipments. Everything is imported, mainly coming from Germany, US, Italy, Japan, and China. These are the imported dental products. You can see dental chairs. You can see the educational products which are there. So many equipments, everything is imported. So what is the need for dental technology? our PM's, India PM's Atmanirbhar Bharat, this is a step towards self-reliant India. And there are 5 pillars of self-reliance in our country. First is economy, infrastructure, demography, system, and the demand. So the need of the hour as of today is that we should start manufacturing dental material, not only materials, we need self-sufficiency for manufacturing of equipments, materials, everything ourselves. So as I said before, a collaboration between the academia and industry is very, very important. Industry expectations from academia, that is one thing that has to be taken care of. And similarly, academia, that means the institutions, they expect certain services from the industry. So what the industry expects from academia is, as you can see, market-aligned courses, develop skilled manpower, solutions for concerns, and operational approach. Whereas what the institutions expect is the funding and the infrastructure, equal partnership, placements, and feasible goals. Unless these go hand in hand, this is the basic requirement from the institutions or academia and the industry partnership for our country to move forward as far as innovations are concerned. So our goal is let's get it done together. That is the goal. That should be the goal. So I work in Maulana Azad Institute of Dental Sciences, and this concept of dental hub, it was conceptualized about 2 years back in 2021. And the meeting, this was participated by MAIDS, that is a short form of Maulana Azad Institute of Dental Sciences, Delhi Technical University, and Department of Science and Technology. This proposal was submitted to Department of Science and Technology, and unless these are on the right side you can see these are the functions of a hub, that is assess the need of such facility. What is a dental hub? These are the functions of a dental hub: identification of problem statements, then constitution of advisory panel, establishing and circulation of thrust areas, setting up of collaborations, review of received proposals from academia and industry. For this, any hub to be successful, we need at least 4 bodies on the same platform. That is, your dental experts have to be there. Then we need the industry partners. Then we have the technical partners and the funding agency. These are the 4 bodies that have to be there on the same platform. This proposal was submitted to Department of Science and Technology, and I'm happy to inform that yesterday only the go-ahead and sanction came from Department of Science and Technology, Government of India. So this is the hub's collaboration network with academic institution of India, that is technical and dental. And collaboration from technical institutes is very important, like the IITs, IIITs, Institute of Indian Institute of Science, Bangalore. So these are the objectives of Dental Technology Innovation Hub. Now, MAIDS has been declared as the first dental technology innovation hub of the country. And the objectives are resource. It is acting as a resource center for dental technology innovation. It is an active facilitator because the awareness for IPR, that is your patents and as well as regulatory clearances, because the awareness is low and help is required. Then it acts as a training center. Introduction of products, then for product translation, that means for the market, whatever help required for the product to go into the market, then centralized testing and calibration, then Indian industry startups, this is for approvals from DGCI, then education of young. These are all the objectives of this hub. And this hub would also assist the government funding agencies on any kind of proposal which is coming to the government funding agencies. So this dental technology hub India, as I said, is just starting today. And the focus, this is the first phase of dental technology innovation hub. We can see the proposals which have been sanctioned. They have already been sanctioned as of today. One comes from Indian Institute of Technology, IIT Delhi. It is on antimicrobial wall coverings and coatings, and the domain is material development. Savita Institute of Medical and Technical Services. It is design, construction, and validation of digital stomatogram, and the domain is dental equipment development. Third is A.B. Shetty Memorial Institute of Dental Sciences. It is magnesium phosphate-based bioceramic composite, and domain is material development. IIT Mumbai, development of indigenous zirconium oxide material, and the domain is material development. Then we have M.A. Rangoon Wala Dental College and Hospital in Pune, development of device for down packing of gutta percha into root canals, and the domain is dental equipment development. Then we have Guru Gobind Singh Indraprasth University, New Delhi. This is artificial intelligence based tool for automated comparison of photos and cars, and domain is AI toolkit development. Then we have Maulana Azad Institute of Dental Sciences and Delhi Technical University. We have fabrication of ultrasound based instrument retrieval unit and pulp vitality tester. The domain is dental equipment development. So as the saying goes by this great scientist Albert Einstein, the distinction between the past, present and future is that we have to stubbornly follow our persistent illusion unless that becomes a reality. So innovations in dentistry. Very briefly, we have the artificial intelligence, and this AI, it analyzes health data, research findings, treatment techniques to provide diagnostic and therapeutic recommendation for patients. As compared the human intelligence, it will, we as humans, we perceive the problem, interpret, and whatever the result we think as human beings, as compared to AI. So one example of artificial intelligence is this tooth-C, and the material that is used for these clear aligners, they are US FDA based. They are invisible, affordable, and comfortable. Tooth-C, it's a clear aligner used in orthodontics. Augmented reality, this is actually projected. This helps the patient to know what they will look after, like after the treatment. And technology is more prevalent in reconstructive and aesthetic procedures, for example, smile designing. One example is the Smart Tech and Kapanu. This is augmented reality app, and it depicts the improved set. As I said, it is a projected reality, and it depicts the improved set of teeth prior to the procedure. This is for patient education. Virtual reality as compared to, this is actually a 3D effect. It is based on 3D concept, and it will provide distraction for the patient while the treatment is on. For example, for patient management. Now CRISPR, this is a revolutionary gene editing method, It is basically the researchers are conducting studies to isolate and switch off oral cancer associated gene and to alter the function of bacteria responsible for plaque formation. Once the functioning is altered, plaque formation will automatically decrease. That is the purpose. Then robotics in dentistry, everyone is familiar. It can enhance accuracy, precision, and workflows. The applications are given below: the filling, oral prophylaxis, extraction, and so many simulated trainings. Now, this robos, they are used in conjunction with 3D navigation, and they can be used for invasive dental procedures. Then robotic oral and maxillofacial surgery, they have become an attractive possibility, especially in treatment of oropharyngeal carcinoma. And this is the clinical application. And for clinicians, as far as dentistry, usual in prosthodontics, tooth preparation for crown and bridge, it is a routine, but it is still challenging even after years of clinical application experience. This is ultra realistic dental training robo, and you can see this picture on the right side. This is a realistic dental patient, and the robo can blink, cough, sneak, known as hanakutu from Japan, and shut her mouth, turn her head as if reacting in pain, and has a gag reflex, can respond to some voice commands also. So MAIDS is a center of excellence, and the initiatives for indigenous dental technology development till now include an implant system, then a Pitt and Fisher sealant, ultrasonic based instrument retrieval system, and a low level laser therapy device. These are some of the patent dental technologies by the institute: a Pitt and Fisher sealant, non-contact type ultrasound to detect separated instrument and tooth during root canal. This is the patent application number. A novel screw type dental implant, and cold laser oral therapeutic device. The application number is given. So the best way we all can say is, well, to be on the lighter side, to predict the future, we have to really create it. So the way forward in innovation in dental sciences is, this hub has already been created, and it is open to all, for everyone to apply in it. Thank you so much.
Thank you, ma'am, for the wonderful lecture. I would now request Dr. Anmol Bagaria, ma'am, Dr. Ashish Chandra, sir, and Dr. Amit Bhardwaj, sir, to please come on stage for the felicitation of our guest speakers. And Dr. Imran Khan, sir, also. So please come on the stage and join for the felicitation. Now I would like to invite Dr. Sangeeta Talwar ma'am on stage. Thank you, ma'am, for your presence here, and the lecture was very guiding. Thank you, ma'am. Next, I would like to invite Dr. Vinayak AM sir on stage and would like him to come on stage and get felicitated for his lecture today.
Is it in the right?
It's not in the right place. Try one. You were operating this?
Now I would request Dr. Anmol Bagaria ma'am and Dr. Amit Bhardwaj sir to please come on stage to felicitate our international guest speakers of the day. Dr. Leena Sanil ma'am and Dr. Lamara Aaron ma'am. I would request Dr. Ashish Chandra sir to join them on the stage, please. Thank you, sir and ma'am. Now we'll proceed further with the lectures. I would request the operator to please switch on the PowerPoint.
Now, I would like to invite Dr. Imran Khan sir. He is the professor of oral and maxillofacial surgery at Jamia Millia Islamia University, Delhi. Topic of his presentation is Role of Total Joint Replacement in TMJ Ankylosis. I would like to invite sir on the stage.
Hello. Hello.
Hello, I think I'm audible. Yeah, thank you so much. At the outset, let me thank Team CynoDent, Dr. Anmol and the Sharda University, and my good friend Dr. Rohit Punga and the team here from the oral surgery to get me here to speak on this topic. So, greetings from the Faculty of Dentistry, Jamia Millia Islamia. This is my workplace, and I would be speaking on role of total joint replacement in TN joint ankylosis. Now, what is an ankylosis? Ankylosis is basically a Greek word which means stiff joint. It is defined as a bony or a fibrous adhesion of the anatomic joint components to the adjacent anatomical structures, causing limitation in opening of the mouth, causing difficulties with mastication, speaking and oral hygiene, as well as inadvertently influencing the mandibular growth. Now, we all know TN joint ankylosis has been classified as fibrous or bony depending on the degree of involvement, whether it's a fibrous one, whether it's a bony one, whether it is unilateral, whether it is bilateral, or whether it's partial or complete. We have a classic article by Soni et al. In the year 1986. He classified ankylosis into 4 types grossly, basically on the degree of mouth opening and involvement of joint. Like type 1 would be where we can see the discal space, basically there is joint space can be seen, and there is a limited movement also. In type 2 we have a fibrous union, and as well as the medial side is slightly free of the condyle. Type 3 and type 4 there is a full bony chunk and there is no mobility or movement. What causes ankylosis is a big question. It's 99.9% it is trauma. Trauma can be because of, in the childhood or in the adulthood, when the patient or the person falls, have a chin injury or has a direct injury to the joint or the indirect injury to the chin. Infections such as osteomyelitis, infection to the ear are also known to cause TM joint ankylosis. Few inflammatory causes, systemic diseases are also known to lead to ankylosis, such as rheumatoid arthritis, ankylosing spondylosis. And there is a rare cause also given by, there was one published report given by Wright GW, where he has given a bilateral temporomandibular joint ankylosis after bimaxillary surgery. So this is also one of the reasons. The patient of TMJ ankylosis will come to you. We have oral surgery residents here. Most of them will, come to you like this. Okay, they'll try to open their mouth, but they are not able to open the mouth. Okay, they would have functional problems, of course, but when you talk to them, you'll realize they will also have some psychological problems also, because the kids, the smaller patients in particular, will be too shy to speak out. Actually, they would be introvert, so there would be psychological problem, and also they would be having problems such as sleep apnea. The quality of life is completely altered for these patients. So along with the functional problems, these are also the problems which a TM joint ankylosis patient will have. Now, what are the management options, current management options for TM joint ankylosis? Now, depending on what stage the patient has had ankylosis, the treatment options may vary. Now, this is a patient of a growing age, teenage patient, but she is not having any significant facial disfigurement. So, a simple maybe what do you call gap arthroplasty or an interpositional arthroplasty may help her. But whereas same patient, teenage patient, but a morbid facial disfigurement. Okay, there is a significant occlusal cant as seen in the picture here. One side jaw is elongated, another side jaw is not grown up. So this shows a facial disfigurement. So for a, and of course this is an adult patient having ankylosis complete, but there is no facial disfigurement. So treatment for all these categories of patient may vary. What I mean to say is different stage requires different surgery depending on when the patient has had the problem. Now, for example, the patient which I just showed here, teenage girl, growing age, but not much of facial deformity, left side bony ankylosis, type 4, standard preauricular incision, standard creation of gap, interposition of the temporalis muscle. Now for the postgraduate, especially here, fat can also be used, abdominal fat, and people have been using it a lot these days. I personally don't have much experience on abdominal fat. I use temporalis because it's from the same incision, but for you preparing for your postgraduate examinations, temporalis, instead of temporalis, you can use lots of abdominal fat, and most of us have lots of abdominal fat here. So you can use it, put it there, patient bhi khush ho jayega ki okay, kuch fat kam ho gaya. So, and this is after a simple interposition arthroplasty, a follow-up after 2 years, and the scar here is negligible. So for people who think there would be a big scar after a Popovich incision, if you know how to close it well, if you know how to define your incision well, you know, a scar is generally not visible. Now for a TM joint ankylosis in a growing patient, in a young boy, say 9, 10 year, 11-year-old boy or a girl, now this picture is from an article by Dr. Balaji et al. Costochondral grafts or CCJs have been, you know, they have shown to be quite effective in especially treating ankylosis. prismatic bent plate sort of a thing, which was not very clear. She was having a plate, probably a possible first surgery, some plastic surgeon put some plate there, and it was distorted. So this is how the stereolithographic model looks like once you prepare a customized joint. It's like this. This is a traditional Popovich incision. Now, specifically for the postgraduates, when you are doing a TJR, you will require an additional submandibular incision. Okay. Now, this incision is to ensure that you insert the ramal component. Okay. So, this one takes care of the ankylosing mass, and this one is for the insertion of the ramal component. Osteoarthrotomy generally is carried out. We create a gap. It can be carried out by a chisel. It can be carried out. I generally do it with a burr, but piezo surgery, if you can afford to have, you have it at your center, is the best. This is the additional submandibular incision which I was talking about. This is how the fossa is adapted, fixed. The ramal component is separately inserted inside by the submandibular incision, and bilateral coronariectomy is also done. I have a small video, if I can just play this. No. No. No, there's some technical, I think, problem. I had a small video specifically for the postgraduates. Can I have some technical team here? Just in case, if we have someone. ये एक वीडियो है इसमें. Okay. Yeah. Folder में जाएंगे एक बार. Yeah. Has the entire folder been copied because वो वीडियो अलग से था. या तो आप उस फोल्डर पे चले जाओगे पेन ड्राइव पे, ये शो पे ये फोल्डर था. या we have a preview. Double click and file. ऑडियो ऑन होगा इसका. एंड ऑडियो भी ऑन. Okay. So I think it's pretty visible. No, it's not visible. It's playing here, so it's not playing there. No, this video is not one. I am playing one video here, which is not being projected there. इधर नहीं आ रहा है video. I have a video actually, which is being played here. We make these videos specifically for these movements. Yeah. So maybe I'll just complete it and maybe just show it. Yeah. Okay, no issues. Okay. इस पे लेकिन कुछ और आ रहा है. आप दिखा. Yeah, so maybe we'll have the video for the later end. So intraoperatively, when you gain a mouth opening,
See, there's a step ladder. In case if you have a mouth opening of 45 millimeters or more after a osteoarthrectomy, you may not require a coronoidectomy, but better you do it. Because you know the coronoids will always impinge, and coronoidectomy can be done via the same incision, or you can do it intraoperatively, intraorally also. I'm sorry, intraorally also. Intraorally, there is one problem. Sometimes the coronoid slips, and you know, once you try to grasp it with your cockers or with your heavy artery, sometimes it slips and you know goes back, retracts it to the ITF or the infratemporal fossa. It is difficult. So better you try to do a coronoidectomy from the same incision, extraoral incision. What I mean to say, I used to do coronoidectomy intraorally also, but many times I could not use retrieve the coronoid process because it used to go up. So coronoidectomy is indicated once your mouth opening is less than 35-40 millimeters, and do a bilateral coronoidectomy also in case if it is less. For the normal side also you can do a coronoidectomy, and make sure your mouth opening or interincisal opening is approximately 50 millimeters intraoperatively. This is how the joint looks like on the post-operative OPG. This the upward component is of the fossa, and then you have the ramal component which is fixed here. And this is the same lady who was doubting us and saying that okay, it will it will again go down. Almost 2.5-3 years now I'm following her up. She has got all her dental treatment done. She has got even a root canal of her posteriors done. With this mouth opening, it is more than 30 millimeters. Happy, doing extremely well. Again, a second case, similar case, again operated I think multiple times before, once in a government setup, twice in a government setup, with a big chunk on the left side. And he must have been, when he reported to us, in his 50s. Okay, again he cannot bite or he cannot open his mouth. Again a standard incision plant. These are the cuts which I was showing you in the pre-op model which we mark. And if you have a piezo, you can actually do a precision cutting thing, because you know the burr which we use, generally that precision cannot be followed. So we used a straight fissure burr, regular straight fissure burr here, 701, 702. And this is the superior cut, this is the inferior cut. We remove the chunk, body chunk, and this is your fossa, which is adapted well, and you can see the ramal component, and down you can see the submandibular incision also. For postgraduates, do remember you have to give an additional submandibular incision to get your ramal component fixed. And this is this guy post-operatively, and we are following him up again for the last I think 3-4 years. In this picture is left coronoid, the actually remnant part of the coronoid, not the coronoid, is still impinging on the maxillary third molar, if you can see it carefully. So the third molar was also removed, and his mouth opening is pretty satisfactory now. So we have done 4 cases in the last I think around 4 years. We have operated on 4 such joints who required total joint replacement. The age group were varying from 27 years to 46 years. 3 were males and 1 was female. The mean interincisal opening before surgery was 2 millimeters, whereas the post-surgery it was 39 millimeters. Follow-up approximately I told you around 4 years now. Major complications was none. Now this is the one people having apprehensions about total joint replacement. This is one good thing which you can actually give to your patient, to improve the quality of life. Now question comes, why TJR? Now in orthopedic surgery, alloplastic joints have been used successfully since decades now, okay, and the functional load on the joint is pretty less than what we have on the knee or on the hip. Considering that fact, you can actually give a biomechanical solution for an ankylotic patient rather than a biological solution. There is ample of literature evidence pointing towards a successful and predictable outcomes for a TJR. The pioneer in India is from AIIMS Delhi, Professor Ajay Roy. In my personal opinion, customized joint are definitely better. They generally take lots of time planning. You have to take out lots of time planning it, but the results are a lot better with a customized joint. So my take-home message for the postgraduate specifically here, that a total joint replacement is recommended or highly recommended for a successful management of TMJ ankylosis, not only in terms of maximal interincisal opening, but also other goals of TMJ ankylosis management, especially in grown-up patients. One lacune, TJR in growing patients or children.
is still a controversy. Okay, people say the best still is costochondral graft. In spite of the fact that it may overgrow, still in children don't go for TJR, try to do for an autogenous graft, that is a CCJ. I would also like to take this opportunity. This year we are hosting this 47th AOMSI conference in Delhi. I would like to request all those who want to register or interested Max Fax surgeon to register for this mega event which is planned. This is my faculty where I work, Faculty of Dentistry, Jamia Millia Islamia. And we have, and you know, the view down in the picture down is of a cricket ground. This is from my actually oral surgery department, which I have taken, so which inspired. I have a star batsman here, Dr. Atriya is here, giving us company. And this is life besides surgery. We play cricket every Sunday, every weekend. And this is one of the winning moments. We won the Jamia Premier League, Faculty of Dentistry. So this is my life besides surgery and academics. Acknowledgements to Dr. Darpan Bhargav from Bhopal, who gets me the joint done. My joints are actually customized by him. And Dr. Anshul, who was with me for the first surgery when I did my first TGR, he accompanied me. So acknowledgements to them. Towards happiness and prosperity, thank you for your patient listening and hearing. If I want to show this videos, can we just, or do I just leave it? No, it's here. It's here. It should be projected here. No, it's there. It's playing here. I mean, it's playing on the laptop right now. Yeah, yeah. So maybe okay. I'll share it with the maybe later on your computer or this thing. Chalo, chodo, sir. Leave it. Forget it. No, I'll be leaving here. I'm fasting, so I have to leave. Okay. So thank you so much. I'll just take out this pen drive.
Thank you, sir, for your lecture. Now I would like to invite the next speaker of the day, and she is Dr. Malika Sethi ma'am. A brief intro of ma'am would be Dr. Malika Sethi graduated from Rajiv Gandhi University of Health Sciences, Karnataka, and thereafter she has completed her post-graduation in the field of periodontics. She is a faculty laser dentistry, and she has done her mastership and diploma in laser dentistry by Society for Oral Laser Applications, affiliated to the University of Vienna. She has been awarded as the Laser Dentist of the Year, the Dental Speaker of the Year in the Asian Pacific Dental Excellence Awards, APDEA 2022, and she has been deliberately going on with the lasers and topics related to periodontology, and has been a guest speaker in prestigious conferences at various national and international conferences. Thank you, ma'am, for coming, for joining us here. Ma'am will be giving a lecture on lasers today, and I would request the IT team or the people who are coordinating with the presentation to please check on the video.
Hello. Hello. वीडियो है वीडियो प्ले कर रही हूँ.
even void कोई मतलब उस प्रेजेंटेशन में ही वो यहाँ पे हो रही थी वहाँ नहीं मैम एक्चुअली स्कूल टेस्ट हो रही थी अभी जो आपका पावर पॉइंट नहीं हो रहा था तो नाउ एटलीस्ट अंडरस्टैंड गई आ जाएगा ठीक है तो हेलो वॉल्यूम ठीक वॉल्यूम रेज करो just tell him to increase the volume put this is it fine I want increased volume आप करवा रहे हैं तो इसमें जब तक इमरान खान सर का वेरिफिकेशन करवा देते हैं हाँ ये बता या श्योर श्योर कह रहे हैं कि पहले स्टेशन करा लो श्योर श्योर या he has done it yeah please फोन आएगा आप कट कर देना आगे से थैंक्स मैम की वीडियो चलाए ना मैम तुमने भैया को बोल के मैम की वीडियो बोल के है फोटो तो वही वीडियो हाँ हो गया ना he has done it yeah he is felicitating him हाँ हाँ यार no problem आशीष है रोहित भी है आत्रिया भी मैं सबको बुला मैं सबको बुला मैं उन दोनों को बुला
Before moving on to the lecture by Dr. Malika ma'am, it's time to felicitate Dr. Imran Khan sir for his lecture today, and I would request Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir, Dr. Athreya Gopal sir, and Dr. Malika ma'am also to felicitate sir. Please give a round of applause for sir. Thank you, sir and ma'am. I would request Dr. Malika ma'am to proceed with her lecture.
Hello. Hello. Well, warm greetings. Good evening, ladies and gentlemen. It is a matter of great pride and proud privilege to be a part of the prestigious 7th World Dental Science and Oral Health Conference organized by CynoDent and in collaboration with International College of Dentists held in this prestigious Sharda University. Well, at the very outset, first of all, I would like to thank the organizers for giving me this opportunity to be here today on this platform. Well, laser is one of the most captivating technologies which has revolutionized several areas of treatment in the last few decades. And today I would be deliberating on the topic laser focused, bringing art to surgical periodontics. So laser, we all know light amplification by stimulated emission of radiation, and when laser strikes the tissue, it can either be reflected, absorbed, scattered or transmitted. As far as the absorption curves of different dental compounds by various wavelengths is concerned, the shorter wavelengths are readily absorbed in pigmented tissue and the blood elements. The diode and the Nd:YAG, they have high affinity for melanin and less interaction with hemoglobin, as you can appreciate there. The longer wavelengths, that is the carbon dioxide and the erbium family, they are more interactive with water and hydroxyapatite. Well, important to remember, laser exerts different tissue effects: photothermal, photochemical, photovaporolysis and biostimulation. And the principal effect of laser is photothermal. Now, as the name suggests, conversion of light into heat, whereas the diode and the Nd:YAG, they have a condition, they create a condition that is known as the hot tip effect. Now, what is this hot tip effect? Basically, the tissue is vaporized and coagulated by the overheated tip rather than the laser energy itself. And these are the different observed effects at different tissue temperatures. Now, talking about lasers in surgical periodontics. So, what is the rationale for therapy? Why do we need to incorporate laser in periodontal practice, especially for surgical procedures? Well, it has potential for root surface decontamination. There is targeted reduction in subgingival bacteria. Suppression of inflammation is another area where laser works. It allows for periodontal regeneration and also helps in biostimulation. Now, discussing about lasers for soft tissue surgery. So, if you look at this tissue specimen treated with laser, the erbium YAG laser results in minimal coagulation, as you can appreciate there. The carbon dioxide results in severe carbonization. With the Nd:YAG, you end up having a thick coagulation layer, and the diode is said to have the greatest coagulation. Therefore, soft tissues are evaporated or incised, leaving different degrees of carbonization, coagulation or vaporization. So, laser helps to cut, ablate or reshape oral soft tissues with no bleeding, no sutures are required. It allows for greater patient comfort and safety when you compare it to electrosurgery. Also, there is minimal scarring whatsoever. No severe pulpal pain, which is reported with electrosurgical procedures. So, laser has all these advantages. Well, I'll walk you through various clinical cases of laser for soft tissue procedure. This first case is a case of drug-induced gingival enlargement. The patient is epileptic and is under anti-epileptic drugs for the last 10 years. Now, this case, external bevel gingivectomy was planned by 3 different methods in 3 different areas on the same day. So, you can appreciate external bevel gingivectomy with a scalpel there. Electrosurgery is used here, and laser, diode laser set at 2.5 watt in contact continuous mode. If you look at the power had to be increased to 2.5 watt. And the initial 7-day healing revealed that the scalpel wounds healed well, followed by laser and then by electrosurgery. Basically, laser and electrosurgery both lead to lateral heat dissipation, but please remember, more with electrosurgery and less with laser. Another case of frenectomy, you can appreciate papillary attachment as classified by Plasek in the year 1974. 940 nanometer diode laser is used here. The first incision is a vertical incision which helps in disruption of the mucosal continuity. Later, a horizontal deeper cut is given to separate the fibers, and you end up having a rhomboidal shape of the frenectomy area. This is at 1 year after treatment. Well, hyperpigmented gingiva is a major aesthetic concern, and laser is used for depigmentation to remove the superficial epithelial lining in short light paint brush stroke in a horizontal fashion. Intermittently, please remember, you have to use gauze dipped in saline to remove the ablated products. My each sentence is very, very important, so please listen to me very, very carefully. Intermittently, gauze dipped in saline is used to remove the ablated products, and this is immediate post-operative at 6 months after treatment. Well, at ITS Dental College, we, especially for this case was subjected to histological analysis, and this is the preoperative dense pigmentation with Mason Fotona stain, and this is the post-operative view at 6 months after treatment. Now, ladies and gentlemen, few important points which I would want to stress here. After laser procedure, no co-pack is required, no antibiotics are required, just plain analgesics would do. Topical application of vitamin E will provide a soothing effect. The patient should be advised to refrain from smoking and consuming spicy food for the first 24 to 48 hours after the procedure. In cases of frenectomy, no sutures are required. Unlike if you do it with a scalpel, you will have to give around 6 to 7 sutures. Important takeaway points as far as wound healing following soft tissue procedures are concerned. Wound healing is slightly delayed. Why? Due to thermal side effects. Secondly, lasers are not employed for incision, their target uses being excision and ablation. Deeply penetrating lasers for periodontal procedures will damage your pulp periosteum, so you can ideally use them where you have bleeding, especially tissues like lip and the tongue. Moving ahead, talking about lasers for surgical pocket treatment. Now, what is the rationale? Rationale is there can be challenges to complete debridement and disinfection of periodontal pocket owing to certain anatomic complexity, due to which the patient is not able to maintain good oral hygiene. Secondly, the clinical attachment level and pocket depth produced by initial therapy may be inadequate for optimum health. Therefore, surgical intervention is required. Well, a case of laser-assisted flap surgery, please remember laser is always used as an adjunct. So, this case, a mucoperiosteal flap is raised. The undersurface of the flap is deepithelialized to create a GTR-like effect. 1.5 watt, each tooth is laced for 20 seconds, and what do you see? That is the post-lacing, this is the pre-lacing. Post-lacing, a light brownish appearance is imparted to the tissue. Important point to remember here, later the epithelium can be ablated after every 7 to 10 days from the outer part of the pocket as well to control epithelial migration, and you end up having a long-term stable connective tissue attachment without any gingival recession, and this forms the basis of what is known as laser-assisted guided tissue regeneration. Well, hard tissue lasers have also been used as an adjunct to flap procedures, and laser can be used for resective and regenerative periodontal treatment. because small contact tips are available which can access deep intra-bony defects as well as furcation areas as stated in many clinical trials, and one such trial is by Nevins in the year 2012, rightly known as LENAP, which utilizes the Nd:YAG laser, and the authors have proved histological evidence of new attachment, that is periodontal regeneration, and they have found out that the mean probing depth reduction is around 5.4 millimeters and clinical attachment level gain of 3.8 millimeters after 9 months of follow-up. Hard tissue lasers also can be combined with various flap procedures for furcation areas for intra-bony defects as stated in many clinical studies by Gasprick, Schwartz et al. And recently by Clem et al. In the year 2021. Important points to remember as far as laser for surgical pocket treatment is concerned. Laser helps in complete debridement of the defect due to ablation effect. There is increased accessibility. Now, out of all the lasers, various authors have stated that erbium YAG laser is found to be the most promising laser device for flap procedures because it helps in granulation tissue removal, allows for new bone formation as well. So what happens if you have thorough granulation tissue removal? You end up having an area, or you have these advantages: high decontamination, increased detoxification efficiency, and you have a blood clot which is formed. Blood clot formation will accelerate your wound healing. Now moving ahead, lasers for osseous procedures, that is for bone surgery. Now if you look at this specimen treated with carbon dioxide, erbium YAG and the burr, carbon dioxide results in visible carbonization, burr results in a groove with a soft tissue remnant which is attached. Erbium YAG laser also results in a groove but with no soft tissue remnant which is attached. So what makes erbium YAG the laser of choice? Basically, this laser provides precise edges without thermal damage. Minimally affected microstructured surface is formed where no toxic substances are encountered. Unlike if you use carbon dioxide, you have cyanamides and cyanates, that is the toxic products which are formed and which are harmful to the tissue. Also, the laser modified layer is said to be mineral rich carbon layer which is formed with laser. Well, a case of bone graft harvesting, this is the preoperative OPG where the mandibular symphysial region is used as the donor site. The recipient site in the frontal maxillary jaw which has deficient bone and which precludes the placement of an immediate implant. Well, the recipient area is perforated. Why? So that you have increased vascularity and also more amount of growth factors at the site. Now, the bone graft is harvested with the erbium YAG laser, a monocortical bone graft. Well, this handpiece is kept at a distance of 10 millimeters from the bone in a non-contact fashion. This is the donor site after block removal, and thereafter it is fixed on and secured with 2 titanium screws. Can you appreciate the edges? They are so precise with the erbium family of laser. Well, decision making on the use of laser for crown lengthening is basically based on the osseous biotype. Hard tissue laser can be used in a closed approach and is ideally indicated for a medium gingival biotype case where the width of the osseous crest is 1 millimeter, 1 to 2 millimeter of bone is removed and the laser should be fired for 1 to 2 seconds. If you have a thick biotype, you end up having a trough or an intra-bony defect. In case if you have a thin biotype, what will happen? You will end up heating the tissue and you will end up having an unpredictable healing response. Well, I would like to show you a video where a hard tissue laser, erbium chromium YSGG, all tissue laser is used for laser assisted flapless crown lengthening. This is very, very interesting. Just have a look at this video. So gummy smile, excessive gingival display, more than 3 millimeters as stated by Ackerman. So the first step is sounding and marking the biologic width. I am sure all of you know what is biologic width. It is a sum total of the connective tissue and the junctional epithelium above the bone. So first step is done under local anesthesia, rightly known as transgingival probing, to feel the topography of the bone. Then gingival ablation is done, as you can appreciate here, with the all tissue laser. Erbium chromium YSGG is used. So you have to preserve the biologic width. If you do not preserve the biologic width, you will end up having inflammation and loss of periodontal support. So the second step, gingival ablation with erbium chromium YSGG. So we are not raising a flap here. It is laser assisted flapless crown lengthening. This is the advantage. Now the third step would be osseous recontouring with the same handpiece. Understood? Subgingival osseous contouring is done, as you can appreciate there, with the same handpiece in a contact mode. So you are reshaping the bone as well. So the first step is sounding, gingival ablation is done. Thereafter, subgingival osseous laser crown lengthening. We have not raised a flap, and just look at the post-operative picture of the patient. This is immediate post-operatively. So basically, all lasers have preset values. Understood? I showed you frenectomy at 0.8 watt. I showed you depigmentation at 0.8. You can increase your power according to your practice. If you encounter a frenum which is thick and fibrotic, please increase it from 0.8 to 1 watt. That totally depends on your practice. Well, I'll walk you through another case of crown lengthening with a soft tissue laser. Epic-X 940 nanometer diode laser is used here. This is the preoperative OPG. Well, she is one of my favorite patients. I have completed the case. She is a doctor, physiotherapist from Gangaram who reported. This is a full mouth rehab case. This is a preoperative OPG. Intentional root canal had to be done for her mandibular anterior. Just look at her teeth. Just see the clinical picture. Crown lengthening was done with a soft tissue laser, 940 nanometers at 1 watt in a pulsed mode. I can set it to continuous also. I can set it to pulsed also. That depends on me. But please remember, if you have a thin, fragile tissue, try to use a pulsed mode rather than a continuous mode. 1.5 watt continuous and 1.5 watt pulsed. Where do you think the energy is more? Obviously, 1.5 continuous, the energy will be more. So, very, very important, rightly said, more than the wavelength, important is controlling your laser parameters. Please remember. Well, I was talking about this case, so composite buildup had to be done for the patient, and this is at 6 months after treatment, full mouth rehab with PFM crowns. So, laser came into practice here because immediately crown lengthening was done and the procedure was very, very quick. The patient was very comfortable. There is absolutely no pain, no blood whatsoever. Yeah, she is a happy patient. Now, important points to remember as far as laser for osseous procedure is concerned. Rotary instruments, they not only cut the tissue, they come in contact with. Lasers cut to an unknown depth away from the application tip. So, depth control is rarely an issue. Damage to the underlying tissues may be avoided by angulating your application tip. Please remember, if you use a hard tissue laser without saline irrigation, you will end up having charring of the tissue. use it with saline irrigation. So the hard tissue laser is already having an inbuilt cooling system, understood? A soft tissue laser, the case which I showed you, you have to use a gauze dipped in saline intermittently. That will prevent your heat buildup. And the last important point is, what is the importance of laser advantage? It reduces noise because it eliminates vibration associated with your mechanical cutting and grinding, and therefore it increases surgical precision and comfort. Well, another treatment modality ideally indicated for class 2 gingival recession. See, my topic is related to surgical periodontics. I can go on and on with laser. I conduct courses on laser, so 3-4 days I can go on, but I have to limit myself for just 30 minutes. Okay. Now, another treatment modality ideally indicated for class 2 gingival recession is the laser assisted laterally positioned flap, and this is the original article by Yilmaz in the year 2014. So the first incision is a horizontal incision in the vestibule, 3 to 5 millimeters from the recession defect. As you can appreciate here, I think the lights are on the slide, so the picture is not very clear. Well, the authors used 3 watt 8110 nanometer diode laser. The second incision is a horizontal oblique incision, and thereafter it is sutured onto the recipient bed. Need not worry about this area, it will heal by itself, and this is at 6 months after treatment. Now, what is the use of laser here? Basically, laser reduces edema, ecchymosis, allows for a passive and relaxed flap. You have decreased tension which is created. So you have maximum augmentation which is achieved, and there if you look at 6 months, there is decreased recession defect and gain in the width of attached gingiva. Now, talking about low level laser treatment in periodontal surgery, well, low level laser, rightly known as class 3 medical devices, or your therapeutic lasers, which they do not cut. There is no incision, but they will provide a non-heating effect, and through this non-heating effect, it will act at the cellular and the molecular level. It will accelerate your wound healing. Well, it has been used in various clinical areas like for TMJ, in periodontitis, in orthodontics to accelerate tooth movement, reduce pain. For lichen planus, I have treated a case of lichen planus with LLLT. It can be used for giving any kind of biostimulation to the area. Now, if I talk about periodontitis, what does LLLT do? So basically, LLLT will stimulate your fibroblasts. It will have an anti-inflammatory effect. It will act on the MMP, especially the MMP8. It will reduce pain post-operatively because it will stabilize your nerve cell membrane. Activation, increased ATP synthesis, therefore acceleration of wound healing takes place. So these are the areas where LLLT works. Now, I'll show you a case of LLLT in the management of intravoni defect. Well, you can appreciate the defect depth measurement as shown with a calibrated periodontal probe. A mucoperiosteal flap is raised. There I can see it is very clear. Here the pictures are not very clear, I don't know why. So 0.5 watt diode laser is used here. Just see the power, 0.5 watt, that means you are giving LLLT. 1 watt, 1.5, 2 watt, that means you are cutting, okay, you are ablating, incision, excision. LLLT will be at 0.5 watt. So LLLT was given here for 2 minutes and the site was laced for 90 seconds. Thereafter, placement of allograft DFBBA was done and sutured. Now, you will ask me, madam, why did you use laser here? I could have used only allograft. See, laser has its own advantages, so why not utilize it? Use laser as an adjunct to any procedure. In this case, laser is used as an adjunct to bone graft, LLLT. Okay, just see the results. This is at 1 year after treatment, and there was a good amount of bone fill which is evident on the radiograph. Now, if I show you here after suturing, please biostimulate the area on the buccal and the lingual flap. So what will happen? You will try to accelerate the healing process. You will make the patient comfortable. There will be less post-operative pain. Repeat the procedure after 24 to 48 hours. Recall the patient and give LLLT, that is at 0.5 watt. Another area where you can give LLLT is whenever you harvest a pre-gingival graft. What do you see? You see profuse bleeding happening. How do you control that bleeding? Just give LLLT on the palatal side and just see the effect. Instant hemostasis is achieved in non-contact mode. Please, LLLT is not given in a contact fashion. Always a non-contact mode is used and the site is laced for 60 seconds. Now, talking about lasers in implants, well, very, very interesting. Why do we need to incorporate lasers in implantology? Firstly, it increases hemostasis. There is reduced infection, minimal damage to the surrounding tissue, reduced swelling and reduced pain. Very, very important point is impressions can be made directly. Please remember, after you do the second stage surgery with laser, if you're doing it with a laser, you can take the impressions directly. Need not wait for a day or two. Unlike if you do with a scalpel, you have to wait. Now, if I compare all the lasers, please remember, diode will not alter your implant surface. The Nd:YAG is a big no because it results in porosity, pitting of the implant surface, right? The erbium YAG laser and carbon dioxide both are good lasers because both are reflected away from the implant surface. So, they are reflected, it will not damage the implant surface. Added advantages of erbium family is it allows for detoxification, has a bactericidal effect, allows for re-osseointegration of the site and allows for greater implant to bone contact. Carbon dioxide is also a good laser, but ladies and gentlemen, please remember, if you use carbon dioxide in a continuous focused mode, you will damage the implant surface. So, always try to use a defocused mode. What do you mean by defocused? Suppose if this is the laser, okay, this is focused, that is the focal point. If I move the laser away, what will happen? You will have a divergent beam. So, that is a defocused mode. Defocused mode will give less amount of energy as compared to a focused mode, right? Now, moving ahead. Yeah, so where all lasers are used? First is osteotomy site preparation, specially done with a hard tissue laser. You cannot prepare the osteotomy site with a soft tissue laser, can you? Yes or no? Can you prepare, can you do bone grafting, bone harvesting with a soft tissue laser? No. Soft tissue laser is done for soft tissue procedures. But one area where you can use a soft tissue, anybody? You can use a soft tissue laser on teeth for treatment of dentinal hypersensitivity. Okay, but that too in a non-contact mode. Please do not touch the tooth. Whereas a hard tissue laser can be used for both. A hard tissue laser can be used to prepare the osteotomy site, can be used for bone harvesting and also can do depigmentation, frenectomy. Of the area provides hemostasis and accelerates your wound healing. Well, another interesting case of peri-implantitis with laser. This is at 4 months after implant placement. Please all of you look here. You can appreciate the threads which are exposed. Yes, buccal threads which are exposed. So, I did degranulation with a soft tissue laser set at 1.5 watt in a contact fashion. DM bone graft was placed, followed by placement of DM bone graft, and then later on it was sutured. So, laser is used as an adjunct for treatment of peri-implantitis, and just look, this is at 6 months post-operatively where a good amount of bone is evident on the radiograph. So, where all lasers are used in implants? for osteotomy site preparation, decontamination of the socket, treatment of peri-implantitis, very, very important. And out of all the lasers, diode will not damage your implant surface. Well, you can use both, but please maintain your laser parameters well. I'm not saying any laser is above any, okay, but maintain your laser parameters well. Well, I would like to conclude my presentation with the American Academy of Periodontology Best Evidence Consensus Statement on the efficacy of laser therapy used alone or as an adjunct to surgical or non-surgical treatment of peri-implantitis and periodontitis, as stated by Homley Wang in the year 2018. Well, there were 3 questions which were addressed. Well, I follow evidence-based dentistry. We should follow, okay. So, the first question which was addressed was related to, do lasers used alone or as an adjunct to conventional forms of periodontal treatment are better, or only laser is better? And the authors concluded that similar or slightly clinical outcomes were better than laser treatment alone. Current evidence fails to demonstrate a long-term benefit of laser, that is more than 48 months. Thirdly, adjunctive use of both the erbium YAG and the ND YAG, they have been found to be superior to conventional periodontal treatment, especially in deeper pockets, which are more than 7 millimeters. Well, the second question was related to peri-implantitis or mucositis. Well, let me tell you the difference. Mucositis is inflammation of the soft tissue only. Peri-implantitis is loss of the supporting bone. And the authors concluded that no substantial current evidence supports their use in the treatment of mucositis. Short-term benefits when peri-implantitis is concerned, no long-term benefits were evident. The third question which was addressed was related to APDT, that is antimicrobial photodynamic treatment. And the authors found out that APDT provided improvements in recidal probing depth which are more than equal to 5 millimeter, and there was good amount of clinical attachment gain which was also evident. Lastly, expert opinion suggests that the use of lasers on healthy sites could cause harm rather than benefit, and if lasers are not used according to proper protocol, damage can occur to the teeth, dental implant or surrounding tissues. Well, I have talked about only not even half of what I normally speak. So, just limited myself to surgical periodontal procedures, right. Lasers have wide range of applications. It can be used for OSMF, in ortho, for mold removal, well, cases of lip depigmentation, for bleaching, etc. Well, ladies and gentlemen, this has been my journey. I have deliberated at various national and international platforms. Well, recently, 2022, I was there at UP Dental Show, then again in 2023 at 48th IDA MP State Dental Conference in January, where I conducted a full-day workshop, then at Mansarovar Dental College, again in January 2023. Well, this was recently this month, and last month, of course, I conducted a 5-day workshop at Chittagong Medical College, that is Government Medical College in Bangladesh, March to April 2023, and this was another international symposium of the academic-based clinical dentistry at Dhaka, Bangladesh. Well, this is my own venture in the heart of Gurugram by the name of Gamzopolis. Well, thank you so much, and I appreciate your presence here. Thank you for being a wonderful audience. I'm available on Facebook. This is my number, my website. You can contact me if you have any queries. Thank you once again.
Thank you, ma'am, for the wonderful lecture. The next speaker for the day is Dr. Athreya Rajgopal sir. And a brief intro about sir would be, he is trained in all aspects of oral and maxillofacial surgery, a fellowship in facial aesthetic medicine and aesthetic surgery from Germany. He has received training in facial cosmetology and facial aesthetic surgery from Korea. He has done his fellowship training in cleft and craniofacial surgery. He is a certified implantologist with a fellowship in oral implantology. He is a trainer for dental implantology and craniofacial surgery. He has conducted numerous CD programs in various medical and dental colleges all over India, and he has been invited as a guest speaker at Japan for 3rd International Congress of Facial Cosmetology and Trichology 2018. He has been trained and he has trained numerous doctors in the fields of aesthetics, surgery and implantology. Sir is going to deliver a lecture on, again, his favorite topic, that is aesthetics.
This is working? Yes, this will work, and you also have a collar mic, sir. Oh, perfect. If you want. Can I have the collar mic? And a pointer. Could I have the this thing on, please? I think it's not mimicking my screen. Oh, yeah, now it is. Okay, by the time this starts, a big thank you for having me here, and a warm welcome to all of you who are here and listening to this. We had a plethora of speakers with so many different things and so many different kinds of topics here. See, knowledge is to take from anywhere you get, and every time you get that kind of a approach where you can absorb new things, it's actually a time to celebrate. I'm going to be talking about aesthetics today, which I do quite frequently these days, because that's one of those topics which is actually the need of the hour. And I'm sure a lot of us would want to diversify as well, apart from doing the routine. And like my routine will obviously be, just because I do facial aesthetics, that doesn't mean I don't do maxillofacial surgery. But this is something that I actually like doing, because it can actually show very good results, and the patients tend to be getting what they deserve. I work with about 6 hospitals, and I have 2 practices. So there's a huge variety of work that we actually do. I'll try and put it forward to you, since time is very little. I'm not going to be talking too much in depth. If there are questions, we will take it offline. So how many of you understand the pattern of aging? I'm sure some of you might have been there yesterday also, this thing. You understand how we age? Okay. How do we age? Do you understand that most of you are pretty young here, okay? And I'll want to be on that side, suddenly. But it's not like that. We are all aging as we are talking. And it's actually, when you are young, you have volume in the right areas. And when you age, you tend to lose that volume very quickly. So most of the aesthetic treatments are actually aimed at giving back volume, whether it's surgical or non-surgical. I'm trying to stick to more of minimally invasive work, which might actually attract you, rather than the surgical work. So we all age, and we call it the triangles of aging, because in a youthful face, you have more volume in your temples, mid-face, and as we age, this triangle will reverse, and you will see more tissue accumulation in your lower third of your face. That's the usual thing. And whenever you want to make a treatment plan for your patient, that's what we want to stick with. So I won't explain this, because this is what we do when we want to treat a patient. So right now, I just want to give you some information about what all things are available in aesthetics. So without wasting much time, this is how a vial of the toxin looks like. And we all know what Botox means. We've all heard the term Botox, right? So you understand the term Botox? You know what it does? So it basically relaxes all those things which are hyperactive. If you think something is hyperactive, some muscle is hyperactive, the only solution to that is the toxin. Nothing else will work. So this simple vial is what you need to dilute with normal saline. How much, you understand, right? It will come as an empty vial. So you need to dilute it further. If it's a 100-unit vial like on your screen, you will want to dilute it with 2.5 ml of normal saline. Botox is the brand name for a specific company. Like that, you should understand this is known as botulinum toxin, which is primarily type A. It acts by stopping the release of neuromuscular acetylcholine from the neuromuscular receptors, and I always mention that you should know all these treatment plans which are mentioned on your screen. It's not just knowing just Botox or just fillers or just threads. If you're talking about just minimally invasive procedure, first of all, you're not doing surgery. Surgery is the easiest to do. You can give very predictable results. But when you're doing these minimally invasive ones, it becomes trickier, because you're actually blinded by the planes. You don't know which plane you're actually injecting into. So you have to be a little more trained there. Your anatomy needs to be to its, your basics need to be strong, basically. So without wasting much time, let's get on to it straight away. I mentioned that it stops the release of acetylcholine from the neuromuscular receptors, but a simple, straightforward case of forehead Botox, it might seem very simple, and it is simple. But there is a whole lot of balancing here that you have to do between the forehead wrinkles, because there is a set of muscles which will elevate, and there is a set of muscles that will depress the forehead. So till the time you don't actually address these two halves, you will not get this kind of a result. And yesterday, some participants were able to see how easy it is to do Botox. How difficult was it to do Botox? Was it easy? Yes, that's exactly how easy it is. But only thing is, you should know the muscles that you're injecting. You should know what planes you're entering. And these are very predictable results that you will get. So the frontal lines, dynamic lines, the crow's feet, all these you can address. Hyperactive mentalis, gummy smiles, as I mentioned. So gummy smiles, I'm sure every dentist should practice. You know, you'll get a case of this everywhere. And as I mentioned yesterday also in the workshop, there are only two reasons why the gummy smiles exist. Can someone tell me what is the reason for a gummy smile? Some of the faces were there yesterday. When do you get a gummy smile? Skeletal and dental? Skeletal means vertical maxillary excess, dental means altered passive eruption. So all these causes, if it's a skeletal, you'll obviously want to go in and do an orthognathic surgery, but how many patients will be willing to get an orthognathic surgery done for a gummy smile? Common sense. The percentage of these patients are very few. So simple shot of this toxin is effective enough to get these kinds of results, to relax the muscles. 3 sets of muscles, the zygomaticus minor, levator labia superioris, and the elichneza is what we try and give the Botox to. This is one very important article because this is the research which we did on our own, and as I mentioned, this is the largest case series of its kind in the world. So we learned a lot from this article. We learned that if you repeatedly give a shot of toxin to a particular area repeatedly, there is some amount of shape memory that always stays after the third shot. Now, just in case you have a patient which is not got a excess of vertical maxillary excess, but still has this kind of a gingival show, it's a very easy procedure. And a simple mucogingival resection of that tissue, no attached tissue to be taken out here, more of the vestibular mucosa, a little in excess, and simple straightforward suturing, and immediate post-op. This is going to be permanent. This is not like Botox, okay? This is a permanent correction. We use a lot for hyperhidrosis as well because it's actually used to be a side effect, but we use it to our advantage. A lot of people come in with sweat, primarily on the face as well. A lot of people have excessive sweating in particular areas, so we can use Botox for hyperhidrosis as well. Very commonly is what we use it for these reasons as well. The other common reasons which should attract attention to any dental surgeon here is temporomandibular joint dysfunctions. Myofunctional pain dysfunction syndrome is a major, major concern. And all of us in our practices will see a lot of patients for MPDS, acute TMDs, chronic TMDs. Chronic TMDs will obviously go into degenerative phases most of the times, can show with subluxations as well. But in acute TMD, the patient is in immense pain. So without getting into TMDs too much, because it's a very vast topic. And once we talk about it, we can only talk about that for the entire day. But Botox really helps in the acute phase. How does it help? Because the set of muscles which the Botox targets relaxes the neuromuscular apparatus, and every TMD has a neuromuscular component involved, right? So that's how, after treating the joint and the bite, during that phase, instead of keeping the patient on heavy muscle relaxants all the time, you should target the masseter temporalis primarily, and in some cases, you might even want to target the lateral pterygoid, right? We got a lot of patients for facial pain and migraines as well, temporal migraines, occipital migraines, frontal migraines. Botox proves very, very effective in these cases. It reduces the frequency and the intensity of the kind of migraine that the patient has. It's important to understand the pattern of the migraine. How many of us place implants here? We place implants, right? And most of the times when you do a full mouth implant, and suppose you have a patient who has to, who cannot stay back, and you want to load it and send the patient off in a full mouth case, what is our major concern? Like in this case, this 85-year-old is a chronic Rajnigandha chewer, and no matter how much we counseled her, she didn't listen. She said, my entire life I've been chewing. The last leg I can't leave. So would you want to give me teeth or not? I said, it comes with your own risks, okay? If you still want it, yes, why should we can't let a lady be without teeth, right? But she should know the weigh the pros and cons of it. So this is the immediate, this thing, we did this loading in about 2 weeks' time. I placed the implants, and the easiest part is placing the implant actually. The toughest part is obviously the prosthetics, which primarily my younger brother looks after, being a prosthodontist. And after I placed the implant, the same session, I did Botox for the masseter temporalis. Why would I do that? Any guesses on that? It's a very well-known article that you will reduce your occlusal load by about 20 to 25%, okay? And those 6 to 8 weeks during the initial phases, you want the osseointegration to be the best possible with least amount of load on your implants. So as a ritual now, any full mouth cases, the day I do the implants, upper and lower, even compromised cases where I'm placing zygoma implants or pterygoid implants and all these things, and because these implants you can immediately load, by the way, but still the bite forces are not going to reduce. So I, as a ritual, give Botox to the temporalis and masseter. Coming on to fillers, fillers are primarily HA based, and they are the ones that are going to take care of your static wrinkles. Static wrinkles means at rest. If somebody ages, you actually require volume, and that is what a filler does. Filler can be anything, like in this case we're talking about HA, but if you talk about surgery, what my commonest filler that I use is fat. There's no filler better than fat. I'll show you a couple of cases also, how we do fat grafting at the later, at the fang end of the presentation. Let's not get into the techniques because you'll have to train hard to understand how this works. And that requires a lot of time, and because of the paucity of time, I can't tell you how these actually work. The depth of the placement of the filler is very, very important. Till the time you don't understand that the depth is where your results will be decided, okay? A superficial placement of the filler is considered to be very harmful. You'll have to let go of the filler. What is the antidote for filler, by the way, if your filler has gone wrong? Can anyone tell me? What is it that you use for OSMF cases? Submucous fibrosis? Hynidase. We don't know hynidase in this room? Hyaluronidase, we don't know? Surprising. So hyaluronidase is what is the antidote for any filler that goes wrong, and when you want to let go of it, you will want to use hyaluronidase. Simple straightforward case of immediate pre and post of a midface, 3 ml of fillers done to the midface. The redness is still there, if you would see. This is all post the filler injections. 4 to 5 pricks on the malaprominence to give him malaprominence that looks better than the flattened malaprominence is what his complaint was. We'll not talk about this because this is again a slightly complex thing and will require a lot more time for me to make you understand that. So simple surgical corrections involves a genioplasty, but the same male for which we did a malaprominence also wanted some amount of correction for the chin. So what is it that you can do? You can either go in and do a genioplasty, but if the patient doesn't have time, like in this case, we did a 2 ml filler to bring his nose chin angle forward, and it's a very predictable procedure. Very, very easy. But the only thing is you'll have to repeat it in 10 months' time, okay? It'll go off. This is one of those cases where I always mention that it's not always beautiful, right? There are complications also that might happen. This is the pre and the post that I'm showing you for a 72-year-old lady. And that's how she used to look, and at the end of the procedure, that's how she looks. But before we did this, we encountered something known as a vascular occlusion. The filler entered the vessel. And once it enters the vessel, it is bound to clog a vessel. And that's how it looks like. So understand, weigh the pros and cons. There are complications also involved, but the best thing is with these complications, you can actually let go of this complication. You have an antidote to relax this. And the result that we get is after overcoming the complications. So you will encounter complications no matter what you do. It might seem like child's play, like a simple Botox shot can over-relax your muscles. There might be drooling of saliva from the corner of your mouth. That is also possible. Temple fillers to temple volume, because we all have to understand that the maximum amount of volume in a youthful face is always going to be in the temples and the mid-face. Please understand this concept. If you can all go back home and stand in front of the mirror and pull your face up from the temples and the mid-face, you will look much younger than what you are. Not you, you guys are already quite young. We'll have to take some of us, they'll have to use some of us to see the mid-face lifting. What can be done for this one? What can you do for them? Come on, give me a treatment plan. Just going to take them to the park, walk them around. They don't have a right to look beautiful. So with these excessive tissue sag, can you see the hooks pulling all that tissue up, even though this kid looks better this way, but that's what you want to do when you have excess tissue folds. You don't want to do that? Too cute, you want to leave him like that? But I'm just demonstrating, we didn't do that. So what you would want to do is you would want to pull the tissue up. The most important thing on your face is the SMAS, the superficial musculoaponeurotic system. And when we age, we lose volume from all these areas. So, like I showed you, for all these things, we use something known as cog threads, seal-out threads, or double-ended threads. And we actually engage the entire face and tuck it in laterally and make sure that we can tighten the face from wherever we want, neck, face, jawline, temples. I'll show you examples of everything. And if some of you are interested, I can show you surgical cases as well. So see, when I pull this tissue up, I can pull the entire face up. And a very simple, straightforward procedure. When I pull these threads up, the entire face will pull up. And that's how she looks after just 3 ml of fillers and 8 cork threads. Her main concern were her nasolabial folds, and this is an international patient. She left in 2 days. This is her second day post-op picture. This is how you would want to do a brow lift, and we use multiple different types of threads, and that's how you engage the brows and mark those areas which you want to lift up. And very easy procedure. The same patient. That's not her. That's how it looks on a cadaver. So that's not, this is how you want to engage it in a live patient, and that's how it will appear in a not so live patient. Same patient, imagine the number of threads we did for her. This is how we do routinely. We did submental, now we're doing jawline, we did eyebrow. And in the same sitting, we did something known as a temple lift also with an aggressive thread like the cork threads, 100 mm threads right through the temples and the temporalis. So you want to tuck this area up so that she gets the temple hollowing can be addressed. And the same area, after I do the temples, I would do the mid-face also. Can you see my temple threads are still sticking out? These are in the temples. The temporalis has been engaged, and all this thread is going to tighten that area. And the same one-point entry, I am addressing the entire face. This is a routine procedure that we do. This is again my own patented technique. I can even use 3 vectors or 4 vectors to tighten the entire face, suprazygomatic, subzygomatic, and a jawline area. I would want you to see the results of this after I show you how this actually works. So this is, I'm taking a retromandibular approach, and the thread enters from that entry point. Sometimes you might even have to give an incision if you are doing multi-vectoral approach. That's also accepted. And the thread is going through, bypassing the masseter, the facial artery, reaching out to the depressor anguli oris, which is known as the marionette line. And once I engage it, I make sure that I have enough threads there to engage that tissue, because that tissue is very bulky, and you want to lateralize that face, make it look tighter and younger. This is what you want to do. And I want you to focus how the threads are actually going to pull and lateralize the face. Can you see how the tissue is engaged? And when you pull, the entire tissue can be tucked in to whatever extent you want. So basically, even with minimally invasive procedures, I can tuck in your face by 1.5 centimeters laterally, and that's going to make your face look younger and youthful. Same patient, you can do multiple mono threads as well. We did 100 of them in the submental area because she had hefty jawline fat. Look at her face. Round, and that's what she didn't want, and now she has a jawline finally. Looks better? Very simple, straightforward. You're just lateralizing the face, putting up the fat, making the face look younger and better. These are how we do under eye. Let me show you, go through it because it's a long presentation. I don't want to waste too much of time. This is an immediate pre and post. So when we address the under eyes, the tired under eyes, what we need to do is we need to put fillers in the under eyes and around it. And this is done by 4 ml of fillers, 1 ml for the under eyes and 3 ml for the mid face. And this is immediate pre and post, what you're getting here. Fillers will show instant results, instant. And that's how I would do an under eye filler. And if I'm using fat, the technique remains the same. My filler might change. So I make sure that I'm not blocking my medial canthus. Otherwise, when the patient cries, it will come out through the nose. That's not going to be a very pretty sight. Again, immediate pre and post. The hollowing, and immediately you see after the filler that the hollowing has been taken care of. Techniques are the same. And these are cannulas which we are using, which are very, very safe. We have 50 mm cannulas, 60 mm cannulas, 25 gauge, 27 gauge. Depends on what you're using, what product you're using. So always remember the tissue plane. you don't want to be too deep, otherwise you're into the orbital framework, okay? And if you're too superficial, the filler will be visible. So either way, you're wrong. So the tissue planes are very important here. So lips are very important, but it is important to mimic them in the right way. And just like I mentioned yesterday, never go according to the patient's perspective of a lip filler. Understand how the patient's face is and deliver results accordingly. The immediate pre and post, you can actually make the lip look voluminous, sharper. And some patients who have a well-defined face, you can even give round and Russian lips, very easy to do. Like in this case, just a little bit of contouring is all you want to do. Slightly botched up case which was referred to me, and once it was referred, it was darker than what it was, because her main thing was she wanted lighter and voluminous lips. This is what I did for her. Made it lighter, made it voluminous. Cleft lip, where I've done a surgical scar revision. And she multiple cleft surgeries she had underwent, and I did pretty much like a cleft surgery. What you do, the flap remains the same. You'll have to do an advancement flap there to reduce the scar there. It was pretty much the same. Then fillers for the lip to give it some normal anatomy. Again, a messed up case, referred to me by someone. The fillers were actually placed wrongly and the lip everted, so I had to surgically take out these lumps and let the lip heal after that. Very simple, straightforward procedure where we do lip reductions for males. This is immediate pre and post. You would want to guard the minor salivary glands there. Make sure that you don't injure them, but the tissue dissection needs to be very, very, decent. Buccal fat removals are beautiful because that's how you do it. A small incision into the vestibule. Just make sure that you're not damaging the Stenson's duct. This is also a case that was referred to me. We had to cannulate the duct, and it was very difficult because it was transected from a very higher level. So we had to actually make a synthetic duct there and cannulate the duct and keep it like that till it had a sinus lining forming around it. So our aim is to remove half of the fat rather than all of it. Otherwise, the patient is young. Right now, you will get good results, but after 5-6 years, the patient will want fillers there because it will be excess of buccal fat that you've removed. Easy procedure, very easy, a simple half-an-hour procedure. And that's how this patient looks. She mainly thought she had a very round-looking face, and before she left, that's how she looked in 3 weeks' time. A difference that you can see, just in 3 weeks. What have we done? Not much. Just a little bit of fat removal and putting a little bit of fillers and threads in the right areas. A lot of Northeastern patients come into for a blepharoplasty. For a Northeastern, we would do an Asian blepharoplasty, and for a Caucasian, the blepharoplasty is totally different. And these are simple, straightforward surgeries where we take out the fat herniating and a simple round of suturing after that. Immediate pre and post, you can see that the patient did not have any demarcation of her upper lid, and doing this, you can straight away give a demarcation immediately. Again, a simple, straightforward procedure. Do you see this patient had a history of trauma? See where the scar is, in between the upper and lower. These days, a lot of people do a lot of things. What was the simplest thing to do? Just take out the scar tissue, undermine, and suture. Immediate pre and post. How simple is it? And it doesn't look artificial. It's the natural hair, right? You've just made sure that the upper and the lower aspect come together, and you've given her normal eyebrows again. So this is these are how our fellows actually dissect and learn. Most of them would want to do their tracing of their vessels on their own, because till the time you don't know your anatomy well, you're not actually equipped to do these procedures. Simple, straightforward rhinoplasty. If you're not doing a surgical rhinoplasty, you might as well do a non-surgical or a liquid rhinoplasty. Broad nose is what she complained of. There's something known as a rhinoplasty thread that comes. So we engage right from the columnar tip till the radix, put in some fillers there, and in 4 months' time, you can see her nose. It'll have some shape, it'll have some prominence, and all done minimally invasively. So that's how we harvest fat. And this is how I want you to see. A small incision below the belt line is what we usually do, or we take the lateral pelvic region to harvest the fat. That is the best place to harvest visceral fat, and making sure that the cannula actually absorbs. You can use a manual method or a motorized method to harvest the fat. And the amount of fat that we get is intense and immense. Imagine you want to do an entire face. Here I'm showing you fillers talking about 4 ml, 5 ml. When we do a full face, we would end up doing 60 ml, 55 ml. Yeah, that's the kind of correction that we do. So the fat has already started coming in my cannula, and I've harvested the fat there. And after this, after I've done this, the next step is let the fat settle. And these are excess oils which we don't want, the RBC content and the extra oils that we want to remove in 10 minutes standing time. That's how it looks. We remove the RBCs from there, and this is all injectable fat that we get. After this, we will filter the fat. This is known as a filter. And with the filter, we can decide the viscosity of the filler. How viscous do we want the filler to be? These are particular filters that we use. And then the easiest part, inject. And contour whatever area you want to contour on the face, neck, easiest part to do. Some of them are even happy. I can give you the fat, after that you can do it on your own, like things like that. So most of it I do under GA only because the patient is very comfortable. You can address all those areas. And I take it as a daycare surgery. I would probably do it in the morning and discharge the patient in the evening. Most of the times, unless it's a compromised patient, I would keep them till the next day. This is how we do a temple filler. And you need to be careful when you're doing the temple, because there's a huge superficial temporal and a cervical branch of it there. So you want to use a cannula and try and be safe there. So you need to palpate how deep are you, make sure you're not very superficial. And again, just inject. And most of the corrections, I can't tell you how many ml. It's all visual corrections, okay? Mid-face, these are all videos. And this is immediate fat grafting, 4 weeks. This is the picture he sent me. These are all outstation patients. They come and get their procedure done and go off. And in 4 weeks' time, the fat will start building up and the face starts looking nourished and well contoured. His main complaint was a tired looking face and malnourished kind of a face. And when this patient sends you a happy picture, that's how it actually looks like. This was a Sri Lankan patient. We took her own fat and injected it in the right areas, and that's how she used to look before and after. We did a submental liposuction, facial liposuction, and injected the fat back. Case of morphea, again a case we did with fat grafting. Morphea is an autoimmune condition, and it will never heal. So you just want to give some quality on the face, and that's how it looks. It will never be symmetrical there, but at least it looks better. That's how a facelift dissection looks like, and when we do a facelift, that's how we need to expose the entire face. If you can see, this is, if you want to read about the anatomy, I can tell you about all of it, but when you do a facelift, this is all the SMAS, which we want to lift up and put it up to the higher plane, and you can see some good vessels here. This is the facial, branch of the facial coming there. This is a surgical facelift. So you should know difference between a surgical and a non-surgical. What I showed before was all non-surgical. This is all surgical. When you have a case like this, we did something known as a platysma application. The 2 bands of the platysma, can you see here? We opened up the neck, did a submental liposuction, did a small cutting of the platysma, and then you need to refix it. See her neck now. We did a facelift for her also, and tightened the face as well, and did a neck lift with a submental liposuction and a platysma application. This is all surgical. So these cases will not get good results with non-surgical work or minimally invasive work. That's where you need to be trained everywhere, but it's a good thing to start with minimally invasive aesthetics, because that can make a plane. This is also a surgical rhinoplasty. If you get a case like this, history of trauma and deviated septum and the bone completely gone, you do anything to camouflage, it will not camouflage. This is a surgical indication. So this is a surgical rhinoplasty. We can even make fillers from your own blood, and the answer is actually in your own blood. We use a lot of albumin and platelet-rich fibrin precipitates, and we can actually make it accordingly and utilize it as a thin filler all across the face and the neck as well. This machine is not available in India. I'm the only one who has it, by the way. So as of now, we are putting it will be up for patent. It's already up for a patent. It will be out this year. That's how you inject it. To address all the areas that you want to do. And again, I prefer to use a cannula than a needle there. You need to be a little aggressive. So pigmentations are again that we deal with mostly with lasers. We've not spoken about lasers, but it's a long topic. Someday if you want to discuss, I would be more than happy to guide you and tell you. But this is with a Q switch and a pico laser with an IPRF session to reduce the pigmentation. This is how you can use PRF to volumize the hair as well, and just 3 sessions. So, interesting part. Bald is definitely just a phase, because we've got the means to do an FUE or an FUT hair transplant. If you have a case like this, you can straight away go and harvest the grafts from the occipital region, most common site. That's how you harvest the grafts from the occipital region. How many of you have seen a hair transplant? That's how you harvest grafts from the occipital region. And once we have harvested the graft, see, what we are doing is I've made the punches before, and now we're just harvesting it, because we don't want the grafts to be outside of blood for very long. Either you store it at exact 4 degrees Celsius or you let it be in blood. Okay? Once you've done this, we graft the area, the recipient area, and in 8 months' time the best results come in about 10 months' time. These are all natural hair that comes up. This patient used to wear a patch, worst thing to do to the scalp, and again 3,500 grafts harvested, natural hair, patient's own hair. And this is what we do routinely. A young boy, 29 years old, we did about 3,500 grafts for him as well. And these days he shows off. He's got a blue spray on his hair, and he walks into the clinic and showing off to me only. He's like, "Tumhare kam hai, ab mere zyada hai." So it's like that. Maine kaha, "Boss, I'll stop your PRF sessions." Beard transplants are very routine. Beard, eyebrow, eyelashes, we do all that as well. This is all transplanted beard. Everyone wants a stubble these days, right? And if you it's an in thing supposedly, and that's what he said. So this is all transplanted beard. We do a lot of transgender cases as well, just to show that a female hairline is completely different. So this is a transgender hair transplant that we did. So you have to design the hairline accordingly. So this is how you do a female hairline. Okay, we would want to reduce the grade 2 baldness, and this is how we transplant a transgender's or a female hairline to reduce the forehead width. Coming on to the last leg, I just want to show you some before-afters. And I always remember this lady's statement. I won't tell you what all we have done for her, because it will exceed the time. There's a lot. Whatever we have discussed today, we have done for her, okay, to give her results like this. She was a 63-year-old lady. And I always mention, because her statement always strikes me. This I did 5 years back, and every year she comes in once. Her only statement was, make sure I look better, and make sure my husband recognizes me. And my only statement was that, first of all, I was laughing. I couldn't say much. I said, I'm sure your husband can never forget you. Pun intended. Complete facial rejuvenation. Everything done with lasers as well. But the lasers we do before, otherwise all those expensive products will resorb. Again, before and afters. There's a lot of routine where you can give results to your patients, make them look better. Acne scars, lifting, tightening, higher cheekbones, better jawline. What I want to do for her is forehead reduction now. She'll look much better with that. Surgical. Again, a case where severe pigmentation, history of autoimmune disorder. You've all heard the term Ehlers-Danlos syndrome. It's known as rubber man syndrome. So it's an autoimmune condition, and a lot of these autoimmune conditions give pigmentation like this. So we changed her entire face, and that's what she wanted. And I always mention this was a very tough one, and done minimally invasively, non-surgically. She didn't have time. So all those long threads and all that that I showed you, 40 to 48 of them, we combined it with fillers, we combined it with deoxycholic acid for the submental area, Botox, and pretty much everything that you had seen, and some lasers as well to give results like these. So the most important thing that we speak about is actually a combination, and when you're able to do that, make sure that your patient that you have selected is ideal, the products that you're using are decent enough, and if that is right, the risk of you going wrong will be minimal. Please don't have a shortcut in training. Train well, because if you're actually wanting to give results to your patients, there are no shortcuts here. If there are any doubts which I can take up, we are short on time, so I won't take up any right now. You want to take it offline, I'm ready to do that. If there are any doubts, please get in touch with me. There's going to be a fellowship program launched soon from CynoDent as well soon. Otherwise, there are already fellowships which are running if you want to train sooner, or whatever you want to do, please get in touch with Dr. Anmol also and Dr. Ashish. Thank you for a patient listening.
Thank you, sir, for the lecture. Okay, so now I would like to invite the next speaker for the day. She is Dr. Yashika Bali ma'am. A brief introduction before ma'am is here for the lecture. Dr. Yashika Bali ma'am is working as an associate professor in the Department of Prosthodontics and Crown and Bridge in Swami Vivekanand Subharti University, Subharti Dental College. She has conducted many pre-conference courses. She has chaired scientific sessions in Indian Prosthodontic Society, PG conventions and conferences. She has been a guest speaker at International Dental Summit in Dubai 2022. She has attended many conferences and workshops till date and presented various posters and papers in conferences, and she's having 2 books and various national and international publications and Scopus publications. Today, ma'am is going to deliver a lecture on acquiring skills in ocular prosthesis.
I think it is not working. Jai Hind and a very warm welcome to all of you. I'm really amazed to see such a wonderful audience sitting over here and sharing and gathering their knowledges. So today I'll be presenting my topic on acquiring skills in ocular prosthesis. So our today's agenda is, we'll be discussing about the indications, what are the basically types of the ocular prosthesis, and socket evaluation, which is very much important before designing the ocular prosthesis. What are the prerequisites for the good fitting of the ocular prosthesis? Which one is better, a socket or a custom-made prosthesis? Methods for the fabrication of the ocular prosthesis, and lastly the tips for your saving or take care of your ocular prosthesis, your eye socket as well as your eyelids. Now begin with the introduction. As we all know that eye is an essential sensory organ. You know that you can very well appreciate from this picture that it is one of the first feature of the face to get noticed. But loss of an eye or a disfigured eye has a far-reaching impact on the individual. Not only the professional life as well as social life of the individual hampered. So rehabilitation of custom-made ocular prosthesis is giving such individuals professional as well as social acceptance. And as a maxillofacial prosthodontist, it is our duty to ensure or to enhance the knowledge regarding the cosmetic benefits of custom-made prosthesis. Now there are various reasons for the loss of an eye and absence of an eye. It could be because of congenital, post-cancer treatment, and due to irreparable trauma. We can find out that there are various tools like MRI, CT scan, as well as corneal topography, which are really helpful to tell us about the suspected diagnosis, for the confirmation of your diagnosis. Secondly, it is very much helpful in tell the extent of the trauma. Moreover, helpful in reviewing of the anatomy of the eye. We can also find out the treatment planning, which we can make out like in surgical cases where we need a surgical intervention. Like in enucleation, where there is complete removal of the orbit including the sclera as well as cornea, leaving the intraocular muscles. Whereas in evisceration, there is complete removal of the intraocular muscles and leaving the sclera and the cornea. On the other hand, there is exenteration, where there is complete removal of the orbit as well as your orbital bone. So when we plan to design ocular prostheses, we require patients who have gone through enucleation and evisceration. Now coming on to the indications, as we have discussed earlier, that there are congenital conditions like in anophthalmic socket. There is complete absence or loss of an eye, and microphthalmic eye, where there is incomplete development of the eye. You can very well appreciate from this socket, it is very, socket is very shrunken in this case. Then comes your acquired condition like phthisis bulbi, then we have the atrophic bulbi. Then we have post-enucleation, then we have chemical injuries, and we have your contracted socket following the radiations. So in all the conditions, we can plan for your ocular prosthesis. Now depending upon the types of the ocular prosthesis, we have stock shell, then we have scleral shell, and we have a custom-made prosthesis. Now when I am talking about the stock shells, definitely they are available in various sizes and shapes, but the major disadvantage of stock shell is that it is ill-fitting, and that's why we are not using in such cases. Second is your scleral shells. It is a semi-customized prosthesis which are usually used in cases where there is thickening of your sclera, and this lens is rest over the scleral portion of the tissue. Last one is your custom-made prosthesis. So these are the type of the prosthesis which are made from your high density polymethyl methacrylate, and it is very much adaptive to your socket. It is very much consumable for your socket, and second thing is it has the adaptiveness with your orbital tissues. So once the adaptiveness increases, it is helpful for the movement of the prosthesis with as compared to your adjacent eye. Lastly is the centralization of the iris. It is very important, so we can design the iris as compared to your adjacent eye. Now we have another options of ocular implants also, but you see ocular implants, it is a very technique sensitive procedures, and sometimes it results in your migration as well as exposure of the implants. We cannot plan to give ocular implants in cases where there is, in children where there is increase in the size of the socket accordingly. Moreover, there are some, cases we have seen where there is contraction of the socket. So there may be, infection will be there, or there is any mechanical injuries. It ultimately lead to the migration as well as exposure of the implant, and therefore it results in the poor fitting of your ocular prosthesis. As you can very well appreciate from this picture, you see there is drooling of your prosthesis. Now socket evaluation is very much important before designing your prosthesis, during the fabrication of the prosthesis, and after giving prosthesis to the patient. There are few points, like first of all we have to evaluate the general appearance of the socket. Your socket should be in a symmetrical as compared to adjacent eye. Second is your lid and the lash position. When you are fabricating, during a wax trial, it is very much important to evaluate the lid and the lash position, because in endoprion there are chances of the contraction of the socket. Last one is the laxity. We have to evaluate the laxity also. This is how your healthy socket looks like. You see the pinkishness, there is no signs of inflammation, as well as you see the deepening of the sulcus, it is symmetrical. We have to evaluate that in some cases there is soft tissue displacement. So in such cases, if we design any kind of prosthesis and we place in the patient's eye, the prosthesis will be drooling out because of the soft tissue displacement. Another thing is, you see over this case, here there is inflammation of the socket because the patient is not maintaining the hygiene, the patient was not regular for the follow-ups. So we have to guide the patients to do a regular checkup. You see, advise the patient to come after 3 to 4 months and to evaluate the socket as well as your ocular prosthesis. Granuloma again. So in every cases we have to first of all treat the underlying cause and then ask the patient or then design the prosthesis. Now what are the primary requisites we have to look into before, after giving the prosthesis? You can very well appreciate from this picture that the aesthetics comes really well. So deep phonics in all the quadrants. If your phonics are not adequate or they are not atrophied, they ultimately lead to the poor movement of your prosthesis. Normal tear secretion. Sometimes we will provide the prosthesis to the patient and it ultimately leads to the dehydration. Why it happens? Because the prosthesis as well as the orbital tissues, they are not closely adapt to each other, and there is seepage of the concerned mucus as well as your tear into the gap which is created between your prosthesis as well as tissues. Lastly is your adequate orbital fat, and again there should be no inflammation of your socket. Now we are very much clear that whether to choose for a stock tray as well or for a custom prosthesis. You can very well see from this diagram that there is a gap between your ocular tissue, orbital tissues as well as your prosthesis. So there is volume distribution is inadequate between your orbital tissues as well as your prosthesis. So there is again seepage of your mucous membrane as well as tears and building a pressure over the orbital tissues, thereby creating irritation to the patient. You see, the centralization of iris is inadequate. Whereas custom-made prosthesis, the prosthesis is closely fitted to your orbital tissues. Thereby, there is equal distribution of the weight of the prosthesis, and it is very much, more comfortable for the patient. Now, how this is important, like how the custom-made prosthesis is important, it is only because of the proper impression techniques. We have two impression techniques, empirical socket method and your modified impression technique. The modified impression technique is more, in nowadays, because in this technique we use a custom-made, a stock tray which is closely fitted to the patient's eye. After the selection of the tray, they are available in various sizes depending upon the size of the defect. Now when we select the tray, we are trimmed the peripheries of the tray and lined it with the light body impression material. You can also use a medium body impression material and ask the patient to do functional movements. Along with this impression tray, there comes a handle of the impression tray and it is inserted on the center of your tray. It is easy for the insertion as well as removal of the tray from the patient's eye. These are the tools which we require for the fabrication of your ocular prosthesis. Now coming on to the steps of the fabrication of ocular prosthesis. This is a case which reported in our department. The patient was suffering from retinoblastoma. This is a 5-year-old male patient, very sweet one. So first of all, very much important is the evaluation of the socket. As we have already discussed that we have to check the orbital tissues. The orbital tissues are in a pink condition and there is no signs of inflammation as well as redness. Always guide the patient to be comfortable and ask the patient to look in a predetermined point position. Once it is done, we have selected the impression tray. And we ask the patient to do a movements. A patient is looking upward, downward, and in left and the right position. You can very well appreciate, like while the patient is looking upward and downward, the barrel is moving accordingly. So that ensures that there is apt adaptation of your impression tray. Now we'll make the impression, functional impression by recording with the impression materials, light body impression materials or a, medium body impression materials. Thereafter, we'll make a 2-piece die stone mold. Again, we make the impression with the alginate and make the impression of the anterior aspect of the eye and then store it with the plaster of Paris. Once it is set, it is taken out from the patient's eye and we'll do the beading and boxing. First 4 we will do after 2 mm below of your impression. Once the impression has been set, indentations will be made and we'll apply the separating media. Once the separating media has been dried out, we'll go for the second pour. This is 2-piece die stone mold which we achieved. This is the upper portion and this is the lower portion. Now we will place it over the upper portion, we will place it over the lower portion and we will flow the wax, molten wax over it. You can very well appreciate from this picture. Now after the wax has been set, it will be modified and finished and it is ready for the wax trial. Now during wax trial, it is very much important to see the lash as well as the lid position as we have discussed earlier. Moreover, the centralization of iris is also determined in this stage. Now there are various methods for the centralization of iris, like we have interpupillary distance, Hirschberg's technique, then we have inscribing method. Another is the using of your corneal buttons. We have used the corneal buttons. They are available in various shades and types and sizes also. Along with this iris button, there comes a stump. So when during the trial stage, we will place the iris button and ask the patient to do a movements in upwards, downward and right and left position. Thereafter, the lab step starts. We'll do the investment. Thereafter, the dewaxing we will do, and after all, we'll go for the packing with the highly grade medical polymethyl methacrylate. We make sure that there should be, a placement of the iris in its concerned predetermined position. Now after acrylication, we will do the finishing and polishing, and this is the final prosthesis. We have put the prosthesis over the 2-piece die stone model and you can very well appreciate the fit of the prosthesis. Now you can also use the rayon threads which mimics like blood vessels and put it over the scleral portion of the prosthesis and lined it with your clear acrylic. Once it is done, it is ready for the insertion. You can very well appreciate the pre and post of view of the patient and the centralization of the iris, how beautiful it is looking. Now coming on to some of the tips which the patient should follow, and it is our duty to ask the patients to always wash your socket first before the insertion of your prosthesis. Always wash your fingers before the insertion of the prosthesis. You can use a suction disc for the insertion as well as removal, because if you use a fingers, then there are chances of the microorganisms which will infect the socket and their chances for the inflammation will be more. While again removal of the prosthesis, always ask the patient to use the suction disc, and you can place the prosthesis in a tissue paper. The more thing is you can use a container and put it the water, disposable container you can use and put a water over it and then place the prosthesis over it. Last one is your disinfection. How to disinfect your prosthesis? So you can use a baby shampoo which have the neutral pH, or you make a solution like use soap and mix it with the 30% of water. Again remember, you have to disinfect the suction disc also. So our take home message is to provide our patient with the most comprehensive eye care. Always inspect the orbital tissues as well as socket before designing the prosthesis. Treat the underlying cause first. and always refer to the appropriate specialist. These are my references. This is our maxillofacial rehabilitation clinic where we usually treat all our cases. Lastly, I would like to thank Dr. Nikhil Srivastav sir, Principal and Dean of Subhati Dental College, and Dr. Roma Goswami ma'am, she is the HOD in our department, for their blessings and constant guidance. I would also like to thank Dr. Rajiv Kumar Gupta for his constant and everlasting support. Thank you, everyone.
Thank you, ma'am, for the wonderful lecture. Before moving on to the next lecture, it's time to felicitate our guest speakers. I would like to ask Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir to kindly felicitate Dr. Athreya Rajagopal sir. And as Dr. M. Siddharth sir is also present here, I would like to request him to please come on stage for the felicitation. Dr. Athreya Rajagopal sir. Thank you, sir, for your informative lecture today. The next speaker is Dr. Malika R. Sethi ma'am. She has delivered a lecture on lasers. Thank you, ma'am. for the lecture. Dr. Yashika Bali ma'am. Dr. Divya Rathi ma'am, she is yet to deliver the lecture, but we request you ma'am to come on stage for the felicitation. As ma'am is not here, I would request Dr. Vishwas Bhatia sir to please come on the stage. Sir is just going to deliver the lecture, but we are felicitating you, sir. Next is Dr. Shalu ma'am and Dr. Amit Bhardwaj sir also. Thank you, sir and ma'am. Now we'll continue with the lectures. Dr. Vishwas Bhatia sir is going to deliver the lecture.
Slideshows on. Hello, am I audible? Good evening, everybody. I'm Dr. Professor Vishwas Bhatia, and I'm practicing in Gurugram. And just few minutes back, we were just discussing, being in Gurugram, there are many speakers from Gurugram, but we hardly get time to meet there. It's in the conferences that, you know, it's an occasion that we all are together. So it's a nice experience that ways. And good to see some of my students from ITS too here. And thanks for coming in. So the topic for today's presentation is let's implant without extracting, astonishing but true. Now, there are many situations in which whenever we plan implantology, we need to think on terms like, guided tissue generations or, guided implant surgeries and everything. So what if there are techniques in which there are simple methods in which the natural guides can be used, and it makes it very simple for the dentist. I wouldn't say too simple because every procedure looks simple, but it is technique sensitive. And any procedure which you plan, there has to be proper evidence behind it, unless and until it is an innovative approach. Now, when we talk about procedures like these, there are many challenges which are faced by the clinician, and some of these challenges include, first of all, the psychology of the patient. You need to understand, as my dear friend Atre also mentioned, that the patient selection needs to be perfect. If you are doing something new, you need to inform to the patient very frankly, and you need to tell them that there are certain procedures in which the outcomes are good, and they're not that two new procedures also. Why? Because there is now a follow-up of 10 to 15 years on these procedures, and we are planning to do that. You need to explain easily the advantages of these procedures, and along with that, certain disadvantages also, so that the patient can decide whether he wants to go for that procedure or not. And you need to explain to him why that procedure is one of the best, not if not the best, one of the best procedures which in long term is going to be beneficial for him. Now, when we talk about challenges, then the next challenge is bone loss. You need to understand that if you are extracting a tooth, because there is enough evidence to see that, or for us to understand that bone loss is evident following tooth extraction, which I'm going to discuss further. Because as I said, you need to explain everybody that any technique has to have an evidence behind it. So first of all, you need to be clear yourself on that evidence part before you plan to do that on the patients. Next, aesthetics. It has been seen post 6 months, there have been studies, numerous studies which have shown that there is bone loss, there is loss of bone volume after extraction. So if you need to avoid those things, and if there are procedures in which you can, if not completely, partially extract the teeth and place implants, then why not and plan those procedures, so that at least the natural aesthetics, the God's gift which is there, that remains preserved, and that is going to, in long term it is definitely going to help the patient. So you need to explain those things to the patients before proceeding further. Secondly, the position. I would show some cases in which the position of the implants goes haywire. You need to understand that if there are natural guides, and if we are extracting the tooth, there is bone formation there. So are we very much clear about the exact natural position of the tooth which was there before extracting? So these are the certain things in which you need these procedures like partial extraction therapies, socket shield techniques, root membrane therapies, all are the same name given by different individuals. The procedures are almost similar with slight changes. So you need to understand that when you are doing such procedures in which you are not completely extracting the tooth or the root part, is it beneficial, and what is the reason behind that, which we are going to discuss today. And next is the angulation. Position and angulation are almost the same, but angulation is very, very important in implantology because angulation would decide the amount of bone remaining around the implant. If we are waiting for osseointegration to take place, you need to be very, very clear that whether there is enough bone around the implant after it has been placed. And this you need to be clear not after placing the implant. You need to be clear on that before placing the implant. So there are cases in which there is very less amount of buccal bone available. So CBCT is going to help you and make you understand that if I extract this tooth, am I going to be left with any bone left? Even if there is some bone left, what would happen in cases in which I plan to put an implant on this patient after 6 to 8 months? So you need to keep that in mind. Now, so let us begin the game of implantology in a slightly different way, keeping the basics in mind, which is very, very important. You cannot ignore the basics. You need to keep the basics in mind, but you need to understand that any new thing needs to be, implemented in the patients as well. Now, let's begin with the fact that dental implants are a remarkable technology, but in the future, we will likely to see them become even more impressive. In additional technologies will be utilized to increase the speed, accuracy, and longevity of the procedure. Now, there is a difference between perception and reality. Now, if we see the perception, this is an ideal case which everybody would want for an implant. Good texture in the bone, okay, good amount of bone volume, good gingival contours, everything, you know, and good interdental papilla. So these are the ideal cases, but in reality, are you getting such kind of cases? Every case might not be that perfect. In reality, things might be different, like this, or in situations like this. So you need to understand that if there is a you need to foresee such situations in which if I extract the teeth and after 6 to 8 months if the patient is going to turn up with a situation like this, that then what I'm going to do? Yes, there are n number of procedures, okay, bone regeneration procedures, n number of grafts and anything can be used. But can those replace the ideal bone volume which was literally there before extracting? That is the main question which we all need to ask ourselves. So there's a difference between perception and reality which can be seen in this pic also. So certain studies to authenticate what I'm saying right now, which has shown like studies like dimensional ridge alterations following tooth extraction. It was an experimental study in dogs which concluded that the resorption of the buccal and lingual walls of the extraction site occurred in 2 overlapping phases. Most important, we are going to discuss the first phase. In phase 1, the bundle bone was resorbed and replaced with woven bone, and in phase 2 this included resorption that occurred from the outer surface of both bone walls. Now this was a landmark article. Another landmark article which was a systemic review of post-extraction alveolar hard and soft tissue dimensional changes in humans. It concluded the search provided 3954 titles and 238 abstracts, and it concluded that horizontal bone loss of 29 to 63% and vertical bone loss of 11 to 22% after 6 months following tooth extraction does take place. So this is the evidence-based dentistry which I was talking about. You need to be very clear on the evidence behind anything which we are planning to do. Then there are certain studies which are CBCT analysis, like ridge alterations post-extraction in the aesthetic zone, which was a correlation analysis, identified a facial bone loss, facial bone wall thickness of less than 1 mm as a critical factor associated with the extent of bone resorption. Thin wall phenotypes displayed and pronounced vertical bone resorption with a median bone loss of 7.5 mm. It is too much as compared to the situation in which the teeth is not extracted. So the question arises, why implantology without complete extraction is needed? Is it always preferable in immediate implantology to extract the teeth completely and then place the implant? If you ask me, no, never. But it depends from case to case. I wouldn't say that if you are planning a procedure, we are talking about a procedure today in which we are not completely extracting the tooth. We are partially keeping the tooth so that the aesthetics can be maintained. How the aesthetics are going to be maintained by partially extracting the teeth, I'm going to explain later on. But in nutshell, what we mean is we don't partially extract the teeth. We bisect the teeth from the center, from mesial to distal. We remove the palatal part and then we place the implant after making some implant bed which is favorable for the implant. Now situations could be such that you get situations in which the implants are not properly placed. Maybe they are placed at a different vertical level, maybe they are placed more buccally. So you get situations like this in which aesthetics are very much affected, in which you might get grayish tinge on the gingival margin or the whole gingival aspect. Then there might be situations in which the placements might be wrong and you might place the implant too much buccally, and then after all the dentist needs to improve those things even if it has been done by somebody else, because the patient has come to you for aesthetics. He's not bothered about the placement, he's bothered about the teeth. The teeth needs to be in perfect shape. But in such cases, if you are touching cases which has been done inadvertently by any colleague or something, you need to clearly explain to the patient that you are going to be, if any failure or anything happens in such cases because of improper placement of the implant, the responsibility would not be lying on you, because you are just trying to prosthetically rehabilitate the case and helping the patient. So in such cases, how do you rehabilitate? You need to make crowns which are bulky, which are vertically very enlarged, which aesthetically is not good, but at least it is better than not having a prosthesis in the first place. So this is the situation in which you try to rehabilitate such cases. Then over contour of the implant. So over-contouring of the implant provisional restoration as it emerges from the free gingival margin can result in apical migration of the soft tissues. If you over-contour, the prosthetic part is very, very important. So it's just a balancing act which happens between the prosthesis and the free gingival margin. The more bulkier the prosthesis, it is going to push the free gingival margin, and you would see that the recession keeps on taking place with time. So the tip is that the facial contour when you are giving the prosthesis should be flatter than the contralateral natural tooth to minimize the apical displacement of the free gingival margin after insertion. Now, then there are situations in which there might be palatal placement of the implant. In such cases also you need to give prostheses which are more buccally placed. So these are all not the correct ways of rehabilitating the teeth. These are just the ways in which you need to give a tooth because there has been an improper placement of the implant. Okay, maybe by a colleague, maybe by yourself, so you need to take care of those things. Now determinants of success are vertical bone height in interproximal areas and the horizontal thickness or the vertical height of the buccal bone wall in the edentulous site. Now this is the kind of results which you would like after the extraction or the partial extraction is done and the implant is placed. You would want to have aesthetics, so that if you ask any of your colleagues, if you ask any of the patient attendants, if you ask the patient, they would not be able to make out which is the tooth in which the implant has been placed and the prosthesis has been fabricated. Now there are n number of procedures which take place, okay, in which you need to, calculate the jumping distance, the distance between the gingival margin and the free gingival margin. Then you need to calculate the angulation, the placement. So the procedures are limitless. There is a long list of the procedures which can be placed after the complete extraction is done and the implant needs to be placed. But here we are talking of ways in which techniques which are little simpler but technique sensitive. Techniques in which the main time or the main purpose of doing it is to very, very patiently remove a part of the root, not completely remove it, and because placement of implant hardly takes around 10 to 15 minutes, okay? But the main thing which needs to be taken care in such cases is proper dissection of the root and disinfecting the area properly. Now, sometimes as clinicians we see that we are giving n number of options to the patients, that you can get this done, you can get prosthesis done in this ways, n number of things can be given or the options can be given, but as clinician we feel that the patients, we are making the patient very happy by giving him multiple options, but in reality the things are totally different. The patient might not take the options in the correct way, so you need to have clear-cut 1 to 2 options and you need to tell the pros and cons of these options so that the patient can make a decision on that. So what are we missing? The success, there are certain things which are keeping us away from the success, and those things are in our hands, but we just need to apply our mind and just incorporate those practices which we have learned, basics which we have learned. We should not forget that, but try to be innovative and try to do new things so that the patient, that can serve as a best treatment, because what we study since long in our BDS and our MDS, and we have those things in mind that this is the only treatment option which is available, but you should always try newer options with proper steps, with proper protocols, and then once you get results, that would help you in building up the confidence in such cases. So how to overcome this challenge is to be a dentist, not just a dentist, but to be a smart dentist, to do the same things in different ways. Now, great things happen when you get out of your comfort zone, so just try it. So, different names can be given to these techniques: root membrane implantology, partial extraction implantology, socket shield implantology. So, the main, the idea behind it is, Dr. Amit would agree to it, that loss of periodontium, that is tooth, periodontal ligament, dental papilla, supracrestal fibers, lamina dura, it affects the remaining gingival aesthetics, including the aesthetics around the dental implant. Are teeth and dental implants the same? So we need to understand that the bundle bone and the family of fibers that create the architecture of the dental papilla, they all belong to the tooth. So if the tooth is out, these all fibers are the ones which we are damaging. So once these are preserved, the blood supply is preserved, and so is the bone. So sometimes you get situations like this in which you get an extraction, you do an extraction, post 6 months, you get the picture on the lower left is the situation which the patient turns up with. And then you need to think on those procedures to get that bulk, to get that aesthetics back. So what's the bottom line? The bottom line is dimensional loss following extraction of tooth is independent of whether a flap is raised, an implant is placed, a bone graft is placed at the time of extraction. Ontogenically, the buccal plate and more specifically the bundle bone, it belongs to the tooth, and removal of the tooth will result in loss of the bundle bone and surface remodeling of the cortical plate to a certain extent. So the bottom line is the periodontium is already there. All the periodontists here would agree to it that it is already there, we just need to respect it before thinking of extracting the teeth completely. So in a way we need to change the rules, because everybody now, the kids today, in these days, are interested from the age of 1 to 2. They want to change everything. They want to do the things themselves. So why not us? We should also be confident enough to change the rules and do different things and incorporating newer technologies and newer techniques in our practices. So how are we going to change the rules of the game? So basically what we are doing is, as you can see in the picture, you can see in the pic on the left side, we are keeping a shield, a part of the tooth structure we are keeping intact. We are preparing the palatal part and then we are placing the implant. So by this, what is happening is on the buccal aspect, the fibers get undisturbed, the bone supply gets undisturbed, and ultimately the bone resorptions get reduced as compared to the resorption which takes place when we completely extract the teeth. So I'm going to share a few cases also on same. So different names: socket shield, pontic shield when you are preserving the pontic site, root submergence, proximal shields, all are babies of socket shield, partial extraction therapies, root membrane therapies. So coming on to changing the rules of the game, again we need to have evidence behind it. So classic article, a landmark article by Maurice Salama, he suggested a strategy to provide a more predictable protocol for aesthetic implant treatment for multiple tooth defects using the root submergence technique. And the article was named as the root submergence technique for pontic site development in aesthetic implant therapy. So he concluded that implants will never surpass the natural tooth's ability to preserve the surrounding bone and the soft tissue. And retention of the natural tooth allows for maximum preservation of the surrounding tissues and the bone. Now, coming on to the socket shield technique, it describes a technique of leaving a part of the tooth, that is the whole labial part of the root portion, okay, which is called as the sliver of the tooth root, attached to the buccal aspect to preserve the periodontium, as I said, which eventually preserves the bundle bone and which prevents its collapse. So this novel concept lies on the preservation of remaining root, which eventually preserves the PDL, which eventually preserves the buccal tissue, and which eventually preserves the facial soft tissue aesthetics remaining. But how does all this happen? Now, tooth loss leads to loss of periodontal ligament and vascular vessels associated. We are going to now see the sequence, what happens when the tooth loss takes place. Now, the vessels help to nourish the buccal plate, especially the thin buccal bone. This loss triggers the bone resorption mainly 4 to 6 months post extraction, and eventually loss of buccal bone plate leads to contraction of the overlying soft tissues, which ultimately leads to unaesthetic result. Now, the list is long. Now, what can you do? Guided bone regeneration and membranes, augmentation procedures with grafting materials, gingival grafts, dash, dash, dash. The list is long. There are many ways to preserve these things or to, rectify these things. But these techniques may limit or mask the unpleasant effects of bone resorption of the buccal bone plate, but none can completely eliminate the problem linked to and caused by extraction of the tooth. So, and we all should be accepting that fact now. So, again, classic article which said that intentional retention of the buccal root fragment prevents the osteoclastic remodeling and consequent resorption of the buccal plate. A common pattern seen in these studies is the formation of new cementum, and this theory is now changing, which I'm going to discuss later on the internal dentinal surface of the retained root fragment connected with mineralized tissue on the implant surface. Again, a step-by-step description of PDL-mediated ridge preservation was given by Mitzias and his associates. They had a 3-year follow-up of this technique in which a part of the tooth structure is left and the implant is placed along with it. So this was an old article in which there was a 3 years follow-up. Now we have a follow-up of up to more than 10 to 11 years also, even more than that, okay, which I'm going to share later on. But the 3 years follow-up revealed that the tissue stability was remarkable. 3 years follow-up means after the implant is placed along with a part of the tooth. Then gingival zenith was comparable to the neighboring natural tooth and papilla, and the natural tooth and papilla completely filled the interdental abrasures. Radiographically, the root fragment remained clearly visible intact with the implant. A major question, what happens to the root fragment? Then proximal bone levels were stable and no abnormal reactions were seen at the bone implant interface. Now, there have been a series of studies, even much more than these, and in the recent times, you have a recent study of 2022 also. Coming on to the case, a 22-year-old male patient with a chief concern of fractured teeth in the maxillary anterior region following trauma 2 months back. Now, as you can appreciate, once the history was taken, all the significant medical history and the dental history, we are going to discuss the dental history. The significant, there was nothing significant in the medical history. General examination, everything was all clear. Extraoral examination, facial symmetry, according to me, it looks quite good, but I need to ask Atreya what about the facial symmetry of this patient, because he's the perfect man to judge it. Now, so now, when we check the facial symmetry, as per the patient, he had gummy smile, okay, but he was a big fan of Akshay Kumar. He did not want to disturb that. He just wanted replacement of his lost tooth. Now, certain parameters which we check for facial symmetry, intraoral examination, you could see there was fractured 2-1, 1-2 due to trauma. Gingiva color was pale and pink, the contour was normal, consistency was firm and resilient, size was normal, the surface texture, in surface texture the stippling was present. Now there was localized gingivitis in relation to 1-1, 1-2, 2-1. Gingival zenith was, you can see the biotype, it was thin. The periodontal examination on probing, depth was more than 3 mm. Now, smile designing, there was certain things, but what was positive for us was that interpupillary line was parallel to the occlusal plane. From the prosthetic point of view, these are certain things which we need to rectify before we proceed for the case. Buccal corridor deficiency, filling up of the buccal corridors was needed, and this was to be done in the final phase. Now, general investigations, now CBCT is a very, very important investigation which needs to be carried out. Now, what you need to actually check is the analysis of the cross sections revealed a very thin buccal plate with a wide range, with a width ranging from 0.2 to 0.7 mm. Now you can see in such case that in such a case, when this is the thickness of the buccal bone plate left, now when you are going to plan to extract this teeth, what is going to be left? First of all, there is going to be some bone loss at the time of extraction. The buccal bony plate might get compressed. Once it gets compressed, you need to think of procedures how to, rectify it. Maybe at the time of surgery, or if not, then later on. Definitely at the time of surgery is the right time to rectify those things. But before even the surgery, if you plan for a technique like a socket shield or a partial extraction therapy, then it would always help in such cases. So this is the kind of defect which you would get post the extraction, and once you place the implant, you could hardly have any bone left buccally over it. So when we come on to the surgical procedure, implant site preparation, administration of local anesthesia, general surgical procedures followed, which you follow prior to any surgical procedure. A long shank burr is used. These days now you even have proper PET kits which can be easily used, which have all these kind of burrs, long shank burrs in sequence, which can be easily used, and it makes the work quite simpler. Then 2 indentations you make at the long axis. You take a long shank burr, insert it in the middle of the root, you take it on the mesial side, take it on the buccal side. You need to be sure that there's a complete sectioning till the apical portion, which you can always confirm with the help of your IOPs. The palatal fragment is then removed. You need to try to remove the palatal root fragment in one piece, and the buccal segment portion can be seen in situ. Next step is very important. You need to do sequential thinning of this buccal segment, because you need to understand that if you have a good 2 to 3 mm of buccal segment left and you are placing the implant palatal to it, so what you are doing is, then you need to make a prosthesis like I showed initially. That is placing the implant quite palatally. If you place the implant quite palatally, then there is a very difficult S-shaped curve or the emergence profile which you need to achieve. So there are going to be now two axes on which the implant is placed. Means the implant angulation is this and the prosthesis angulation is quite buccal to it. So you need to make sure that there has to be proper thinning of the buccal fragment or the buccal shield, so that if proper thinning is there, proper height is maintained, then you do not have to take the contour of the ceramic of the prosthesis too much buccally. Okay, so that needs to be taken care of. So this is how you sequentially contour it. You can use an instrument to take it away from the take away the gingival margin, and then you can use a flat tapered burr to sequentially thin the buccal fragment. Once that is done, you need to use your, now comes the regular implantology, conventional implantology procedure or sequentially drilling, using your drills in the sequential manner according to the implant size chosen. Now in this case, 3.75 by 11.5 mm tapered self-thread implant was used. Now the implant size would allow for the retention of the root fragment with approximately 1 to 1 mm of thickness. You need to take care that once you are drilling, you need to take care that the force of the bodily force of the drill needs to be on the palatal side, not on the buccal side, because in such a case you may dislodge the buccal fragment. But the beauty of this procedure is, if suppose you are during drilling the buccal fragment is dislodged, you always have a plan B in action. You can always do a regular immediate implant. If the buccal fragment is dislodged, just remove the buccal fragment and continue with your placement of implants. Now, a screw retained prosthesis was given. This was the IOPAs of the central and the lateral after placement of the after placement of the implant along with the shield. This was the pre-operative photograph. This was the post-operative photograph. You can easily appreciate the contours of the gingiva which have not been touched, the gingival contour, the zenith, the bulk of the gingiva which was there initially, okay, the keratinization which was present is there, which is very, very important for long-term longevity of the prosthesis. This is how the patient came to us, and this was the final outcome. As I said, he was a big fan of Akshay Kumar. He did not want to get the gummy smile corrected, so we left him as it is. Now, you can see the follow-up after 6 years and 4 months. Yes, initially we do call the patient once every year. We remove the prosthesis, we see if there is any internal inflammation to check if anything is required, if any rinsing with betadine or if any antibiotics need to be given, if he is not maintaining proper oral hygiene. That is the main concern. So these were the pics from the left and the right profiles. This is how, when we remove periodically after a yearly, we call the patient, we remove the prosthesis, see for any inflammations or anything, everything looked perfect. Coming on to the case 2, again a case in which the same technique was performed on a canine. You can see the labial half. In this labeling, you will be easily able to appreciate the procedure. This is the labial half, then the palatal half. Now, as you can see, this is the bisected line which we need to plan, imaginary line, before we plan for bisecting the root. Once the root is bisected, then you need to very, very carefully remove the palatal portion. Okay, there are certain tips which I am going to just make note of. I am going to explain it to you at the end of the session, which will help you, I would not say easily do the procedure, but which would help you in minimizing the mistakes which many people make during such surgeries. Now, once the palatal half is done, you remove the palatal half carefully, as can be appreciated in the pic. Once the palatal half is removed, you need to clean it, very, very important. You need to clean it and check whether it has come completely or there is still a apical portion, because most commonly what happens is your IOPA might show that your burr has reached the apical portion till the apical tip, but the burr might not be bisecting the center of the apical portion. It might have gone labially or buccally. That can be clearly made out by evaluating your palatal part of the root. Once you evaluate the palatal part, you can easily see whether the section has been made from the center or not. Okay, and then you can easily rectify it. If your section, while going to the apical portion, you have tilted the burr palatally, you would see that in the shield it is just you know, ending with just a thin shell. But if while sectioning your burr is on the buccal side, you would see that along with the palatal root, there's a part of the buccal part of the apex which has also come out, okay? And there's nothing to worry in that case. What is important is the sectioning needs to go till the apical part. After evaluating, then you need to evaluate the labial root section. What evaluation do you need? You need to take any instrument and check whether there is any movement buccally, lingually, apically, because if there is any movement in the buccal segment, then the only option which you need to do is to abort the procedure. You need to abort it and you need to do a conventional immediate implant procedure. But if it is intact, which you need to practice, why? Because as I said, I'm going to share a few tips which I have experienced personally while doing such cases. Then it would definitely help you out in minimizing these mistakes. Now then you evaluate, what all to evaluate? You need to evaluate the apicocoronal position, the mesiodistal direction and the labiopalatal. You need to just take an instrument, place it on the buccal shield and evaluate whether there is any movement or not. Now once the evaluation is done, then the shield is ready to undergo thinning and shaping. Thinning of the shield and shaping is now done. You need to make sure that you do not lose the crestal fibers which are there. So the thinning has to be 0.5 to 1 mm above the gingival margin in cases like this. And also the thickness shouldn't be more than 0.5 to 1 mm. As I explained, what is the role of the thickness? The more thicker you are going to keep the shield, the more palatally you need to place the implant. So you wouldn't be able to get that kind of aesthetics, because aesthetics is the main reason for which you are planning such techniques. Okay? So you are not going to compromise on that. Proper thinning of the shield is important. Now, if I ask you a question that when do you want to do the thinning? Whether you want to do the thinning before bisecting the root or you want to do the thinning after bisecting the root. Would anybody like to answer this? Would you like to thin the shield before bisecting the root or after bisecting the root? Anybody? It can be a wrong answer. So the tip here is always try to thin the buccal shield before bisecting the root. Because once you bisect it, what is going to happen is after bisecting, when you are going to thin it, okay, there are chances that the shield might rotate, you know, inside the socket. But once you have not bisected it, you know, you take the long shank burr, first do the thinning of the buccal shield and then bisect it. In that case, there is no undue pressure which you are going to apply on the buccal shield later on to thin it. So whatever pressure needs to be applied to thin the buccal shield, always do it prior to thinning. Once you apply the buccal, once you thin the buccal shield, then bisect it and take the root portion, palatal root portion out. But if you are going to do vice versa, which you may read in many of the articles, but practically if you see that if you bisect it, take the root portion out and then you start thinning the shield, practically you will see that there are chances that the shield might rotate 360 degrees into the socket itself. Okay? So that is one of the tips which would help a lot in such cases. Then you need to measure the shield properly. Once the measuring is done, then you need to follow the sequential steps of drilling sequence followed for a regular implant. So this is how once the shield was thinned, the implant placement was done. So you can see the natural apparatus, you can see the shield along, and then you can see the implant placed palatal to it. Prosthesis fabrication done. This was the post-op pics after the insertion and the IOPA post the insertion. Another case in which the same technique was done in the lateral incisors and the premolar region. Now I'm going to show some pics sequentially. The upper pics would, as you can see, first we're going to discuss the CBCT in such case. The CBCT, as you can see in such case, you can easily imagine once this root portion is extracted, so what are you going to left with? So you need to see these things before planning for complete extraction of the teeth. Now, the above pics show the sequential steps followed for lateral incisor, and the below pics show the sequential steps followed for second premolar. As you can see, first the evaluation done, sequential sectioning of the, in this case, we were able to remove the palatal part of the lateral root in pieces, which is absolutely fine. There's no issue with that, but always try to remove it in one piece, as we managed to remove it for the premolar. Once that is done, then you evaluate the site, evaluate the shield, check for its for any movements. If everything is perfect, then you just need to do the sequential drilling and place the implant as can be seen in the pics. Implant placed, prosthesis fabricated. After 1 week of prosthesis fabrication, after 1 week of prosthesis fabrication, you can always remove the prosthesis and check for any inflammation. Just 2 minutes. Again, in another case in which these were the initial cases which we started, just to see how it goes off, removed a part of the root, sequential drilling done, and the implant placed in central incisors. Again, the sequential steps, the same steps which are followed in the other cases. Now, are there any long-term studies? It is very important to have human studies in such cases. Yes, because human histology would never ever lie. So what does human histology study say in such cases? That it was seen that trabecular mature bone was seen at the interface of the implant, and the bone was present between the implant and the root. And the root membrane and the buccal plate appeared intact without any sign of resorption. Similarly, I'm going to share which article this is. It was also seen that there was compact bone in the medial thirds, and the apical portion of the implant were evident. Also, in the coronal portion between the root and the implant, connective tissue without any inflammatory infiltrate was present. And it was also seen in the apical portion, a part of the cementum migrated below the root portion between the root and the implant. So this was the article by a good friend, Mitzias, the root membrane technique, human histology evidence after 5 years of function. It happened that the same patient met an accident in which, because in such cases it is very difficult to do histological studies because you need to take a specimen out of it. But unfortunately, the patient underwent a facial trauma, and that portion needed to be extracted, and he came back to his doctor who had placed it, and this is how the article came into process and the studies were done on that same patient. A very good friend, that's the reason why I added one of the pic with him. So what to do if there is mobility? As I said, simply abort and do a conventional immediate implant. And if the implant fails to osseointegrate but socket shield is stable, again simple, just remove the implant and the site is closed, let it heal before re-evaluation as a pontic site. So advantages, it protects the bundle bone, most important. It is cost effective and acts as a guide. You get a natural guide for placement of the implant. And the interdental papilla is naturally preserved because we are not touching it. And limitations, it is technique sensitive, and risk of displacement of the root fragment is very, very important. Can we do it the digital way? Yes. Now you can always scan, digital surgical guides can be fabricated, and then you can easily place the implant accordingly. Now, this is how you plan it. You plan the position of the implant, and then you can always get good results even by digitally, virtually, placing the implant before planning for the surgical guide. Now, some small tips before concluding. First, sectioning. As I said, always section from the middle, and most importantly, before sectioning, go for thinning of the buccal shield and then plan for sectioning. Second, direction of the burr, always mesial and distal. That would always help. Never there should be any bodily pressure on the shield, buccally. Third, bodily pressure of the drill always on the palatal side, because if you keep it on the buccal side, it is going to get dislodged. Always prefer thinning of the shield before sectioning. The reason I have already shared with you all. Any questions are most welcome. So in the end, I would like to conclude that it seems to be an exciting technique for preserving the integrity of the buccal bone in immediate implant patients, but every technique comes with a learning curve and potential set of complications, but that doesn't mean that you should stop trying. Because the fact is, one who has bone has ample money, but one who has ample money, this is a very common thing in practice, has no bone. So what we need to do is, we need to just keep innovating and keep doing the same things in a different manner. So as the saying goes, that behind every successful man, there is a woman. But there can be some deviations also. Behind every successful woman there are men like these, okay? So we need to appreciate each man and woman also, but keep trying until you succeed. Because if this guy can succeed, the picture on the right, then I think anybody can succeed in this world, okay? Now thanks for your time, for your reference, some of my books, okay, for the reference of the students, book on prosthodontics for helping in NEET preparations. It is a comprehensive book on complete dentures with multiple choice questions, books on implant supported dentures, and we have recently launched the books on partial extraction therapy also. Some awards which always keep us motivating and keep us doing more and more, some awards on innovations. Then takeaways, evidence-based is the key. Trying new things is important, but always keep the basics in mind. Thanks for being a lovely audience. Namaskar. These are my details. I'm heading the Department of Dentistry. I'm the director of Signature Dental 32 multi-specialty dental clinics, and we are running our 2 centers, one in Miracles Mediclinic or Miracles Hospital in Sector 56, Gurugram, and in Apollo Spectra Hospital, Sector 82, Gurugram. Thank you so much for your time and for your patience. Thank you so much.
Thank you, sir, for your wonderful lecture. So this was Dr. Vishwas Bhatia, sir. He is Masters in Prosthodontics and Implantology, gold medalist, and sir has been practicing for the past 17 years. He is a diplomat World Congress of Oral Implantology, Japan. He has keen interest in implantology, maxillofacial prosthodontics, and designing innovative appliances. Many of the appliances are patented, and some of his innovations like handy stent, an appliance for specially abled people, and 3D printed movable hand has won accolades and awards at national and international conferences. Apart from his achievement, he has been awarded as an Excellence in Prosthodontics, Best Dental Researcher, Best Innovation in Dentistry, World Top 100 Dentist Awards by Global Summit, Las Vegas, and the Best Dental Center in NCR. Along with all this, he has been awarded Outstanding Dental Faculty Award by King Khalid University, Kingdom of Saudi Arabia, and these are a few of his achievements. He speaks extensively on partial extraction implantology and innovative prosthodontics at various conferences and conducts hands-on courses on the same topics. He was the organizing chairman of Global Outreach Innovation Dentistry Conference past year, which was one of its kind initiative focusing on new age innovations and entrepreneurs. He has authored 3 books on partial extraction therapies and complete dentures. Presently, he is running his 2 dental practices by the name of Signature Dental 32 in Apollo Spectra Hospitals, Gurugram, and Miracles Hospital, Gurugram. Thank you, sir, for your wonderful lecture. Now it's time to welcome the last guest speaker for the evening, and she is Dr. Divya Rathi ma'am. She has completed her bachelor's in dental surgery from Manipal College of Dental Sciences, Mangalore, and thereafter a stint as a junior resident doctor at the prestigious Maulana Azad Institute of Dental Sciences, New Delhi. She has started her journey into implantology in 2015 and have been awarded Fellowship of International Congress of Oral Implantology and Academy of Oral Implantology, and she has been into private practice since 2014 in New Delhi and have been actively involved in imparting education in implantology. Today, the topic on which ma'am is going to deliver the lecture is 10 golden tips for beginners in implantology. We welcome you, ma'am, and we are very delighted to have you here with us.
Thank you, thank you. It's okay, I think this is okay. So good evening, doctors, and as I believe we've already overshot the time for lectures, so I'm going to try and complete these 10 tips within 10 minutes. Please bear with me, I'm going to speed through them, right? So 2.70 lakh, that is the estimated number of dentists in India. Assuming half of them practice implantology, so there are about 1.35 lakh implantologists in India, right? So what sets you apart? The implantologist seated in this auditorium. That's right. As sir also mentioned, going back to the basics, being strong with your basics. Basics are the foundation for a successful implant practice, or for that matter, success in any field, right? So, going back to the basics, of course, what is implantology? Implantology is a prosthetic discipline with a surgical component. So, prosthetics and surgery go hand in hand, right? That is why treatment planning should always be done in reverse. Even before you pick up the drill, even before you give a final coat to the patient, you must know what your final treatment plan is. And for that, you can get surgical models of the patient, check the crown height spaces available, plan your prosthesis. Let's say for a 5 mm prosthetic height, you know you need a screw retained crown. Tell that to your patient initially, there is going to be an access hole. That is how you inform the patient in advance the number of implants that is going to be there, what kind of a prosthesis is going to be there, what is going to be the veneering material, right? Also, whilst your surgery is going on, you must check during the surgery where the access hole and the long axis of the prosthesis is going to be, right? So even for immediate implants, it must touch the functional cusp of the opposing arch, right? Coming down to tip number 2. I hope this is not too fast, but then we need to welcome the cultural guests here, right? So tip number 2 is correct 3D placement. The implants must be placed in the right 3D directions and orientation, which means they must not be too buccal or too lingual. If it's too buccal, this is what happens. Ye implant kisi kaam ka nahi hai. It is just going to lie there. You cannot give a prosthesis over it, and this just becomes a calendar implant. It's only good for calendar tongue now. So this is of no use, right? Do not do this for your surgeries. Make sure the implants are in the right position. They must not go into the socket, but should be drilled palatally, right? So, as you see, the osteotomy must be palatal to the socket, apex of the socket, right? Tip number 3, get the numbers right, right? So, it's a numbers game. These are the numbers associated with implantology. Distance between 2 implants must be about 3 mm, between tooth and implant should be about 2 mm, and this helps with the planning of these surgeries, right? So, 1, 2, 3, cha-cha-cha, right? Tough audience. So, you have a 15 mm space there. You know your numbers. You know eventually how you can get 2 implants or 4 mm there each. I'm sorry, I don't have time to explain this, right? So, numbers speak for themselves. They're not arbitrary. A lot of research and data has gone into developing these numbers. Must respect the numbers, right? So, tip number 4 is implant selection. Of course, बहुत सारे implants available है market में. How do you select what you want? What's right for you or your practice, right? Too many choices. So there's a small roadmap that you can utilize for this. These are the tips that you can use for selecting the implants you need for your practice, the make of the implant, the service of the implant, but most importantly, deal kya de rahe ho bhaiya, right? It's all about the moolah, right? So again, when selecting the implant out of the implant system that you have for your practice, make sure you try and get a wider implant than a longer implant. A wider implant increases osseointegration area by about 33%. A longer one, 1 mm increase, about a 10% increase there, right? Tip number 5, use sharp drills, stay sharp. थोड़ा मुश्किल हो गया अभी इतने long lecture के बाद staying sharp, but then never mind. A sharper drill will reduce heat generation at the interface of the drill and bone, thus reduce irreversible cellular damage, right? So better surgery is there. Also, you must replace your drills. Drills are not perennial. Ideally, they must be replaced every 30 to 35 osteotomies ke baad. Your companies will give you a better idea of when to replace the drills, right? And when we're talking about staying sharp, it's not just the drills, your instruments, the blades, everything needs to be sharp. Better tissue handling, right? Tip number 4, take radiographs at every step. They help you see what you cannot observe clinically. So do not be shy in taking radiographs. Take radiographs for all the osteotomies, implant placement, component placement, implant, prosthetics, every damn step, right? Tip number 7, now you're done with the implants. Saath mein kya aayega? Grafts, membranes, the other tools, army puri, right? So get the right biomaterials. The right biomaterials will help you develop better results. We have all of these kinds of grafts. We're just going to skim through these. And this is this case of a soft tissue and hard tissue defect, right? So you measure the defect, you place the implant, submerge the implant, and then what you see is grafting done here for the tissue defect and a membrane. And this is the final result. So when you open, there's no miracle there. It's all the right tools, right? So when you open, you get a good contour and you get a good surgery, good results, right? So tip number 8, use powder-free sterile gloves. It has been shown that powder in gloves eventually leads to delayed wound healing, leads to cross-contamination of the wound, and of course, latex allergies, right? So try and go powder-free in your practices. Then tip number 9, tie a floss and save your practice. Floss tie karna lawsuit bachane ke liye sabse aasan tarika hai. These are some of the radiographs of where patients have ingested implant components, implant drivers, implant drills, paralleling pins. We do not want to see these in our practices. So better safe than sorry. Tie a floss, or better use a throat pack or a gauze pack. And ye tohfa apne aap ko khud dijiye. Save your practice. Then tip number 10, finally learn when to say no. There are a lot of things other people can do better than you, better than me, better than all of us here. Let them handle it. Do what you're good at, do what your specialty is, do what's your expertise, and do not touch something which is way beyond the capability, right? So a strong foundation is the key to creating long-term success. This is my team and my mentor, the person who's been pushing me to be better at my foundation. And of course, that's me. And I think I've wrapped it up in 10 minutes. So I think we're good there. Thank you. Thank you for being a wonderful audience.
Thank you, ma'am, for the fast and wonderful lecture.
Thank you.
Before we move on to the award ceremony, I would like to invite Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir for the felicitation of Dr. Divya Rathi ma'am. And Dr. M. Siddharth sir as well. I would request Dr. Divya Rathi ma'am to please come on stage. Thank you, sir and ma'am. Now we'll proceed towards towards the ceremony. We'll start with the award ceremony. I would request everyone to please take their respective seats. A very good evening, ladies and gentlemen. Once again, this is Dr. Anam Siddiqui welcoming you all to this extravagant evening of the World Excellence Dentist Awards, recognizing and honoring dentistry and associated people. And this ceremony is initiated and organized by none other than CynoDent International and ISD. It is with the divine grace of Almighty that we have been able to come this far today. I congratulate Dr. Anmol Bagaria ma'am, CEO, CynoDent International and President, ISD. Along with Dr. Ashish Chandra sir, the co-director of CynoDent International and Vice President ISD for this grand success, we feel immensely honored to have amongst us the charismatic array of dignitaries. There is this age-old quote in English that all birds find shelter during the rain, but eagles avoid rain by flying above the clouds. So problems are common, but attitude is what makes the difference. Today, we all have gathered here to honor the exemplary and the very inspirational personalities of our dental fraternity who work day in and day out at the very ground level and have done some amazing work in the field. It is a proud moment not only for them, but for all of us who are present here as well, because these are the people taking our fraternity and profession forward and contributing in its excellence and beyond. As I said this afternoon, appreciation can change a day, even change a life. But your willingness to put it into words is all that's necessary. This award show is CynoDent's small initiative to acknowledge and honor the hard-working dental fraternity as a whole. We have various categories nominating dental students, clinicians, academicians, and of course the foundation stone of every dentist education, the dental colleges of India. Without further ado, may I please invite Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir on stage so that we proceed for the award ceremony. I would also like to welcome Dr. M. Siddharth sir on stage. What better than to start a ceremony with the blessings of our guiding light and the truest well-wishers. Now I would request my fellow, Misbah Kadri, to take over the mic and proceed with the award ceremony.
Now, award for the first category, that is Emerging Implantologist of the Year, and the award goes to Dr. Yashika Bali ma'am.
Congratulations, ma'am.
Now, award for the next category, that is Young Researcher of the Year, and the award goes to Dr. Mithilesh Narayan Mishra. Next category, Emerging Researcher of the Year, and the award goes to Dr. Prem Latha BR. Award for the next category, Implantologist of the Year, under 35 years, and the award goes to Dr. Divya Rathi ma'am. Congratulations, ma'am. Now, award for the next category. Best Emerging Laser Dentist of the Year, and the award goes to Dr. Swati Mahajan ma'am. Now the award for the Laser Dentist of the Year.
Congratulations, ma'am. Dr. Swati Mahajan ma'am as the Best Emerging Laser Dentist of the Year. Please give a round of applause for ma'am.
Now the award for the next category, that is Laser Dentist of the Year, and the award goes to Dr. Malika Sethi ma'am. Congratulations, ma'am. Now the award for the next category, that is Emerging Endodontics of the Year, and the award goes to Dr. Shashank Agrawal sir. Outstanding contribution to the field of dentistry, and the award goes to Dr. Pavitra Rastogi sir. And the next category, that is Oral and Maxillofacial Surgeon of the Year 2023, and the award goes to Dr. Atheri Rajgopal sir. Award for the next category, that is Dental Leadership Award.
So Athreya sir is here. Dr. Athreya Rajagopal sir for Oral and Maxillofacial Surgeon of the Year 2023.
Congratulations sir. Dental Leadership Award, and the award goes to Dr. Sumit Goyal sir. Now next category, that is Student of the Year BDS 3rd year, and the award goes to Ankit Lekra.
I would request students from Subharti Dental College to take award for Dr. Sumit Goyal sir. He has won Dental Leadership Award. Anyone from Subharti Dental College? Okay, we'll proceed on to the next category. Student of the Year. Okay, the next is Dental Talent of the Year UG, and the award goes to Dr. Nauman Sheikh.
Congratulations, Noman. Now, award for the next category, that is Emerging Researcher in the field of periodontology, and the award goes to Dr. Vinayak AM sir. Congratulations, sir. Now, award for the next category, that is Outstanding Researcher in the field of periodontology, and the award goes to Dr. Amit Bharadwaj sir.
Congratulations, sir. Emerging Prosthodontist of the Year, and the award goes to Dr. Harsimran Kaur ma'am.
Emerging Orthodontist of the Year, and the award goes to Dr. Chetali Parikh ma'am.
Please give a round of applause for all the awardees.
Congratulations, ma'am. Student of the Year, BDS first year, and the award goes to Paridhi Rastogi. Dental Student Leadership Award, UG, and the award goes to Dr. Sachin Rana.
Now, as Dr. Pavitra Rastogi sir is here, I would like to invite Dr. Pavitra Rastogi sir, and he has been awarded the outstanding contribution to the field of dentistry. Congratulations, sir. Dr. Pavitra Rastogi sir.
Now, award for the Student of the Year, BDS first year, and the award goes to Dr. Now award for the Practitioner of the Year, and the award goes to Dr. Vishwas Bhatia sir. Congratulations sir.
The next award is for the Outstanding International Dentist of the Year in the field of orthodontics, and the award goes to Dr. Rabindra M. Shresht sir. The next award is for the Outstanding International Dentist of the Year, Facial Aesthetics, and the award goes to Dr. Leena Shalel ma'am. Please give a round of applause for ma'am. Congratulations ma'am.
Now the award for the Outstanding International Dentist of the Year for Facial Aesthetics, and the award goes to Dr. Lamara Aaron ma'am. Congratulations ma'am.
Now, as the Emerging Endodontics of the Year, the award goes to Dr. Shashank Agarwal sir. Emerging Endodontics of the Year.
Congratulations sir. Now award for the Young Researcher of the Year, Dr. Mithilesh Narayan Mishra sir. Now the award for the Young Researcher of the Year, and the award goes to Dr. Mithilesh Narayan Mishra sir.
The Please give a round of applause for sir. Dr. Mithilesh Narayan Mishra sir. Now, the Outstanding International Dentist of the Year in the field of orthodontics goes to Dr. Rabindra M. Shresht sir. Congratulations sir. Outstanding International Dentist of the Year for the field of orthodontics.
Now award for the next category, that is Dental Talent of the Year, and the award goes to Dr. Malika Sethi Rishi ma'am.
Please give a round of applause for ma'am. She has won 2 awards today. Congratulations ma'am. Dr. Malika Sethi Rishi ma'am for the Dental Talent of the Year award.
PG Student of the Year, and the award goes to Dr. Anand Singh. Now we have next awardee, Emerging Periodontist of the Year 2023, and the award goes to Dr. Nitin Tomar.
Dr. Nitin Tomar, sir, for the Emerging Periodontist of the Year 2023. As sir is not here, we'll proceed to the next category. It is the Best Oral and Maxillofacial Radiologist of the Year 2023, and the award goes to Dr. Shalu Rai ma'am. Again, the next category.
Now, Best Dental College in Promoting Scientific Research, and the award goes to School of Dental Sciences, Sharda University.
Best Dental College in Promoting Scientific Research goes to School of Dental Sciences, Sharda University. I would request all the people who are present here from Sharda University to please come on stage and collect your award. Congratulations, Sharda University. School of Dental Sciences, Sharda University is the best dental college in promoting scientific research. Now, the next category is for the best
Now, the award for the Best Oral and Maxillofacial Surgeon of the Year. Now, the award for the Emerging Oral and Maxillofacial Surgeon of the Year, and the award goes to Dr. Rohit Sharma, sir.
Dr. Rohit Sharma, sir, for the Emerging Oral and Maxillofacial Surgeon.
Congratulations, sir. Now the award for the Student of the Year, BDS Final Year, and the award goes to Dr. Devansh.
Proceeding to the next category. Dr. Devansh, Best Student of the Year, 4th Year BDS. Please give a round of applause.
Now the award for the Student of the Year, BDS First Year, and the award goes to Paridhi Rastogi. Congratulations, Paridhi.
Paridhi Rastogi for the Student of the Year, BDS First Year. Congratulations, Paridhi.
Now the award for the Best Dental College in Community Services, and the award goes to Subharti Dental College.
Best Dental College in Community Service, Subharti Dental College. I would request all the Subhartians to come on stage and collect your award. I would request Dr. Vishwas, sir, to join them on stage, please.
Best Dental College in Community Services, Subhati Dental College.
The next award goes to Manav Rachna Center of Dental Excellence, and the award is given for promoting advanced dentistry program. Manav Rachna Center of Dental Excellence, and the category is for promoting advanced dentistry program.